experience in practice. Before we begin, may I request you all to please put your mobile phones on silent mode. It's my pleasure to invite and welcome the chairpersons for the first session, Dr. Manish Chandra, who's a senior consultant radiation oncologist at Jupiter Hospital, Mumbai, Dr. Vijay Patil, who's a consultant medical oncologist from Mumbai, Dr. Pavan Raj Chalise, who is an associate professor and head of the department, Urology and Kidney Transplant Surgery Department, Nepal. I request the chairpersons to be seated in the front row of the audience. And before I hand over the session to the chairpersons, I request you all to please be strict with the time management of the sessions, as it's easy to get carried away. My apologies in advance for interruptions if I have to, in order to have a timely conduction of the meeting. I invite our first moderator, Dr. Anand Raja, who is a professor, Surgical Oncology, Cancer Institute, Adyar, Chennai. He will lead a case-based discussion on penile cancer. I also invite the panelist, Dr. Srivatsan Ramani, who is a consultant urology and uro-oncology and robotic surgery from Polo Rotan Cancer Center, Chennai, Dr. Anil Kumar, who is Director and Head Department of Uro-Oncology from Zymus Hospital, Bengaluru, Dr. Tanwar Shahid, who is a consultant radiation oncologist from Apollo Multispeciality Hospital, Kolkata, Dr. Amit Joshi, Professor Medical Oncology, Tata Memorial Hospital, Mumbai, and Dr. Francis James, who is a professor and head of the department, Radiation Oncology, Regional Cancer Center, Trivandrum.
So without much further ado, I think in the spirit of keeping time, I think we are 8:29 and I take the liberty of starting 1 minute earlier. So let's quickly rush into the case. So this is a patient for a carcinoma penis. We again don't have to introduce the star-studded panel. I mean, everyone here is a rock star, so everyone knows everyone. So let's not waste time introducing everyone and talking about the credentials which are already very well known. So here is a 30-year-old gentleman who was a hypertensive without any history of multiple sexual partners, had a penile growth of 3 months duration. On clinical exam showed there was a 3 × 2 centimeter ulcerative growth over the glans penis. The meatus was well made out. There were no palpable inguinal nodes. Clinical examination also included a small nodule palpable in the perineum over the spongiosa for about 0.5 to 0.5 centimeters. It was quite firm. So what are the next steps? Dr. Anil, patient has come to you here. What are the next steps?
So with this information, clinical examination is enough to know the primary.
Okay.
And for the small nodule, I want to stage or find out whether it's a skip lesion or something. I want a MRI or ultrasound if MRI is not available to see what the nodule is.
So if you have to categorize the evaluation for these lesions, Dr. Srivatsan, how would you categorize it? I mean, would you like to have a biopsy, local staging, regional staging? How would you categorize evaluation and investigations? I have all the investigations put up in the next slide, so I don't want to go there.
So I think there'll be a local investigation for the local lesion and for the loco-regional, basically whether nodal as what was skip lesion that could be there, and obviously a metastatic lesion. Metastatic would be the last if you're suspicious of so. So I think for this patient, obviously as you said, a biopsy is an essential part of the diagnosis. There is there are no nodes palpable. Probably a screening of the ultrasound of the groin would be a part of the workup for the loco-regional, and this is something which is unique, a small nodule over the perineum, which you don't usually see. So probably I would do, like Sir said, I would do an imaging local for this, either ultrasound, preferably an MRI to find out exactly what's happening in the urethra.
So we have, for local, we have a biopsy. For regional, we have an ultrasound that Srivatsan had said. For, for that nodule, we have an MRI that Dr. Amit had said. And do you also want to do anything else apart from the ultrasound of the groin? And do you also want to do an ultrasound of the abdomen, pelvis, or an X-ray chest? Or would you do that later on?
So chest X-ray is a part of a metastatic workup, but again, nowadays chest X-ray is basically not very, I mean, you don't usually decide, especially in India, you can find a small nodule. So I think a CT chest is the basic minimum for screening. But without knowing the characteristics of the tumor, probably I will do that first and then probably think about...
So the wedge biopsy versus squamous cell carcinoma grade 2. So we, the protocol that we follow at our place is that we always do an ultrasound of the groin, because a clinically N0 node does not mean that there's a pathological N0 node. You can do an ultrasound and a guided FNAC from the nodes. If the nodes turns out to be positive, you already know that it's a metastatic node, and the patient will go on for a therapeutic inguinal lymphadenectomy at the same time. On the other hand, if the FNACs are negative, it is still a CN0 groin, and in a CN0 groin, the patient will go for staging inguinal lymphadenectomy, whether you do a sentinel node or a superficial block or whatever it is, and then take a call whether the regional nodal basin is involved or not, and then take further call based on that. So the ultrasound of the inguinal region showed near centimetric nodes with intact fatty hilum. FNAC was only reactive lymphadenitis. We also did an ultrasound of the abdomen. At a high volume center, you know, the diagnosis, the horse is first, the cart is always behind. The diagnosis is first, the staging is always later on. But in a busy center, it's always difficult to go and do an ultrasound of the regional nodal basin, stage it or not, and then go and do a second, ultrasound of the abdomen to stage it. So we take the advantage of, patient is already going to the ultrasound scan room. So we always image the abdomen and pelvis, make sure there are no retroperitoneal nodes, liver metastasis.
The same with the CT as well, sir.
Yeah.
CT
So, but the CT is not indicated here right now.
I am not talking about guidelines here.
The CT is not indicated right now because it is still technically a CN0 groin. So as was already very well said, so the MRI was already done, and as you can see here, there is really nothing. The tumor is seen there, involving almost the proximal part of the shaft, and then the nodule which is palpable in the perineum would have been somewhere here. I'm only showing you representative images. The MRI was completely normal. The nodule that was supposed to be palpable was not palpable, and the inguinal regional nodal basin, as you can see, is completely clear. There's nothing too much there to talk about. So it's a clinical stage T2N0 that we've come about for this patient. So what are the next steps? This patient would typically be with either Dr. Amit or Srivatsan. So what next?
Sir, in this case, depending on the MRI image and also its size of the primary is 3 centimeter, there won't be.
So there was a nodule in the perineum.
There was a nodule in the perineum.
Clinical exam showed that there was a nodule when we examined the penis. There was a growth in the penis, but we also always examine the perineum, the urethra there. There was a 0.5 into 0.5 centimeter nodule which was present over the corpora there.
Why not do FNAC or something of the nodule then? Biopsy.
So the advantage of being a moderator is I can ask the questions.
You are ignoring the nodule. In that case, MRI is not needed.
FNAC sometimes can miss.
I would rather go for a biopsy of the nodule.
Or whenever you are dealing with primary, you can either biopsy the nodule on table and send for a frozen section and then take a call from there.
Anand, just to clarify, for a clinically T2N0 penile cancer, would you recommend an MRI? Would the panel recommend an MRI? I mean, that's all we are trying to ask, because we generally don't do it.
Exactly.
So we probably, if there is a nodule, was it seen on the MR? Did it help?
No, the MRI was not shown up. So that's why I said it was a 0.5 to 0.5 centimeter nodule on the cavernosa. It looked like more like a cavernosal calcification on clinical examination. That's why we got an MRI done. On the MRI, it was pretty clear and it was very, very small, 0.5 into 0.5.
Bottom line is you don't need an MR unless,
there was a special situation. That's why we did that.
Thank you.
And it looked more like a cavernosal calcification there.
Would you do an ultrasound at least?
What? Groin?
For that. No, not the groin, sir.
No.
For that nodule.
I would biopsy it. If it's suspicious, I would biopsy it.
Fair enough, sir.
On clinical exam, it looked like a cavernosal calcification. So because it looked like a calcification, and it was negative on the MR, we ignored it. We didn't do, pardon? MRI, that's what we got an MRI done, and the MRI was negative. I mean, it didn't show up. So we didn't further FNAC it or biopsy it because, I mean, clinically it was not very suspicious. So what next? The patient has come to you for treatment. Staging investigations are done. It's a CT2, N0, M0. What next? Dr. James and Dr. Tanveer, both of you have been very quiet. Would you want to consider this patient for surgery, or would you want to consider for penile conservation surgeries? The image for the penis is I've already shown here. It's quite a large progressive fungating tumor here. Would these patients be candidates for penile conservation?
So these are the candidates where we should think of a conservative surgery, no doubt about it. I mean, we have to conserve the penis in this kind of patients, and accordingly we should be planning. I mean, so we'll be discussing in the MDT, and after that, along with the surgeons, we'll take a call.
Such large volume tumor which have ulceration, fungation, and which is also having a little bit of discharge from the from the tumor. Such large tumor you will consider for penile conservation? Or would that be more for smaller lesions, flattish lesions, small ulcerations? Would those be the ideal? So in your opinion, what would be the ideal candidate for a penile conservation? The characteristics of the primary that would be the ideal candidate for penile conservation?
So it's basically, I mean, T1 lesions or less than that, so that will be better. Size is definitely less than 2 centimeters, that will be even better. So size-wise criteria, if you see the smaller the lesion, the better it will be. It's like a very, I mean.
So this lesion, would you consider or you will not consider? Dr. James is also there, got vast experience in penile cancers.
I'll consider for lesions less than 3 centimeters where the control is very good. Our brachytherapy results, 75% of them get control if it is T1. So when the lesions become quite bigger, the control rate drops down. And especially for such bulky disease, I'm not keen to consider.
Francis, you mentioned about external beam radiotherapy. You're still doing EBRT for slightly larger tumors?
Some
those who may or may
something
not
like 3 centimeters and all, we consider external beam radiation, which can be easily given.
How do you do it?
For giving radiotherapy, you'll have to keep the penis inside a box. We do with
wax mold, wax box. Yeah.
Which 2 pieces are joined together and the penis is inside that, and then we can give external beam radiation. So the tissue is treated through and through, and no dose come to the body because it's this standing straight.
Right, so the patient has come to you, non-metastatic disease, large volume tumor. It's a very small penis, so although the tumor appears to be involving only the glands, there really is no space with margins to go and do a partial amputation. So this patient is a candidate for total amputation, and that's what he went. So how will you stage the groin, Dr. Srivatsan? We have facilities for sentinel nodes, so we keep doing it left, right, and center. But in this patient, what would be your policy, Dr. Srivatsan and then Dr. Amit, for staging of the regional nodal basin? Would you do it at the same time? Would you do it as a staged procedure based on the stratification? Would you do a sentinel node? Would you do an SIBD? Like, what would be your thoughts on this?
So in a clinically N0, I think dynamic sentinel node is one of the best way to do it, but sadly I don't have the facility, so I do a stage process where I see the biopsy of the penile growth, and if it is high risk stratification, go in for a superficial liporectomy, send it for a Frosel, and they decide what to do.
Dr. Amit, would that be your process as well?
I agree with that. Depending on the characteristics of the primary, depending on the risk factors, if you don't have a facility for DSNB, better if the patient is not able to go to a center where DSNB is available, we can do a staging.
So our thoughts on this are slightly different. Low risk in the EUA certification means low. Low does not mean zero. The reason why people, according to the EUA risk stratification, don't stage the groin in a low risk is not because that the possibility of finding nodal metastasis is not there. It is just that the morbidity of the surgery, which is by way of superficial block dissection and the attendant lymphedema, would be so high that the risk of finding metastasis would be to the tune of 2 to 3%. But you will stage everybody means you might potentially give morbidity to about 95 to 97% of the or 100% of the people. 95% of them won't benefit from it. The morbidity would be higher. The risk of finding a metastasis would be lower. That's why they don't do it. But the dynamic sentinel, it is a no-brainer. The morbidity from that really is close to zero. So that's why we do the sentinel node irrespective of staging. Unpublished data from our own institute for about 300 patients and 550 groins shows that as per EUA low risk stratification, even in the EUA low risk, our own center data shows that the risk of nodal metastasis is 5.5%. So that's quite significant. Yeah, please, sir.
Yeah. I think, do we have information on the degree of differentiation of the primary biopsy?
Not yet.
So it was a grade 2.
Not yet.
Squamous cell carcinoma grade 2.
Do we have
Initial
any
grade.
information on the depth of invasion? I know
No.
just for a biopsy, we don't, probably in the main specimen we'll have it. The trouble is, in India, you have to look at the ground realities. Many of these patients, like T2, they come in an advanced stage. Many times, the sentinel lymph node biopsy, it may be negative, but still you will have an occult metastasis in the inguinal lymph nodes. Because the dynamics of sentinel lymph node, what we talk about, see, India, people would have sort of barefooted walking, infections, so many other causes for that. I personally feel that yes, people do have, ideally you would like to sort of prove that there is a metastasis or no, because there is a complications, lymphedema, everything about lymph node dissection. But I think these people have one good chance of getting better. And if we have all adverse characteristics, T2, I think prophylactic lymph node dissection in large bulky disease, especially these kind of patients, I think probably would be the ideal thing to do.
I think Dr. Markand has hit the nail on the head, and I think he has just put it very, very brilliantly. So this is what I keep saying in here and in other forum as well. The dynamic sentinel node is not for the faint-hearted. It is not for everybody. One, standardization and technique and doing all that takes a lot of time. It took us 2-3 years to develop the technique, standardize it, reproduce it. Again, and these patients should be motivated to come for follow-up. Follow-up is very intense, monthly for the first year, second monthly for the second year. So if the patient is not going to be compliant on follow-up or is not willing for follow-up, this procedure is definitely not for them. Those patients will be better served by doing a superficial block
Also,
dissection.
high volume centers.
Yeah, sure. So we've spoken about the SLNB, SIBD. So now you have to do, the staging inguinal lymphadenectomy, DSLNB. So any special consent would you take before the total amputation of penis? Now that you have done the superficial block or the sentinel node, would you send it for frozen section? You would not send it for frozen section? Your thoughts, Dr. Srivatsan and Dr. Amit?
So special concern probably for a perineal urethrostomy since total amputation, and possibly that resection of the nodule there, and that will be sent again for a frozen. Always the superficial inguinal nodes in my center goes for a frozen to make sure that we have one, is it positive or negative, which will decide the future course of treatment in the same setting.
Would you want to wait for the final pathology and do it as a staged procedure?
No, sir.
Would you're a big proponent of robotic surgery here. Would you like to do a robotic veil here at the same time as doing the penectomy?
So as I said, I always do the staged procedure. So I do the penectomy first and then...
It comes out as high risk.
High risk, then I would, if it is a clinically N0 and image-wise N0, I will suggest a wheel procedure is not a bad idea.
So what are the any disadvantages of veil that you could think of if you are doing a robotic veil here?
So the only problem with veil is that we do generally both the deep as well as the superficial lymph nodes. We generally do not do only the superficial, and they'll go on to progressively. So that could be a slight, I wouldn't say slight, increased morbidity due to over treatment generally. So
Perfect.
in a general case, probably this guy would have got away with a superficial inguinal lymph node decompression, would probably have an increased risk of morbidity.
Exactly. So if you do a robotic veil, in most instances, it ends up as being an over treatment for the high risk, because they would have needed only a superficial block dissection, but most of them end up doing superficial and deep inguinal lymphadenectomies. Dr. Sudhir is here. Is it possible to do only a superficial block dissection with the robotic veil? And I know you've published, you presented a paper on this also, so that's why I'm asking this question here.
We have a maximum series of
yes.
this thing, and it's not that you can't do superficial block dissection with the robotic veil. Only thing you'll end up in having more time. Because you remove the superficial, then you go on other side, then you come here. So that is why for convenience you do that thing. And there is hardly any increase on morbidity, especially if you are saving the saphenous vein. Only problem with the robotic veil is lymphoria.
Yes, sir.
And this is with open also. And in open we have tried everything, clipping, ligating, all the lymphatics, even then it occurs. So we are working on something, it may actually sort out some problem about this.
So we published a randomized control trial on clipping of the lymphatics after the open inguinal lymphadenectomy. What we do is inject methylene blue all around the incision, and wherever the open tips of the, wherever you can see the open lymphatics there, which, where the lymphatic ooze is there, with a surgical clip, we go and clip off, although the 200 clip, we clip it off. So we did a randomized control trial, 20 patients on either arm, and then we found out that the total lymphoria and the number of days that the drain is in situ for the clipped versus the non-clipped was highly significant, was far lower for the clipped versus the non-clipped. The lymphoria was also far less for the clipped versus the non-clipped.
Anyway, drain output, sir? Drain output also? Sir?
Drain output was lower. The number of drains, days that the drain was in situ, and the total lymphedema for the lymph. The final lymphedema was also different. We've also had some patient where one side we've clipped, one side we've not clipped. You know, that's the way the randomization came in.
How much the difference between days? On
what was the
3 days, 2.5 days.
When you clipped?
We clipped, it was lower by 2.5 days.
The approximate number
the
of days?
lymphedema was also lower in the clipped versus the non-clipped.
What was the approximate number of days used to keep the drain in clipped cases?
I don't exactly remember. I'll pass on the paper to you.
Dr. Sudhir, sir, how many?
I'm not sure. I know your question, and you're asking how is it that the final lymphedema was lower? It should technically not be lower, but it was. So we did not publish the results because the trial only looked at the number of lymphoria and the number of drains that the drain was in situ. But we've looked at the final lymphedema of both the limbs after surgery.
1 year, I think you have to wait 1 year.
Sir, we've already published this paper about 2 years back. The lymphedema was not part of the study. We've looked at the lymphedema later on. We are going to publish it now. We've collected the data. The final lymphedema is lower for the clipped arm. I don't have a reason to explain why it is, but it is. Maybe. So going on. So the on-table plan, what we did is the total, the frozen sections, these are the biopsy reports. The frozen section from both inguinal regions came out as positive. The nodule at the cut end of the urethra shows tumor. On-table plan. Dr. Shivatsan.
I would proceed with the complete urethrectomy with corpectomy, which is there. Radical penectomy.
So will you do only, Dr. James, would you like to differ? Now you already know there is some nodule in the urethra, so on and so forth. Would you tell Shivatsan just do the inguinal block lymphadenectomy and leave it at that nodule which is positive in the urethra that can come positive later on also? So I might as well just radiate the entire area at risk.
I think we started.
It's a skip metastasis in the urethra.
We started with T2, now we have gone very.
This is a real case. There is nothing that is surrogate in this.
So we have gone to very higher stages, so it has to be very aggressively treated. And I understand that surgical treatment is a good way to deal with it. And then maximal aggressive approach with chemotherapy and radiation.
So I think we got very lucky here. The plan was we had completely disregarded the nodule in the urethra, except that we have to send it for a frozen section here. And we were in general discussing in the ward that, you know, where if it comes positive, we have to do a total prostatourethrectomy, so on and so forth. After the nodule came positive, and I was just sitting there, dumbstruck as to, you know, I have not taken consent for this, and my postgraduate comes up and says, oh sir, you were talking about all of these things, so I have already counseled them, I have done everything, and that sits on paper here, we've already taken a consent for the prostatourethrectomy. So we got very lucky with our postgraduate here.
Would you think of a scopy at this point of time, sir? Would you do a urethroscopy?
The MRI was already done. I mean, the MRI only showed you the representative images, but the MRI was already done for the pelvis and nothing was there. So that was already seen prior. So what we did is this. Sir wanted to say something, I think.
No, this after prostatourethrectomy, what did you do for diversion?
So we just put in an SPC. We closed the bladder neck and then we just did a final an SPC, a permanent SPC.
I think the option is not to do the SPC. You can go for metrophenol.
Yeah,
you can
could
put
have been
appendix,
done.
or you can take a bladder wall, or you can go for
continent diversion could have been done.
Yachias,
I agree. That would have been a very viable option at that point in time. So again, now the biopsy is there is sentinel nodes have been done. 4 nodes have been sent for biopsy. On either side, 1 node is positive. Would you want to do only the inguinal lymphadenectomy, or would you like to do the ilioinguinal lymphadenectomy and then what else, what not?
The ideal would be to do a deeper node and then send it for frozen again to think. But considering the fact that this is probably a T4, probably I'll think about an iliac as well.
Yeah, so what we did is we did an ilioinguinal lymphadenectomy. That's what we end up doing most of the times, because as per recommendations, it should be more than 2 nodes or any perinodal spread. Then you have to go back and do the iliac lymphadenectomy, which is again a secondary procedure. Here we have already opened the pelvis. The pelvis is right there. There is very little option to go back again inside again. So we have done the ilioinguinal block lymphadenectomy.
So I have a question. I mean, so the way the stage is being changed now, and the disease, the way it has come out to be, the lymph nodes, bilateral inguinal lymph nodes are positive. still will you be...
the biopsy is there.
No, so reconsidering your, like we started all the treatment with just with a chest X-ray. So would you like to again go for some other imaging, because just chest X-ray and ultrasound, will that be enough?
So
or you want to go
in
for a
our
CT
own
scan
experience,
now?
we've done a fair bit of penile cancers. So in the absence of gross retroperitoneal nodes or gross pelvic nodes or multiple pelvic nodes, the X-ray chest, until and unless you see something else there, is sufficient most of the time. We've reviewed our data for about 1,000 patients on penile cancer, node positive about 700. Very, very few patients have had chest X-ray normal and then have had some other lesion. Only in the presence of bulky inguinal nodes or retroperitoneal nodes would there be an increased risk of pulmonary metastasis. But that having been said, I agree with you, that would have been a good investigation to have. Outside of an institutional practice, a CT chest would have been a very good investigation to do.
I think we should go for a CT chest. And I mean,
in a clinically node negative, the role to do a CT chest would be a little remote. Anyway, going further, we have, I have a very strict timekeeper
How about
here.
a PET CT? Would a PET CT would have...
Sir, a PET CT scan for a penile cancer, the role is more investigational until and unless there is a suspicious nodule or suspicious sites elsewhere. The role for either a primary staging or metastatic staging in the upfront setting, the data is very limited. Dr. Sudhir has some role.
Early CA penis, it overstages. It's actually fallacious.
Exactly.
You will see the node positive on PET CT. When you operate them, they are negative.
Exactly. So
But
it doesn't
in
help either in
advanced
staging of the
definitely
primary or the met. So that was the biopsy report now. 6 of 39 nodes were positive. Perinodal spread was seen. One pelvic node was also positive now. One pelvic node on either side with perinodal spread. So 2 inguinal nodes on either side and 1 pelvic node on either side with perinodal spread. Dr. Amit, he's been quiet for a very long time now. Now we've done our part, everything else. Now the patient comes to you. Patient is being discussed in an MDT. Dr. Amit is here and Dr. James is here. Dr. Tanveer is also here. The plan for adjuvant therapy for this patient.
Before that, one question which comes in my mind, that the probability of being a retroperitoneal node, have we done a CT abdomen pelvis?
The MRI included, because we got an MRI done, we also got an MRI of the upper abdomen done. The retroperitoneum was clean. In fact, pelvic nodes are also very small, 1 centimeter nodes.
So if we are assuming that there is as no metastatic disease,
we are not assuming, we know that there is no metastatic disease.
But it's a disease which will come back in 1 year, 1.5 years, that I am sure. Seeing
So
CA penis patient.
So that's why you are there. Two inguinal nodes on either side. So 4 inguinal nodes and 1 pelvic node on either side with perinodal spread.
So what we practice in our adjuvant chemotherapy with the tip-based chemotherapy adjuvant for 4 cycle, and we also consider doing CT-RT post-chemotherapy. So that's a little bit over approach, but I feel that in CA penis, first chance is the best chance, because when the disease recurs, it recurs. So adjuvant chemo followed by adjuvant CT-RT.
Chemo followed by CT-RT. So
some cases we are doing, I think that's a little bit over and above, but what we have felt that adjuvant chemo definitely, that is the standard of care, and then we give CT-RT in
So
few
what
cases.
really is the role for adjuvant RT today, Dr. James? What do the guidelines recommend and what is it that we practice here?
When there are multiple nodes, extra capsular extension, pelvic node involvement, these are all very high risk features which says that they are quite likely to occur, and we give radiation to such patients. Vedang has published
Dr. Vedang will now scream at me if I tell this, but if you look at all the recommendations that are published, there is a role for adjuvant chemotherapy, but all recommendations, whether it is the EUA or the ESMPO or the AUA guidelines, all of the guidelines say that as of date, the role for adjuvant radiation in penile cancer is not there outside of a clinical trial. That is what are the recommendations. But having said that, I know Dr. Vedang has something to say.
2023, they came to their senses and they have said that adjuvant radiotherapy has a role now. EAU.
So
yes, it is Dr. Raval's paper. They refused to include our
So would you
paper
like
in
to
that,
incorporate chemotherapy first, radiation first, or chemoradiotherapy first together?
What we published a couple of years back is we looked at all our, I think, 125 patients for PN3. This is only PN3, mainly either pelvic node or ENE. And we found that intensification of treatment was the best. If you give, some patients got adjuvant RT alone, some got chemo alone, some got CT-RT. All the outcomes were similar if you didn't intensify with adjuvant chemo followed by CTRT. Small numbers, maybe some biases, maybe they were fitter patients, but they did the best, and that's what we tried
So
to
RT,
do.
what would be the field of RT that you would give? You would give to both the groins, both the pelvis, both the groin and the pelvis.
I think,
and Dr. Shivatsan, you've operated on this patient. What would be your concerns?
Wound concerns and lymphedema concerns and all those things. Plus,
I think they know it.
With IMRT these days, the toxicity is considerably less compared to the olden days.
So first, what would be your field of radiation? Is it only the inguinal, or is it the iliac, or is it the ileal and
inguinal and iliac? Inguinal extended field RT.
We looked at this very recently. In one line, if there is a single node positive in one groin, we should include extended field. So we include the pelvis and other groin as well.
And if the pelvic node is positive, do you go one station higher?
No, no. Then Amit Joshi's prediction is going to come true.
So they have published the
I saw that.
radiation guidelines actually, the landmarks and everything field actually. And हमारा जो data था TMH का, in that the intensification group of patients was the one which survived maximum. The others who received single adjuvant, they died actually earlier. So that's important for everybody.
I think the bottom line is what Amit is also saying, we are all saying, there's only one chance. You do as much as you can safely, there's only one chance the patient has got.
Fine, I think we are completely out of time. I had one more case. I think I overestimated my time.
Last 1 minute.
So I'm not going to my next slide. I am going to skip my entire second case and I am going to just go for, so this was supposed to be a spotter. I thought we can have 2 cases and then 1 spotter. So this is the spotter. Dr. Markan, you had something to say.
Yeah.
So before we go to the spotter.
Yeah, I think the point here, I think everybody has to take that message and it is loud and clear. The large volume centers which deal with penile cancer, I think now we're trying to give a guidelines like this. If you are going to do sort of extensive lymph node dissection, and if you find sort of one sort of single lymph node positive on one side, possibly I think these patients either can be observed or these patients can be given a consolidated treatment, as Vedang is saying. There's one good chance of getting better. You can, not do radiation on the opposite groins. If you've done ilioinguinal on the opposite side, there is nothing there. Probably you can spare that groin. So the morbidity is quite less. But if you want to consolidate the treatment, I think CT-RT is important because these the patients do extremely well. And I think we all centers in India who do large volume of CAPNE should come together, and then come out with these kind of guidelines because these patients are messed up.
There is one international study, I think Tata is going to become part of the impact study. That will give the answer of this sequencing, and that has all 3 questions. I think TMH is going to be part of that study.
One observation which I have throughout the case and which is baffling to me, his primary disease is only grade 2, which so much of
which is very unlikely. I agree.
I mean, exactly. I mean, grade 2.
Yeah, which is one of those cases.
Exactly.
So last question, just a spotter. So this is just one opinion from everyone. We are not going to discuss this in detail. One spotter. So I put them on an exam spot. They are going to say, and then I'm going to tell my impressions about it, and we'll close. So this is a patient who is a middle-aged gentleman with small inguinal nodes, large bilateral inguinal nodes. What would you do for this patient? Chemotherapy first, radiation first, surgery first?
Neoadjuvant first.
No retroperitoneal nodes, no nodes anywhere else, no nodes in the lung.
In this scenario, neoadjuvant may be better.
Does everybody agree on neoadjuvant chemo here? Sir, we have a slide. Dr. Santosh. And I think we'll end with this. Perfect. So we have a slightly different take on that, and then I think we'll finish this. We can discuss.
Sir, I'm sorry, I'll have to.
Thank you.
I'll have to.
I think we'll finish this.
It's just going on and on.
We'll finish. Thank you so much.
Thank you so much, Dr. Andraja. I am so sorry and apologetic for cutting down the session, but we have overshot the time. The next discussion is on testicular cancer, and as moderator, I call upon Dr. Rakesh Sharma, who is a consultant uro-oncologist from Basavatarakam Indo-American Cancer Hospital, Hyderabad. And as panelists, I invite Dr. Ravi Mohan Mavaduru, who is a professor in urology from Postgraduate Institute of Medical Education and Research, Chandigarh, Dr. Santosh Kumar, who is a senior professor, Christian Medical College, Vellore, Dr. Kushal Narang, who is a senior consultant, radiation oncology from Medanta, the Medicity, Gurgaon, Dr. Kshitij Joshi, founder, director, and consultant medical oncologist from Mumbai Oncocare Center, Mumbai, and Dr. Chandrasekhar Pete, who is a consultant medical oncologist from Mumbai Oncocare Center, Nasik, and Dr. Archie Agrawal, professor, nuclear medicine, Tata Memorial Hospital, Mumbai. I hand over the session to you, sir. 30 minutes you've got. Thank you.
Good morning, chairpersons, and good morning, everyone. Thank you, SOGO, for the opportunity. So without wasting time, we'll go on the case-based discussion on testicular cancer. These are my esteemed panelists. Thank you for being there. Dr. Anish Srivastav is not there, sir, so I will ask Dr. Santosh and Dr. Ravi Mohan to take over. Thank you. So starting with the first case, typical Monday morning case, you have a 17-year-old male with a right testicular pain since 1 week on self-examination, not associated with any swelling or redness, no issue of trauma. Patient had a self-examination. On my examination, I had hard swelling on upper pole of the right testis, 2 into 2 centimeter, no tenderness. So the first investigation, ultrasound scrotum, Dr. Ravi Mohan. This is what is generally what we'll see in the ultrasound for a small indeterminate lesions. What is your take? How do you interpret such patients?
Sensitive investigation we have for testicular masses. So it goes without saying that no other investigation or nowhere probably ultrasound has stood as it is for testicular tumor, and typically you would see a hypoechoic lesion which would be lesser than the normal testicular parenchyma. And if you have an abscess, you would have some internal echoes, and obviously there will be some tenderness, redness, and all those stuff, so which is not there. So I am pitching more in for, since you said a solid lesion, it could be either a tuberculosis or a seminoma, which should be kept in mind. Tuberculosis will be more of a heterogeneous kind of lesion, and seminoma I expect a more homogeneous kind of lesion.
So we have a very good sensitivity for the ultrasound, but specificity can be relatively poor. So do you investigate the patient further, or Dr. Santosh, you would like to investigate the patient further, or you would go for some biochemical testing or something?
You can do the tumor markers.
Okay.
The only thing here is that pain. Pain again is not a sign of malignancy, it's more towards inflammation. However, you have absolutely no local signs of inflammation, which you usually do not see in any acute infection. And the history is very short. So you have to, if he comes to the OPD, you will definitely send the tumor markers apart from ultrasound.
Okay. So this gentleman already had a MRI done outside, and but would you like to get investigated MRI in case, or you are happy?
Most of the time, ultrasound is absolutely enough. If you have an intratesticular tumor which is vascular, or a lesion which is vascular, usually hypoechoic, that is usually enough.
So that is what even the evidence says, that there's not much of addition with the MRI. Only if you're planning for some testicular sparing surgery, you might get benefit with your planning and all those things, and find some other small lesions inside. Otherwise, there is not much of advantage of MRI. So this was the MRI done for this gentleman, and we had a 1.3 into 1.2 centimeter lesion close to the mediastinum of the testis, which was T1 heterogeneously isointense and T2 heterogeneously hypointense. And this was a lesion which was identified. So what is your take on this, sir? We had this serum testicular markers which you asked for. Unfortunately, they were not anything concluding towards.
Why you say unfortunately? Fortunately.
Fortunately.
Okay, for the patient.
For the patient, fortunately, but for us, it's still confusing.
So T2 hypointense and DWI imaging is what they would look at the MRI.
Yes.
I am not expert on MRI. I will never try to interpret a MRI. You have either paid somebody to do the MRI, let him do his job. And if you think there is a solid lesion there, it is very small, indeterminate, you can think about doing a conserving surgery, first a biopsy, and then go ahead. Conserving surgeries are usually done for only unilateral for testicular preservation, but when the diagnosis is uncertain, you can think about it.
So testicular markers basically are recommended in, yeah.
Room to say, please comment on microcalcification.
You can see, you don't need ultrasonologist to definitely tell you whether microcalcifications are there. When you see the picture, you will make out that microcalcifications are there or not. So the rest of parenchyma, anyway, it doesn't add much.
Yes, microcalcification anyways doesn't add much of addition. And even these investigations all have been inconclusive. It's not one case prior also have faced such issues. So where MRI and ultrasound both have been inconclusive. So finally you have to, as a clinician, take a call what is it. The radiologist says that we can do some FNAC, biopsy, whatever you want, but nothing we can say concluding that it is malignant. So this is what, there are some other markers are there, biomarkers, we are still under investigation. These micro RNAs are there. They are easy available, investigation can be blood or urine or semen, there are multiple of them are there, but still as of now not recommended, they are under investigation. So would you observe, sir, this patient, or you want, as you mentioned, that you would go for a testis sparing surgery or something?
When you are thinking of a tumor, you won't observe. Just having a normal marker doesn't mean anything.
Yes.
So you will not observe. If the patient is very keen, very anxious, you can remove the testis because the other one, because you have a solid lesion which is vascular, likelihood of it being malignancies is very, very high in spite of normal markers. So it's still go and take it out. So the only thing is patient.
So these are indeterminate masses, almost 20-25% can be
You can think of
also.
a conservative method. So you can do a Shivazus and take it out and do a biopsy and take it from there. However, testicular sparing is usually for only solitary testis. Should not try to do it just as like we do partial nephrectomy.
So we'll involve our medical oncologist also. Dr. Chandrasekhar, do you feel that any role of antibiotics, even though patient was complaining of some pain, and then because many times patient will present to the medical oncologist also directly, less often, but still?
I would be very happy if a patient presents to medical oncologist first. But this is what we actually tend to do, because even if I say this patient should undergo surgery immediately, he is always going to take some time to decide. So antibiotic would always remain a fair line of management.
Okay. Dr. Ravi Mohan, what is the current role of biopsy or FNAC in these lesions?
So I don't think we generally won't do a biopsy or an FNAC. One, because it violates the normal planes, and second, when there's a strong suspicion of a tumor, especially on an MRI, it's better to go for if there are multiple lesions, maybe we can do a Shivatsu or bilateral lesions, but otherwise I would prefer for a hanging orchiectomy. Okay.
So I've done some review of literature. There is a meta-analysis on this scrotal violation, mainly with scrotal orchiectomy, open testicular biopsy, where 1,082 patients were included with scrotal violation of 206 patients. So statistically significant 2.9% versus 0.4% was the incidence of local recurrences, which was statistically significant, but there was no statistical difference in the survival rates in all groups. So what they say is scrotal violation doesn't overall affect the survival or the prognosis of these patients, and they have to be in the similar surveillance protocol which you are going to put in the stage 1 patients. So Shivasa's maneuver was done for this patient. These are the steps for this procedure, we all know. Under ultrasound guidance only, we took out only the lesion and sent for a frozen section. So this was the final histopathology of this patient. External biopsy, we showed NSGCD, embryonal carcinoma, 1.5 centimeter. LVI was absent, and rest of the testes. So we did the completion orchiectomy, also orchidectomy for this patient, and there was no residual tumor seen.
Rakesh, can I interpret with pathology?
Sir.
So how difficult it is to interpret the photogenetic Santosh must be there. So we are doing a Swarjume, and we have to be pretty sure that how comfortable you are reporting frozen in this scenario?
So generally what I ask my pathologist, just give me whether it's malignant or non-malignant.
Cancer hai ki
nahi? I don't want any further details on that.
Giving a germ cell tumor on frozen is not an issue.
Not
so
an
we may
issue.
not be able to say it's an embryonal carcinoma or yolk sac on a frozen.
That is what we don't want, sir. Sir.
Rakesh, excellent. I think if you do a Shivasus and if you're going to take this tumor out, I think I'm sure there are centers who are trying, and we started recently. We are doing something, these patients who are unmarried, still to have fertility, do something called as an onco micro TC. Yeah. So you have rest of the tissue. So when you send it to pathologist for a frozen section, you take that amount of tissue and do for an onco micro TC, and that's much more easier and people would be happy with that if you are doing Shivasus.
So the only problem is Shivasus was planned here because this mother was very much sensitive, and he's just 17, 18, just getting to degree college. Often you see in such patients, with tumor markers normal. These are the problematic.
But that's usually the case. As Santosh had said, most of the seminomas you would not get raised tumor markers.
Yes.
But if at all you want to do Shivasus, otherwise also for orchectomy we started doing this oncomicro-TC.
Okay, sir. Thank you.
Even Rakesh, before going for orchidectomy, I think the sperm has to be discussed.
That we do, sir. In the paucity of time, I have not invested.
So if we are planning for do you still their role of micro-TC if you have collected the sperm? If the number is adequate, I don't think so that, because that will add to the cost of that overall. If the number is not there, then
sir,
the question
other problem in these young patients, the problem is they are not prepared to give the sample, sir.
Yeah,
psychologically, they are too disturbed. What I have faced in my clinical practice.
That's
so I offer them, yes, sir.
Yeah, that's the ground reality, because even people have looked at the stress pattern of semen quality which has been given prior to surgery. And even sort of subsequently also for 2 to 3 weeks you do semen preservation, the quality of sperms is not good.
Yes.
So though it is cheaper, not sort of clinically properly utilized, that's one option, but I think anyway you're going there, why not have it?
Yeah. True, sir. Thank you, sir. Well taken, sir. So, as Dr. Santosh has already mentioned, the problem with this testis sparing surgery is the local recurrence. So, radiation, Dr. Narang, do you want to add anything in these testis sparing surgery is done for these gentlemen? So, I have not done in this case, but if it is done, then what you would do further for this patient? I would like you to answer these points.
So obviously, as if you have done a testis sparing surgery, which is of course not the standard here, then biopsies from multiple sites have to be taken to make sure that there is no area of germ cell neoplasia in situ. And then in that case, the patient will also require, after preservation of the semen, he'll require a dose of radiation, low dose radiation, 20 gray in 10 fractions is given to the testes. But as sir also mentioned, the scenarios are when you have either bilateral tumors or you have the single testes with the tumor. In that case only we can use this scenario. And then after that, patient has to be on stringent follow-up by testing the serum tumor markers every 3 to 4 monthly, and also an imaging follow-up. In fact, yeah, I mean, right now also we haven't done the imaging as yet, so we have to make sure that there are no nodes on the
So,
CT.
Dr. Achi, this is basically a very early disease. So, still you want to do imaging or will avoid imaging?
I think, I mean, if you are speaking about PET, there's no role of PET in a non-seminomatous germ cell tumor. A CECT would suffice, abdomen and pelvis would suffice, and there's no role of FDG PET-CT in non-seminomatous.
Even in
germ
the
cell
early
tumors.
disease when the patient had presented, we will not advise. Right? Thank you very much. So this was a stage 1, CT and everything was normal. Even chest was also completed. PT1, N0, M0, S0, NSGCT, low risk disease. What are the treatment options here? Dr. Anish Shivasajna, I would ask Santosh sir to take that.
So you are looking at risk factors. So LVI was not there. It is embryonal carcinoma. How much percent embryonal carcinoma is what you look at. Now whether there's such a small focus, I don't know. So one risk factor definitely is there. It's completely embryonal carcinoma. So these type of patients.
Sir, yes.
Embryonal predominant. So for risk
Sir,
stratification for embryonal, it should be embryonal predominant irrespective of the percentage.
No, Anand, in the recent guidelines, embryonal has been removed. Only LVI is there now.
No, embryonal is also there.
No. I'll show you. I'll show you the. So this is the recent guideline which says only LVI is the high risk factor. This is what is the recent guideline says. So, sir, we follow it is different, sir. So I am presenting the evidence. This is what the evidence says. So as of the present guidelines, this gentleman comes in the low risk category. So we can offer him surveillance because in low risk category the incidence of coming is around 10%, and it increases to almost 30% if there are LVI is present. So he is a candidate for surveillance.
Now you are looking at a prognosis nearly cancer specific survival and this thing of 100%. So you are now looking at what possible. RT is out, chemo versus surgery. Now chemo, it depends on the patient. The response rate of chemotherapy is much better than surgery alone. 5 to 10% they would do better. But problem with the surgery is if there is a non-nerve sparing bilateral, then you have high risk of RE. If you can do a nerve sparing, 90% would have preserved ejaculation. The issue is that there is local recurrence after surgery. Don't think that surgery is 100%. Within the template of this thing, if you have not done a complete template, it is a little higher risk, maybe 5%. Even can go to 10% if surgery is not done properly. But again, this is very early disease. In this, you do not expect local recurrence. There's a small 5-10% chance that you may have a distant recurrence. And chemotherapy there would be about 5 to 10% better. But if the patient wants to avoid chemotherapy, long-term side effects of chemotherapy, then you can offer him surgery.
So we'll ask Dr. Chandrasekhar to answer that point.
Rakesh, I just...
Yes. Yes.
So the risk factors completely change. Embryonal 100% without LVSI. From a pathologist point of view, it is problematic because these tumors are very friable and they go everywhere. They stick around all the tissue. So recognizing LVSI is a big problem and big issue.
Okay, so you will keep in the high risk group.
Yes. So
okay.
we have to be careful. If
yes.
it's purely embryonal, we would really want to find those LVSI because that's completely changing.
Agree, sir. Yeah. So, Dr. Chandrasekhar, chemotherapy.
As Amit Bhai pointed out, these patients actually do not do very well. So, I always discuss chemotherapy with these patients.
Okay.
Many a times I still end up doing one cycle of PB. That is what I.
Okay. So 1 to 2 cycles are recommended. I think one is more than sufficient. What Dr. Santosh has already answered about the primary RPLND, it can be done in a nerve-sparing way. So in that case, if you have a pathological node positive, the incidence of having recurrences are up to 30%, and if it is negative, then still 10% chance is there. And if the node is positive, then again the patient requires chemotherapy. Okay. So this is what the guideline says.
If you are actually looking at an N1 node after RPLND, he may still be curative. There are patients where you can have 5 to 10% recurrence local, which can again be either with chemotherapy or with surgery dealt with. So it depends on what is your mindset. If a patient is dead against chemotherapy and he has opted for surgery, even if he has a small recurrence, that chance will be much less in N1 versus N2, N3. If you have N2, N3, it's better to have chemotherapy, but N1 you can even observe.
Okay. So this is what the guidelines say. The standard option would, in this patient would be to go for surveillance if low risk, and if it is high risk, the standard would be to go for adjuvant one cycle BP, as Dr. Chandrasekhar has mentioned. And this will be the protocol if you are planning for a surveillance. It's a little strict protocol. Patient has to have a regular surveillance, at least for 5 years. So the tumor board, we had a discussion and the patient opted for surveillance, and this is a recent case, so I can't tell you the follow-up as of now. Case number 2 is a 46-year-old man, again present with the right testicular swelling since 1 month, hard nodular, 3 into 3 centimeter. This was the ultrasound, tumor markers were normal, and in the high orchiectomy specimen, we had a classical seminoma, and there were no other high-risk features. I want to ask Dr. Santosh, he is available. Sir, what is the role of IHC in these testicular markers, testicular tumors as of now, in the primary?
It's not done in every case, because if you have teratoma, cleavage or yolk sac pneumonia, then seminoma we don't do IHC survey, which is a classical. So in 1 in maybe 8 cases, 1 in 10 cases, you would want to distinguish because we're trying to look for embryonal. Now that it's out of risk, we may not even end up doing those.
Thank you, sir. So this was
I'll add a very quick point here. What Santosh sir pointed out is perfectly right, but then what happens in clinical practice is completely different. Yes. You have to be very sure who is reporting your pathology. If you are not sure, you always end up ordering an IHC because you want an HP review.
True.
So it's the other way around.
So CT scan was done for this patient. We had a 3 into 3.5 centimeter left parietic nodal mass, and the post-op tumor markers after 4 weeks were normal, and this was the stage PT1A, N2, M0, S0, 3A, good prognosis. What are the treatment options? Dr. Ravi Mohan would like to do RPLND straight away for this patient. Tumor markers are normal, but it is a seminoma.
No, so I'll not do RPLND. They should clearly go for a tumor board, and they would mostly receive chemotherapy as the first option, and then the RPLND, the problem in seminoma, we have to remember that there's a lot of desmoplasia. It's completely stuck. You will end up leaving more tissue and damaging more than removing.
But that is generally post-chemo what see.
Yes.
In upfront, you won't see that situation.
Yes. But then even in this situation, we would err towards chemo and radiation rather than surgery. That's our protocol. So we generally don't do it.
Dr. Narang, any role of radiation therapy in this gentleman?
Yeah, radiation therapy does have a role in this situation, and we'd like to treat the paraiotic and the ipsilateral iliac nodal regions to a dose of 30 gray, the entire region, and followed by a boost to the gross nodes with a margin there to a dose of 36 gray. The technique used is 3D conformal techniques. APPA, anteroposterior, posterior anterior portals are most commonly used, shaped with multi-leaf collimators. That way it helps reduce the dose to the kidney, the bowel, and the liver. and those I mentioned. But limitations, yeah, and long-term side effects wise, it has been said that the radiation does increase the risk of second malignancies to the tune of 1.8 to 2 times. Although second malignancies are also reported with chemotherapy, but with radiation the incidence tends to be slightly higher. Hence the preferred option here is chemotherapy.
Dr. Joshi, would you like to?
Yeah, definitely seminoma is very chemosensitive tumor. This is a N2 disease, good risk. I definitely want to give chemotherapy, and my preferred choice is 3 PEB if there is no contraindication from pulmonary point of view. Otherwise 4 PE.
Rakesh,
Yes,
was it stage 2A or 2B?
Sir, it's 3A, sir.
3A. Right, it's a high volume disease. Right. Okay.
So definitely no role of RPLND because of high chances, still investigational. And Dr. Narang has already explained about the radiation. The reported relapse is around 9 to 24% in these patients. As the stage increases, the chances will further increase. So this was the recommendation here. Preferred will be chemotherapy for 2A and 2B, and if alternative, you can go for radiation also. So our patient is started on 3 cycles of BEP. Dr. Archie, how would you like to follow this patient? And what is your timing of PET-CT? There's a lot of discussion always happening when to do this PET-CT in these patients.
The guidelines recommend post 6 weeks after completion of chemotherapy, but in TMH we have started doing after 8 to 10 weeks, particularly after 10 weeks. That's better because you still may have the inflammation due to the chemotherapy and a lot of fibrosis, which can show increased uptake. So we don't want that, and to avoid that, it's better to do after 8 to 10 weeks after completion of the chemotherapy.
So your first scan itself is a PET-CT in seminoma, or you do a CT, and if required, do you do PET-CT? Because there will be a long waiting list for the PET-CT, I believe, sometimes.
I mean, in our cases, we do a PET-CT, but then when you have residual masses more than 3 centimeters, because you are looking at basically the negative predictive value of a PET-CT in more than 3 centimeter sized masses is better, and we are looking at whether it shows uptake or no, and if it doesn't show uptake, we know that there's no disease, and such patients can be observed. Whereas if you're seeing some uptake, then you should go in for a biopsy, and then
So our patient had a CT scan at around 4-6 weeks, and it was around 2.5 centimeter, and then later a PET-CT was done, and it showed 2.3 centimeter. SU was very low.
Yeah.
So what if we have a nodal size of 4 centimeter with at 2 months with a SU of around 5.5?
See, actually, there's no SUV cutoff as of now, but we go in visually, and if you're seeing more FDG avid as compared to the background, we say. But a recent publication where we have looked at seminomas, and it's going to be coming in the print soon, where we have seen at a cutoff of 4.5 gives a good sensitivity and specificity and a positive predictive value. So 4.5 in our study that we have seen. We have also looked at tumor to background ratio or the tumor to liver ratio, and we have come up with a value of 1.2, which shows a high good sensitivity and specificity, but that's still coming in, and it will come up soon, maybe in 2-3 months. It's already accepted. But as of now, we go by the visual
impression,
visual evaluation only, and if we see that the uptake is more than the background, then we say that it's positive uptake. With a 5.5 SUV, that's definitely high, and we would call it there's chances of residual viable disease in such a tumor.
Dr. Ravimohan, would you consider for excision of mass RPLND in such?
Yeah, in this scenario, yes, because you have a 4 centimeter mass which is showing an uptake, good uptake on PET scan, FDG PET, and ma'am rightly said that more than 3 centimeter residual mass, we would typically get a PET scan, and if it is enhancing, we go and excise it. Here, we will not probably do a formal RPLND, unlike we do it in SGCT. If it's a seminoma, we would just excise the mass and maybe do that clearance of that vessel on that side. We really don't go very radical in seminoma.
So, role of RT, Dr. Narang?
Yeah, I could see Dr. Vedang approaching the mic. I think he wanted to say something.
Okay.
And there was a publication from Sir and TMH team 2 years back in which they have stratified this into very poor risk category, size more than 3 centimeter and SUV more than 3 centimeter, and then SUV more than 3, and then try to give radiation to these patients, and they have fared well as compared to observation.
Dr. Chandrasekhar, would you like to keep observation for this? This is a 2.3 centimeter, means the real scenario for our patient now with a low SUV.
Less than 3, I would put on observation.
Okay, thank you. So this patient, yeah. Sir.
How keen are we to do an RPLND?
No, so if it is more than 3 centimeter, our biopsy is positive.
Post chemo, if we have the option of giving non-invasive RTs,
We always do that. No, RP-LND is an option, but first we have to confirm that we have any residual malignancy, viable malignancy. Then it's always decision between decision between the RT and excision of the mass. How confident you are. It is very rarely done. Probably I also must have not more than 3 cases, sir.
The worst case is, I think, if you give RT and if he fails, and then doing sort of RP-LND again, that mass is going to be challenging.
It's almost like impossible. So that is what I was trying to tell Amandeep, that if required, you have to take decision now only.
So though seminoma is radiosensitive, I think it's much more easier if you have smaller volume mass. But I take a point, especially on the left-hand side is okay, but on the right side, when the KY is so thin and plastered, it's impossible, a lot of complications.
Most of the time we end up with just piecemeal removal of the mass.
Yeah,
it doesn't come out intact.
But if you do an incomplete excision, I've seen people feeling and sort of having further problems, and giving even a second line, third line is going to be challenging those situations.
JNK sir, yes.
Yeah, there's a serious issue with the thing, with the PET CT that you're asking. The issue, I think Madam has very clearly told, the true negatives are very good.
Yes.
The false positive also equally bad. If you go by the SIMPET study, it was horrible. Nobody has been able to reproduce those results. And we have our publication on seminomas, large residual mass of seminomas. If they are non-enhancing and decreasing in size, we still, even if they are high SUV, we just observe them.
Yes, sir.
We do not intervene.
It takes time to shrink.
The biopsies we have done are all been negative, and they are usually necrosis because the initial mass was too big. So they take time to shrink, and with time they keep shrinking. And those we don't interfere at all, don't give RT also.
So that is what we'll wait for the maximum time, follow up this patient closely, and then take a call.
So very contextual, let me put it in context. So clearly a post-chemo residual seminoma which is largish and a SUV of say 5 or 7, we don't know what to do, correct? So some brave surgeon might try to operate, which I would try to avoid. Observation, multiple PET scans is one thing, lot of anxiety. We believe that these patients, and Archie has also published, about 30% of them will relapse and they will need second line chemotherapy. That is not easy. Radiotherapy to that area may be over treatment for about 70% of the people, but it will be safe. So we are actually doing a randomized trial. Many of you know about this. Some of you are going to participate. It's called ProSen. Exactly this patient. Standard is observation with repeated PET scans that you were saying. And test arm is giving 30 gray to only the PET positive area. So it's a 74 patient randomized trial. We are at about 20 right now. If anybody of you are seeing seminoma patients who are post chemotherapy and you want to join in, please let me know.
Sure.
We'll
sir.
More patients.
Yes, sir. We'll discuss. We will discuss that during the coffee time, sir.
Yes.
Case number 3. This is a 27-year-old unmarried gentleman with a swelling of less testes, 3 months duration, palpable mass. This is ultrasound, and here we have a AFP of 37, and beta HCG and LDH are normal. So definitely, I think our surgeons will go for surgery. And this is a CECT of this patient, multiple retroperitoneal nodal masses of largest 4 into 4 centimeter, and CECT showing multiple lung lesions. So, any role for upfront chemotherapy? Do you decide, Dr. Chandrasekhar, that you want to give chemotherapy? What are the case scenarios you take a call for that?
Most of my patients would not land up with upfront chemotherapy, but then I have
big
seen some
lung
patients,
masses are there, not this classical case, this case
but
what I am
if
seeing.
a patient is too symptomatic for a lung disease, or we have got a, say, a spinal mass intruding into the spinal canal, then probably these are situations wherein I would, maybe I will go ahead with chemotherapy first.
So what is the regimen you follow in those cases?
In practice, I end up giving BP only, though VIP.
The lungs are bad. Lungs are bad. Patient has severe SOB.
See, this is a scenario which is different from what we routinely see, but then BP does remain a good option. VIP, of course, is a better option, but many a time these patients, if they have not undergone upfront surgery, we tend to give up cisplatin etoposide in reduced doses and then hand it over to surgeon.
So what in cancer center, what we see is these patients present with SOB, they are very bad. They are admitted in MICU straight away. They are on oxygen support, sometimes high flow oxygen. So our medical oncologists prefer to start with EP, and subsequently once the patient has stabilized, they will add BEP in the second or third cycles. So this patient underwent hindwall orchidectomy. This was a histopathology report. NSGCT embryonal carcinoma, 2.5 centimeter, invades the spermatic cord, and it was PT3 N2 M1A S1 3A NSGCT, good risk. Dr. Joshi.
Yes, sir, definitely chemotherapy, 3 PEP, as it is a good risk.
Any other options?
Then both options are mentioned, but my preferred option is 3 BEP, which is slightly better than 4 EP. And I will prefer EP only when there is a compromised lung or compromised kidney function, because that can lead to also pulmonary toxicity, bleomycin induced. And if the patient is above the age of 50, then I will. Otherwise, all other 3 PEP.
Okay, so this patient was given 3 cycles of BP and is on follow-up, and he's undergoing chemotherapy. So another
Sir,
case.
you have 1 minute left.
Yeah, ma'am. I'll
Exactly
complete.
1 minute.
I'll take 1 minute extra. Thank you.
No, sir, I will not give you 1 minute extra.
So this was another case, similar findings, but here we had large abdominal masses, retroperitoneal masses, and the chest HRCT was done, so it was normal, and these were the tumor markers. As discussed, cryopreservation, all those things are generally done as a standard, and this was the histopathology report, and it was stage 3B, PT1, N3, M1A, S2, intermediate risk. Madam, any role of chemotherapy, PET CT here?
It is an NSGCT.
Yes, ma'am.
Right? So then there's no role of a PET CT. I've already said that there's no role of PET CT because neither the positive predictive value, neither the negative predictive value is very high. So there's no role of PET CT in a non-seminomatous germ cell tumor. Because even mature teratomas, they can be completely non-FDG avid.
So here we had a PET CT done outside. Only the additional finding, we had a parasocial nodal mass was there, 3 centimeter. He received 4 cycles of VIP. Are you comfortable with VIP, sir?
30 seconds, sir. Last 30 seconds.
4 cycles of VIP was given. So are you comfortable with VIP as upfront chemotherapy regime, or Dr. Joshi?
Our preferred regime is BEP, but VIP we give sometimes specifically, as sir has mentioned, in mediastinal masses. And the neutropenia chances are little more, but with compromised lung functions can be taken care of.
So later the post chemotherapy, the tumor markers normalized. This was the CT scan at the end of 4 weeks of chemotherapy. Dr. Ravi Mohan, what is your plan?
Yeah, that's a difficult situation, but yes, I think majority I would go in and excise it if the markers are normal, and because there's more likely to have a teratoma, and yes, it would end up with more of a multidisciplinary approach where we would have a vascular surgeon along with me, and it's an entire day's job.
Okay. So RPLND bilateral complete template was done, and this was the intraoperative findings: histopathology teratoma, mature teratoma. And regarding chest, how would you manage same sitting, separate sitting, duration?
Sir, I'm sorry, I'll have to.
Okay, ma'am.
I'll have to cut short
here. Last slide, ma'am. Sequencing has to be done in these patients. You have to plan, and generally, when the histology at the abdomen or whichever is a larger area of involvement, whether it's chest or abdomen, accordingly you have to plan. For example, if it's abdomen, in this case, 90% chance that you'll have the same histology. So this patient underwent a mediastinal mass excision also later, and he had the similar findings, mature teratoma there also, and he's on follow-up. Thank you very much. Thank you, panel, for the good discussion. Thank you.
Thank you, Rakesh.
Thank you so much, sir. I'm so sorry for cutting it short, but we are already running late in our schedule. So our next topic is psychological help and palliative care. How early is appropriate? And as speaker, I would like to call upon Dr. Jaita Devdhar, who is a professor in palliative medicine and psycho-oncology at Tata Memorial Hospital, Mumbai. Ma'am, you've got 10 minutes and 5 minutes for discussion. Thank you.
I guess as one of the conveners, I request everybody to stay with time. And I know ma'am is very strict with timing, but
I know, but please do not put me in an embarrassing position where I have to cut you short. Thank you so much. No, today being the last day, lots of people have got their flights, so we would like to be on schedule so that people can finish on time and be at the airport. Thank you very much.
Thank you. That's 20 seconds gone from me. Okay, so why talk about psychosocial care? We've been hearing about the pain discussion that we've had. Quality of life are areas of concern. We are talking about different cancers at different age. So prostate cancer patients compared to testicular cancer patients, different stage in life. What about prognosis? the treatment implications. We have to remember that, and the possibility of recurrence progression. And what do we have to see? We have to think about coping for both patients and caregivers and consequent mental health issues. So I'm going to stick to what the literature shows, and you can see and you can expect that depression and anxiety symptoms are really common in all the genitourinary malignancies, almost 40 to 60%, some more of depressive and anxiety disorders. But specifically in prostate cancer, it's seen that 60% of the patients, mainly older adults, have a lot of decision-making distress. And we know about depression and anxiety symptoms related to androgen deprivation therapy. We've seen that any kind of treatment, most patients really tolerate it well psychologically. There's been some studies showing that active surveillance will have, patients will have more anxiety, but that's sort of not, it depends. And the cognitive impairment that is associated with prostate cancer, which some studies have shown, it still is at an equivocal evidence base now. For bladder cancer, we know, and it's proved that the suicide risk is really quite high, and it's mainly in older, unmarried, and those with advanced disease. And because of the significant mortality despite advances in treatment, there are poorer physical outcomes, and the quality of life impairment because of things like urinary complaints, sexual effect on sexuality, and most of the GU malignancies. That's a problem, that it's something about shame, and you can't really talk about them, and especially in countries like us. And kidney cancer, it's really about, again, mortality, the possible prognosis. So 20 to 30%, this is quite proved, about depression and anxiety and maybe disorders. And there's always that fear of cancer recurrence in the localized cases. Testicular and penile cancer, especially testicular cancers, it's all about coping with diagnosis and its stage in life. So it's all problems with intimacy, sexuality, fertility. We didn't really talk about that in the panel discussions, and this is so huge for them. And typically also body image, fear of recurrence, and long-term effects of treatment. So overall, what should we do about psychosocial interventions? We should think about early recognition. There's a whole big need for information because patients and caregivers need to make the right decision, which there is a role for active counseling. And at each transition point, how early is appropriate? It's at each transition point. We have to think of long-term effects, and we also have to think of the caregivers. What is the evidence base? Evidence base is mainly that there is a small and short-term benefit in certain domains of QOL and knowledge about, that is in prostate cancer patients. And in bladder cancer, there has been some role for group and couple interventions. So moving on to palliative care, because the reasons why we are talking about psychological help are the same things that we need to focus on palliative care. And those who think that palliative care is end-of-life care and it's hospice care, this is not. This slide shows that it is really encompassing along the cancer trajectory and the disease trajectory, and can begin right early and go on to when it is terminal decline and terminal, and of course post-bereavement. And ever since Jennifer Temel broke into the scene with studies on early palliative care, and now we have Cochrane reviews saying that early palliative care is so important. So unfortunately, in GU malignancies, the uptake for palliative care or the referral to palliative care, if you see retrospective studies, is not more than 10 to 20%. And in the established studies on early palliative care randomized control trial, GU malignancies have been represented in only maximum 8 to 10% of the patients. So these are some of the non-randomized studies of palliative and supportive care interventions. And you see that there are some short-term benefits, but the most of the things is the ones that you see here. There's no randomized control trial of integration of palliative care in GU malignancies as yet. These just show some trials in using exercise as a supportive intervention. So aren't there so many possibilities now? So you can, then these are some of the, where do we see? So is it early? Is it appropriate? Is it timely? We'll talk about that. But the things that we need to discuss are, you know, decision making. How can we help with decision making? There is any time we can talk on emotional and spiritual issues, fear of recurrence, death anxiety, so that at any stage. Of course, there's physical symptoms and subsequent psychological distress because of that. There's always financial concerns, ethical, legal, and decision-making difficulties. And at any stage, again, it is difficulties in how best to use surrogate decision makers. So there are some movements from early palliative care to something called timely palliative care. Because how early is early? Nobody really says about how early is early. We say within 2 months or within 3 months. And it's been seen that early palliative care, those who were referred for that, some of them really didn't have that much of symptoms at the beginning. So they don't tend to follow up, or it is not that effective. So what they recommend is something called as timely palliative care with 4 components, which is you do a routine screening, you have referral criteria, we have automatic triggers, and this is mainly for outpatient palliative care resources, and this will help in increased timely palliative care access and improved patient outcomes. And so I leave with these thoughts for you. Should it be early? Should it be timely? It should definitely be a person-centered and a family-centered approach, both for psychological help as well as palliative care. It should be needs-based, those who need, but how do we know? We need to identify them. And of course, there's possibilities for integration, and in our resource constrained settings, we really need to develop our own models of service, both in psycho-oncology and palliative care. So thank you very much. And should I get a brownie point? I still have 2 minutes. Okay. So that gives me time for questions. So.
Yes.
Thank you, Dr. Joyita. So, sometimes we see it on the face of the patients that the moment we mention about the need to visit the palliative clinic, they feel as if, you know, there's not much can be done, even though the fact remains that we are still looking at like a 5-year or longer survivor. So this scenario could be either because the disease, even though metastatic, typically prostate, you know, even in a advanced prostate cancer, some of these patients live 5 years more. Or it could be somebody with a non-advanced disease, but we feel the need to, see your department. So could there be a better or an alternative? I mean, do you think that acceptance of the palliation might be more if we dissociate the term palliative and use an alternative term for it?
Okay. So you've come to the nomenclature bit. However you dress it up, the underlying is the same. So there are studies which have said, MD Anderson Cancer Center has said, moved from palliative to supportive care. Some people are very staunch about maintaining palliative care, but I think it is the components which are important. Just changing the name, even if you talk about that, patients talk amongst themselves, and it is still going to be room number 75. Whether we name it as palliative care or it is supportive care. And also very important to remember is a lot of the stigma that you're talking about comes from professionals themselves. And why do we do that? Is because we are equating palliative care equal to end-of-life care. Palliative care equal to hospice care, which is no longer the case. It has moved up some leaps and bounds. So we need to, because these are subliminal messages which we are going to do. We can also do better from palliative medicine specialists. We can do leaflets, we can put up notices, we can do that. And it's good that we work together in Tata Hospital, so we don't have that. Patients will have that, and that's all over, international. And some people are very staunch for supportive care, calling it supportive care. Some people sit on the fence and say palliative and supportive care, so you don't want to take sides. And some people will staunch about palliative care, and the last group includes me, because I don't really think that changing the name changes the service. We do the same thing, so that is there. So we need to do more, especially in our settings, but it's not just our settings. There is that bias about. And that's because it comes because it's always been about end of life. If we don't have that, if we have to talk about what we do, we talk about physical symptom management, psychological symptom management, help in communication, make goals of care decision, better decision making, advanced care planning. These are the components that we need to focus on, and this is what we need to advertise and publicize.
Thank you.
Oh, I had to ask them, Madam Chairman, to make sure I had time for this question. So great talk. I would say the nomenclature is not unique to India in terms of palliative care, supportive care, et cetera. I think we see it across the ocean. One question I do have is sort of how do you square away the patient panel we had yesterday and their concerns with access to just the physician, but at the same time we're trying to speak out of both sides of the same mouth of getting early access and early referral to, early intervention for understanding the disease and the palliative care, because it seems like we're torn not just here but across the world in terms of resources for both.
Yes. So resources are always going to be a problem. So I think that is why I left the last slide as that we need to develop our own models with the number of resources that we have. And the resources start right from the oncologist. So whatever the basic primary palliative care approach that the oncologist does goes a long way. And especially in a country like India, where doctor is God. Of course, we are also doctors, but the oncologist is Godder. So everything will be about that. So if we can pass on that message and we do that bit of symptom management, pain management, and then say, don't you think that you would be better off with, going to this particular service, provided that service is there. What if the service is not there? And that becomes a collective responsibility, that this is such an important, essential, crucial service. We should all buy in, all institutions, private sector, public sector, NGOs, we should all advocate for palliative care. That is one way to go about it. We can complain till the cows come home, but that is not going to be doing there. So we need to do our bit. Thank you.
Thank you, Dr. Jayita Devdhar, for an excellent talk. Our next speaker is Dr. Amandeep Singh Arora, who is an assistant professor in the Department of Uro-oncology at Tata Memorial Hospital, Mumbai. He'll be elaborating on post-treatment quality of life and bladder cancer. Over to you, Dr. Amandeep. You've got 9 minutes. Thank you.
Great. Good morning, everyone. After that absolutely amazing talk by Madam Devdhar, we'll look at post-treatment quality of life, so something a little earlier to the setting that Madam spoke about. So over the next 9 minutes, we'll go over these 3 settings that we see bladder cancer patients in. And for all of these, we'll look at what tools do we have to assess QOL. Do we have Indian data about it? Is there scope for improvement on our parts to improve the QOL for our patients? And what numbers do we actually quote to our patients while counseling them about side effects and long-term side effects? Why actually are we discussing this? Professor Ian Tannock in this very hall said that all our efforts, all studies, either have to make patients live longer or make them live better. So this talk is about trying to make them live better. With intravesical therapy or cystectomy or with radiation, survival benefit has reached a plateau, right? So you do cystectomy, patient is going to live long depending upon what biology the patient has. Only systemic therapy advancements can push the line further. Only they can, increase overall survival by a few months or a few years now. So we need to make our established existing treatments more tolerable. That's all. We need to just make them a little more tolerable for our patients because we cannot increase lifespan further with our surgical treatments. And we maintain long-term quality of life for them. What aspects of QOL do we look at? We want to look at overall QOL, that is very vague. So we break it down into physical, psychological, and sexual QOL. at what time points. So we assess at baseline because that is how we compare in the future. Immediate is for BCG on when the patient is on installation, cystectomy when the patient is in the hospital with you and during RT. This is usually captured in literature as post-operative morbidity and not really quality of life. And then actual quality of life is reported at 3 months, 6 months, and 12 months, usually in literature. Coming to NMIBC with BCG. So why is QOL important in the NMIBC setting? Because NMIBC doesn't kill, right? Patients live long. We have long-term survivors, and many of our patients are young and they're expecting to live as normally as they were earlier. How do we measure QOL in them? So this is a little heavy slide. So we have cancer-specific questionnaires. I'm not going to go into the details. I'm only naming them. EORTC QOL Core 30 is the most commonly used in literature. The FACT with 27 questions is also used. We have disease-specific. So we come to bladder cancer-specific questionnaires. These are the 3. So you can see they are all in excess of 20-25 questions. So they are objective, they are validated, they are great for research, and they help you compare across papers. One thing that we don't know is if for function X, if open cystectomy has a score of 80 and robotic cystectomy has a score of 85, and that is statistically significant in that paper, is it actually clinically significant? That nobody knows. And you obviously cannot be using these questionnaires in your day-to-day practice in the OPD. So what do you do in the clinic? You use the CTCAC for urinary symptoms and hematuria. You use the International Prostate Symptom Score, although it is for BPH, but you use it to assess urinary symptoms in our patients. And we use the IEEF-5 for asking a patient 5 questions about sexual health. That is also mostly male patients. Do we have Indian data about QOL and NMIBC? So this was from the group at Kokila-Bain. And we look at only this column because it is about the Moscow strain, which is available in India right now. And you can see 67% patients had moderate to severe side effects. 43% had to discontinue BCG. 20% required anti-tubercular therapy. 11% required a cystectomy. These numbers might seem a little higher than what we actually see in our clinical practice. Bottom line is patients face a lot of problems when they are on BCG therapy. We have another paper from the group at Adyar. 96% of their patients would complete the induction phase, but a 1/3 needed some breaks to complete the phase. One difference in their schedule is that they give monthly maintenance, probably a little more tolerated better. We have unpublished data from TMH where we looked at 100 of our patients. They received the Moscow strain. 37% had to discontinue. So how do we make intravesical BCG more tolerable for our patients? We allow a minimum of 2 weeks after TURBT to allow that scarred area to heal. We educate the patient about expected side effects right in the beginning. We tell them that you are going to face mild symptoms in about 60% of our patients, severe symptoms in about 1/3 of our patients, about 1/3 are going to actually discontinue BCG. So when we tell them that we cannot give you more BCG, they are in fact bothered about the oncological outcome because they're like, you're not giving us treatment now. Electively use a lower dose of BCG in the elderly and in those with existing symptoms. This is sometimes that we take a clinical call, 70, 75-year-old, already having LUTs, probably give a 40 mg dose of BCG in the clinic. We obviously want to rule out a UTI, ask the patient how he tolerated BCG the last time before you put in the drug again. Always instill under gravity. Don't push for 2 hours. Tell the patient 2 hours is what I would like. 1 hour is enough if you can do that. And you may reduce the dose or change to something more tolerable if there are signs of intolerance. Coming to post-cystectomy, now why is QOL important here? Nobody wants their bladder removed, right? Nobody wants to undergo a cystectomy. Most common diversion that we do is the conduit, and it's a body disfiguring surgery. NMIBC patients who undergo a cystectomy and PT2N0 patients, they live long, right? So these patients' quality of life becomes much more important a few months after they have undergone the surgery. Does the approach matter? This is from the RAZOR trial. They used these 2 questionnaires, the FACT index and the short form 8 health survey. We'll come to it again later on. They assessed QOL parameters at baseline, 3 months and 6 months. As I told you, that is how they do in most papers. They did not find any significant differences at any time point. All of our surgeons, when we see an open cystectomy patient, the patient is usually not sitting up well in bed the next day, but the robotic patient is probably sitting up in bed the next day. So these questionnaires actually look at quality of life. That is what I'm telling you. 3 months is a little too late to assess if the robotic surgery had an effect better than open surgery, because robotic surgery helps the patient go back home early. But at 3 months of time, that difference has probably, gone away. Does the type of diversion matter? So all our data is retrospective over here, but it usually points towards the fact that neobladder may be better than the ileal condio. But the patients, if you help them, they learn to live with the condio without having any inhibitions in their day-to-day activities over the long time. And that is why even if patients perceive that a neobladder is a better diversion, it has to be a shared decision. If the patient understands that he's not going to do CIC, he's not going to do his own bladder washes, he does not want to wear the diaper, but he's okay with the bag which is hidden under his shirt, he probably wants a condio, and that is what you should give him. This is the short form 8 questionnaire. This is one questionnaire that can be used in the clinic. First question, overall, how do you rate your health? Second question, does your current physical status limit your physical activities, daily physical activities? Are you able to do your daily work at home? Do you have bodily pain? These are the first 4 questions. Very simple for the patient to answer. Next 4 questions, how much energy do you have? So basically, how active do you feel? Does your current problems limit your usual social activities? Are you bothered by emotional problems? And do they prevent you from your daily activities? So we wanted overall QOL, and we broke it down into physical, psychological, and sexual. These 8 questions give you a very basic idea about the physical and psychological status of the patient. You can ask him or her a few questions separately about the sexual health, and you have your own personalized overall QOL in the clinic. How do we improve QOL after cystectomy? So we counsel the patient rightly and have the post-op expectations set right at the beginning. We select the right treatment option for the right patient, whether you want to give neoadjuvant therapy, whether you want to give adjuvant therapy, the patient has PCNs, you want to first operate, get rid of the tubes, because moving around with tubes is also a quality of life index, which is not captured by any of the questionnaires. The approach probably does not matter. The type of diversion probably does matter. And nerve-sparing cystectomy may probably give you better sexual outcomes. The support system, right? So we had a representative from Littlemore yesterday on the dais with us. Ostomy India, Bladder Cancer India. These are forums, patient support groups, which is going to help the patient, cross that journey from the day of surgery till coming back to how he was living life prior to the surgery. These are some images from our stoma care clinic in TMH. And basically, patients meet the stoma staff. They meet patients who have already had surgery, so that there is some survivorship clinic happening there. Last 3-4 slides. QOL inherently, is it better than cystectomy with bladder preservation? Because the patient retains the bladder, there is no post-op comorbidity, there is definitely no mortality, but it does have its own QOL issues. So we use routine questionnaires even in the papers, and the RT-OG grading is used. We have unpublished data from TMH, where we have found that the urinary and bowel system domains are the same for both. Sexual domain was better with RT. It's probably very obvious. This is a prospective collection that we have begun doing, the compact study. We are aiming for 250 patients. We'll be using those questionnaires and keep on following patients till they have a metastatic recurrence. What numbers do you tell your patients? You tell your patients right at the beginning for a surgery. 2/3 are going to have minor complications, 15% major complications, 2% will not go home. CTRT, severe grade 3 complications, 2%, mild to moderate. I've taken these numbers from a radiation onc colleague, so I'm not extrapolating them or saying wrong numbers. 15% need a salvage cystectomy. Finally, QOL is as important to the patient as the oncological outcome. Objective and validated tools are used in the research setting. In the clinic, you can use these tools. The SF8 is a fantastic tool to capture it. You look at physical, psychological, and sexual domains, and then you get your overall picture. Counsel patients with honest numbers. Intermediate and long-term outcomes don't depend on modality of treatment, don't depend on open versus MIS. Neobladder is probably better than a condio. Most patients will learn to live with the changes in QOL. Physical and psychological scores recover. Sexual scores take a little longer and mostly don't recover. This is the most number of times during a talk that I've looked at the timer because I don't have a timer here.
5 minutes for discussion. Thank you so much, Dr. Amandeep.
Thank you. Thank you.
You have 5 minutes.
Yeah.
Thank you, Doc.
So, I have been favoring, collecting questions, answers, or whatever. So, the one who's asking the questions is very important.
Right.
I cannot ask a CS cervix patient who has undergone radiation about her sexual health.
Yes.
A lady did it for me who was elderly, and she knew exactly what to ask.
Right.
So if there was another resident of mine who did that, tried to do that at least, but they couldn't get the similar answers what the elderly lady was doing.
Right.
So it's totally different. Our subset of patients is, you cannot apply these RTOG,
Yes.
EORTC, QL, all those.
Yes, so in literature, all of these are self-administered questionnaires, but a lot of our patients require vernacular versions of these questionnaires, and even then they would require help to make them understand that this is what we are trying to ask you. Most of the times we ask the question and then record their answer.
No, most importantly, who's asking
Yes.
and how we ask.
Yes.
Most of the doctors don't know how to ask.
I agree.
Because they call up, they say, they just rattle it out like a parrot, and they expect answers. The patient has to think. You don't give them. You send a mail, they don't want to, they don't reply.
Yes, yes.
So,
So we
telephone
have to
call
respect the social thing in our
setup,
society.
when they come to the OPD, we spend about 5-10 minutes. In your setup, it's impossible.
Yes, yes.
So these studies are all vague.
Yes.
And we don't even give some kind of a literature or a form before treatment.
Yes.
What
Next
to expect,
question,
how much
please.
of energy you have, that's vague. I cannot answer.
Yes.
Next question, please. Sir,
Ah.
you're waiting.
Thank you, doctor. I get the figures right. It is only 15% of the post-RT patients required a cystectomy?
Yes.
Is it the figures
Yes,
right?
so the figures were around 30% earlier. The most recent papers, 15%
At
is...
what time it is you're
I'm
talking
sure
time
Virang
frame?
sir, if here is, he would think that...
Time frame of 5 years you're talking around?
Yeah.
Okay. Okay.
Yeah. Yeah.
The other thing you mentioned is that the urinary and bowel scores were similar between those who received radiation and those who underwent cystectomy.
Yeah.
But would there be any difference in terms of temporal profile? When did you measure that?
Yeah, so they were
QL?
they were measured at baseline 3 months, 6 months, like in any other paper. The urinary symptoms for the cystectomy patients were mostly calculated for the patients who had a continent diversion, because for the incontinent diversion there is nothing much that you can really ask them.
It's very ironic that if you preserve the bladder, the QL is the same. And that means the QL questionnaires are not really capturing the real thing. It's very ironic.
Yeah, so these are the limitations that are written at the end of every paper that reports on QOL, that this is what we have, this is validated in other studies, but still we are not really sure if we are capturing what we want to capture. Because what we begin thinking that let's do a QOL study, CT-RT definitely has better QOL than cystectomy, probably does not come out. Robotics definitely has better QOL than open. Is it the questionnaire at fault that is not capturing what we think it is supposed to capture?
Dr. Amandeep, thank you for bringing this important issue and under the discussion. So most of the time as a clinician, we discuss about the updated evidence and think that the patient will live better, longer with all this treatment. But actually, we never had thought about this issue in our clinical practice.
Yes.
We also have a lots of, in our setup, I'm from Kathmandu, and in our setup, it's very difficult to give a time in our OPDs with this patient and discuss about their quality of life and expectation.
Yes.
So I think it is very mandatory that someone, at least in the clinics and the ward, think about their quality of life.
And that is why you use the shortest possible questionnaire, which is the SF8, probably. Yeah.
So I think we need to incorporate our practice, at least in the clinics, to assess about what are their expectations. So thinking about this BCG, I would like to make a comment. I think that the BCG, there is evidence that it prevents recurrence, but how many patients are really benefited from those, and what are their life is being? I am sure this BCG discontinuation, you showed it about 50%. I'm sure it's more than high than the 50%. I have not seen patients who are completed 3 years with BCG. They will have a sepsis. They will end up in the ICUs with all those anti-tubercular treatment and all. So I think this part we need to discuss in details, and at least not in OPD setting may not be possible, but in a ward setting, I think we need to have this QOL assessment.
Agree, sir.
I think I disagree with you on the BCG 50% discontinuation rate, but that's a discussion for a later date. I don't think it's that high, and the BCG complications are overrated than what I think time is out, we'll discuss later.
Thank you, Dr. Amandeep Singh Arora. I would like to invite...
last question.
No, sir, I'm sorry, I cannot allow. We are already 5 to 7 minutes late. You can discuss at the tea time, in the tea break, sir. May I request Dr. Mahendra Pal, who's a professor uro-oncology from Tata Memorial Hospital, Mumbai, And he'll be speaking on optimizing surveillance protocols in bladder cancer for India. Over to you, Dr. Mahendrapal. You've got 9 + 6 minutes. Thank you.
Thank you. So, optimizing the surveillance protocol bladder cancer in India. And as Amandeep said very well, by this strategy, we are making patients to live longer with good quality of life if we adopt adequate and effective surveillance for any cancer. So what do an oncologist wants during the surveillance? Like no recurrence, detection of early recurrence, the side effects of the treatments, good health of the patient, good functional status, and good quality of life of the patient. But in reality, what do our patient need actually during the surveillance? Is it an assurance, safety and reliability, accessibility for the healthcare, minimum discomfort, low cost, and definitely a minimum travel to go for the surveillance. Hurdles in India, a vision factor, heterogeneity in the guidelines-based following up or expert opinion, patient data, quality of medical care is not this equal everywhere. Patient factor, adherence to the advice, the compliance, demography, geography difference over the country, cost factor, another that we really do not know because we do not discuss all these things with the patient. So coming to non-muscle invasive bladder cancer, that generally focuses on the disease progression and the recurrence, and maybe the side effect of the BCG related treatment. As we see all the guidelines have a similar follow-up schedule for the low-grade cancer and as well as the high-grade cancer, but none of the guidelines define exactly what is intermediate risk. And as per the follow-up, as we can see, there's always all weak recommendation, and for intermediate, we don't know how to follow up, it should be individualized. And for high-risk patient, it is yearly after the 5 year, but how long? It is lifelong for 30-year patient or lifelong, or maybe it has some time frame for that. This article, when it go through the low-risk NMIBC, and it concluded that there is an overuse of scopy in about 3/4 of the patient, and the patient care and having tumor comorbidities and earlier diagnosis, as well as multifocal tumor are associated with the overuse of cystoscopy, and they concluded, and they also raised the concern about the bladder cancer surveillance cost and the quality in the low-risk NMIBC. This retrospective study of 428 patients which focused on the high-risk NMIBC, and what they did, they, as per the EU guideline, they followed the patient for 10 years, and they proposed a follow-up schedule which was almost equal with the recurrence rate and the progression rate as well as the EU guidelines, and they proposed a little bit stringent follow-up for the high-risk NMIBC and with the highest risk NMIBC. What they did, for the cystoscopy and other follow-up, they modified compared to the EU guidelines, and they have some intense follow-up initial period where has the highest risk of the patient, and along with the reduction rate of 40% the cost of for the patient. And they concluded that this certification of the highest risk, high risk NMIBC could potentially reduce over investigation during follow-up and improve surveillance cost for the patient. This again, a recent article 21, follow-up in the non-muscle in the cancer facts in the future. They concluded that follow-up in MIBC is too frequent with low level of evidence and suboptimal tools, and this article focused about the one which never discussed is the patient unfriendly and the costly aspect in the guide, which not in the guidelines. And again, they say urinary markers have been around for decades, but still they are not a gold standard which can replace the cystoscopy. Again, if it's the cost, as we can see that high-risk NMIBC has the highest burden of the cost as well as disease progression, and this article concluded that it would be prudent for us to lower the intensity of the surveillance for the lower-risk NMIBC, but it should not be compromised the outcome of the high-risk NMIBC. So my point of view, session for the NMIBC, a surveillance point of view, the number of follow-up cystoscopy should be needed to be reduced, at least for the low risk and few percent of the high risk or intermediate risk of the patient. Maybe the 3 months annually, then 5 year, or maybe less for low risk. High risk 3 monthly can be done, but for how long? Cytology, it should be in each visit, that we do not know. Intermediate risk should be individualized, because again, we do not know the follow-up schedule for the intermediate, other than the NCCN guidelines, they had, but other guidelines don't support those schedule. If we certify the highest risk NMIBC, maybe it will affect the cost and the follow-up schedule, and the biomarker may replace the scopy in the future, but it needs more validation at present. Now coming to the cystectomy, condy or the neobladder, that generally focuses on the local distant recurrence, the upper tract effect, either recurrence in the upper tract or the functional outcome, metabolic and functional issue with the neobladder and the condy. What we should focus on again in this aspect is the rehabilitation, which I think Dr. Gagan, Dr. Amandeep will be agree that this improves the quality of life. And all the guidelines again have the same protocol with the 3 to 6 month year imaging for the 2 year, and every year they should have a LFT and the biochemical and the blood test investigations. This article specifically compared the detection rate with the NCS guideline and the EO guidelines. And if you can see, EO guidelines has 20% more detection rate compared to the NCS guidelines. And they quoted that the patient older than 80 years with T0NX disease, which would not die with the cancer mortality, compared to the age of 60 years of the patient who is having T4 or T3 disease, he should have more stringent follow criteria compared to the 80-year-old patient. It should be the same for all the patient. So what they propose that a surveillance algorithm based on the interaction between the recurrence rate and the competing health factor should be utilized when proposing a follow-up for these patients. Again, the topic on the optimal delivery follow-up care, as Amandeep said, it takes at least 1 to 2 years to see the rehab of the patient after the cystectomy, along with the recurrence and other things, which include physical training, nutrition supplement, and patient education of stoma care or the neobladder care, and it has a level 1 and level 3 evidence to support this care for these patients. This article specifically stratified the MIBC patient in low risk, intermediate, and high risk patient, and they give a scoring system based on cardiovascular disease, peripheral CKD, type of diversion, and TNN, presence of LVI. And what when they divide it into the low risk, if you can see, the follow-up schedule is just like a MIBC, maybe the low grade intermediate risk of the patient. High risk, however, is similar to what are proposed in the guidelines. And they propose that risk score stratified surveillance protocol has potential, it is not proven, but has potential to reduce over-evaluation after cystectomy without adverse effect of the medical cost. So what my take on that, EUA protocol has a better recurrence detection rate compared to the NCS guideline. Age at treatment can be used to determine the frequency of follow-up. Initial 2 years are very critical to assess recurrence and the functional improvement. After 2 years, it can be individualized based on the patient factor and the disease factor. And sub-certification may help reducing follow-up schedule without affecting cancer care at the individual basis. Coming to trimodal therapy, which focuses on local distal recurrence and the upper tract, definitely metabolic complication is not with the trimodal therapy. And the follow-up is almost similar with the MIBC patient, other than cystoscopy every 3 months, 6 months, and annually. And the clinically indicated, as well as the imaging as per the guidelines. This article from the Tata Hospital proposed that if we do cystoscopy, either every visit 3 monthly, or every 6 monthly, or when there is a doubt of recurrence in the bladder, and they found that there is 64 and 67% finding rate if we do either alternative 6 monthly or when doubt is of the recurrence. And they propose that it may replace the imaging follow-up for the post-trimodal therapy. But again, we do not have very much evidence on the trimodal therapy, how to follow up other than the guidelines and how to modify it. But I think that MIBC protocol should be followed over there, and cystoscopy along with the CT scan or other imaging may be detected with a better cancer detection rate compared to the only scopy alone. This article generally focuses to find out the cost of the follow-up patient with the cystectomy as well as trimodal therapy, and they found that the outpatient visits post-operative period are the main factor which are affecting the patient and increasing the cost for the patient. Future, the EuroFollow trial will tell us something about the less intense follow-up, but again, it is focusing on the low grade, not on the high grade and the intermediate risk that we do not know how it's going to help us in future. So if we again think and see the hurdles in India factors, so I would like to just conclude. This is not take-home message. This is just suggestions about that. For NMIBC, individual adaptive approach may reduce number of follow-up cystoscopies, For MIBC, initial 2 years are critical for oncological, functional, and metabolic assessment. Precursor system may help to define better surveillance strategies. For TMT, MIBC protocol plus the cross-section imaging may improve the detection rate, frequency that we had to define. And assessment of cost-benefit ratio for the patient point of view should not be ignored. Euroflow follow will guide us, but for low risk, we don't know how it's going to affect. But we should have urgent need study focusing on optimizing surveillance protocol in our India, keeping patient factor to reduce the health resources and the patient burden in our country. Thank you.
We have 5 minutes for discussion.
Thank you, Dr. Mahendra Pal. So most of us are following the Western guidelines. So whatever they say that 3 monthly, we told patient to come after 3 monthly, but our patient is very different. So they has to travel a lot, and we need to consider the economical factor and their social background. So you told us that this intermediate risk is individualized. Can you highlight some of the points? So whether they go into the low risk category and infrequently cystoscopies, or they go into the high risk? What are those factors?
So by definition, we do not have exact factors for the intermediate risk. Yes, it's about low risk. It is a TAG1 is a low risk. High risk, T1, NEG3, CIS is the high risk. But what comes in this intermediate risk, even we do not know. If you ask me that this patient in category, I will take 30 seconds to think about the category it is, right? So again, we should know, and about the follow-up schedule, it also be individualized. Maybe for low risk, it is 3 monthly, 9 months, and annually. And for high risk, it is a 3 monthly for 2 years. It may be 4 monthly for 1 year, maybe like that. Even we don't have guidelines, but we can individualize at the patient basis. Where does he stay? Like that, he's coming from bus, from the train. What his profession is, whether he's able to bear the cost of the follow-up. Everything we have to think about before putting him in intense follow-up for the intermediate risk.
Mahendra.
Yes, sir.
Here. In tri-modality treatment, after tri-modality treatment, you said imaging and cystoscopy. Now, recently what I have seen, because many patients, they do get tri-modality because cystectomy everybody avoids. The patient is followed by PET scan. And PET scan does show the uptake in the bladder, and you do the cystoscopy, there is nothing. Probably you can resect that area,
yes,
and there may be nothing. So what is your take on, or maybe other like in crowd who are doing tri-modality, what is they have their experience? But my apprehension is always that if the patient fails, because of that uptake in the PET scan, he actually can, come back to you and saying that you did not diagnose or what happened. So, what is your this?
Yeah, so sir, in this case, when the PET scan is done after the radiation therapy, either it is within 3 months, within 6 months, or within a year, and urine cytology report, if it is negative or it is positive, I think these two factors will decide to do scoping or the biopsy or not. But if there is a persistent, and maybe we can also follow up after 2 months of the PET scan. If it is still AVD area is there, then we should have a biopsy, because we do not know it is a disease or just inflammation. It should be individualized. There are no guidelines about even PET scan is not recommended. I don't know why it has been done also. Yeah.
See, I'd just like to share my personal experience. I have my follow-up of my treated own patients, both groups, for 15 to 20 years. So first 2 years are very crucial.
Yes, sir.
In that period, we follow what you said. After that, it is individualized.
Yes, sir.
That is my practice, and that is I'm doing.
Thank you very much. I just wanted to emphasize in the post-cystectomy one, there are the 3 things: upper tract deterioration. For whatever reason, in Christie Hospital, we used to do a MAC3 renogram for every year for these patients. And what we picked up was 30% of post-cystectomy ileal conduits would have a deterioration in the renal function, out of which 30%. So overall 10% would have an obstructive cause. So always consider doing a DTP renogram or a MAC3 renogram for upper tract assessment. That's one. Second, for the urethral recurrence, we used to do a flexible urethroscopy, but that we replaced with just saline barbotage of the urethra, and we know that that's good enough. And which ones you do more intently depends on your pathology element of it. And then the third aspect with respect to the recurrence of the primary, there would be the systemic recurrence and local recurrence. And with all the adjuvant treatments we are doing, especially RT,
The local recurrences we can control, but the systemic will be with the CT or a PET CT scan, depending on whatever patient can afford. Thank you.
Right, sir.
Mahendra, I had one comment. What about this flexi cystoscopy? Is it overdone? We are talking about it more often than required, or it's not the answer actually?
Sir, if it done as per the schedule, so it is just a method to see the bladder for the patient comfort level. But I don't think so. Nobody is using monthly basis or something like that. It is just like as per schedule, it's a comfort level of the patient, and it's proposed like it's about comfort for the patient.
They say it's an office procedure.
Yeah.
I mean, that's the problem sometimes. If you find there is a tumor, then you have to take to the OR.
Right, sir.
Yeah, that's the problem.
Basically, most of the European studies also what they've done is previously they used to do sort of bar test or cytologies to find out if it's positive, but they're scheduled for a flexible cystoscopy outpatients. There is a parallel theater which is available. In case if you find, then you put it to sleep and do it. No.
Sir, I think only biopsy they do in the day-care procedure, not the TURBT.
No, we keep this theater standby ready. If you have found out, then do it. So it saves the visit.
Yeah.
Thank you, Dr. Mahendrapal.
Thank you.
And I would now like to invite Dr. Amit Rautan, who is a consultant medical oncologist from Manipal Hospital, Bangalore, to talk upon upper act urinary cancer for adjuvant versus non-adjuvant therapy. Over to you, sir. You've got 9 + 6 minutes.
Thank you. Good morning, everyone. So my topic is upper tract urothelial cancer, adjuvant versus neoadjuvant therapy. So we know the challenges we face in the upper tract urothelial cancers. It's a rare disease, seen quite uncommonly compared to urothelial cancers. If you compare stage by stage, the prognosis is definitely poorer than the urothelial cancers. We face the major problem. The exact staging is something we always differ about. We're never sure about what we are dealing with. Is this the exact stage? Because we're never able to get muscle in the biopsy. And so that's quite a times we treat these patients even with cytology reports saying that if you have a high-grade tumor, they're high-stage disease. So this is always a problem which we face in upper urothelial tract cancers. There's always the major issue we talk about, renal dysfunction, which will set in after surgery. And we've seen various studies showing various declines in renal function. And again, a small population, so data is small. Whenever you have smaller data, you're never sure what you're telling your patients. You cannot tell them emphatically that this is the results. And you always kind of put it, this could be the positives and this could be the negatives, and then you take a decision. And that's what happens in clinical practice. So I will do the same as what we do. I will tell you the positives and negatives, and all of us can take the conclusion the way we want to. So if it's adjuvant chemotherapy, the advantage, clearly, you've done a surgery, you know the exact stage, you know what you are treating. You know you're going to treat only your high-risk patients, your low-risk patients you may get away without giving them and exposing them to any chemotherapy. And the best thing is you have a robust data. You have a big phase 3 trial, which is amazing to see, which was done in this rare indication. The major disadvantage, we've seen, you remove the kidney and you do a nephrourectomy, you're definitely decreasing the GFR. There have been studies which said that it came down from 58% to 15%, the eligibility for a cisplatin-based regime in various studies. Again, this is kind of an overkill, I think. It doesn't happen that much, but definitely there's a decline in GFR, and we know that cisplatin eligibility may change. I think this is one of the most elegant studies in this setting, the POUCH study. It was a perioperative chemotherapy versus surveillance in upper tract urothelial cancers. Now, this study was done over in the UK. They looked at patients who were upper tract, who operated. They looked at PT2 to PT4 or node positive patients. So they said these are the high-risk patients who need adjuvant chemotherapy. Before this, the standard of care was surgery followed by surveillance. So they randomized surveillance versus chemotherapy. And the chemotherapy used was gem-cis or patients with gem-carbo. Now here was the inclusion. They actually reduced the GFR to 50. So we in practice say 60 is our cutoff for cisplatins, but they said we can even go down to 50, which is good, which enables more patients to get cisplatin. And they said you could sometimes, if you're not sure of it, you can even do split cisplatin dosing, which we do in practice quite a lot. But if it was below 50, between 30 to 50, they said we could use carboplatin, and gem-carbo was the regime. 4 cycles adjuvant. Primary endpoint, disease-free survival. Secondary endpoint, metastasis-free survival and overall survival and quality of life. A clear improvement in disease-free survival. I think there's no denying the fact, if you look at that 3-year mark, 50% versus 71%, hazards of 0.51. There's absolutely no denying there's clear benefit in disease-free survival by doing adjuvant chemotherapy of 4 cycles versus surveillance alone. Metastasis-free survival, again, a very clear benefit, hazards of 0.52. Which subgroups benefit? And this is important. And what we saw eventually, every subgroup benefits. So clearly, there's every patient benefiting when you're doing adjuvant chemotherapy in this subgroup, in this population. The right side curves are overall survival. They are numerically better. They didn't cross statistical significance, but then again, that was not the primary endpoint. So clearly the conclusion, adjuvant chemotherapy, gem-cis, rarely gem-carbo, is the standard of care for patients who have been operated with more than PT2 disease. But we could do neoadjuvant, and bladder we have moved to neoadjuvant, and we extrapolate the same data and we say we do neoadjuvant in urothelial bladders, why don't we do it for upper tract cancers? Advantage, clearly the kidney is there, the creatinine is good, the GFR is good, you can give them the ideal cisplatin dose. You're not going to compromise on anything, you're not going to start talking of carboplatin, which we all know in our minds is not great, but we do it because we can't do the cisplatin. We can see our responses, and we can, after we give the cisplatin-based chemo and when you operate and we look at PAT-CR, we can tell patients, we can prognostify them. There's a subgroup who will do well and survivals are good, or there's a group who did not do well and you can prognostify and say they're not doing well. But more important to me, it's not prognostication. It's only prognostication doesn't matter. I think we are moving to an era where we say, does it predict? And we need prediction. So if we didn't get a good response, I think that's the space where we will talk about escalation of care in the adjuvant setting. Will it come to more chemo, different chemo, or immunotherapy? And I think it's going to be the immuno era that's going to take over. The disadvantage is you're not going to get an accurate staging. You will be over-treating some of your patients. And if you looked at the data sets, there were 10% patients who actually were not malignancies, and they ended up getting chemotherapy, which is non-pardonable, that you're trying to treat a non-malignant condition with chemotherapy. So this is a worry always. So you're going to overexpose to chemotoxicity, and you may not have required it. And the main thing, we don't still have phase 3 data. We just have phase 2 data. One of the phase 2 data sets, this was a neoadjuvant study. Look at the number size. It's just a 57 patient study, which has been quoted so many times. And this is the biggest study. The other study which was quoted is just 28 patients. But this is a 57 patient study. They got neoadjuvant gem-cis. It could be even a split dose cis, depending on the creatinine clearance. They got 4 cycles, and then they undergo surgery. But what we saw, 70% of patients completed the 4 cycles, 89% were able to complete 3 cycles at least. All of them went to surgery, no one progressed, so that's good to know. That's what we worry about. We give chemo and the patients progress, you lost a chance of cure, but that's not happening. 63% patients had a pathological response, and pathological response is less than PT2. 19% patients had a complete response. That's what we always want to achieve as oncologists. When we see YP T0, N0 is something we always love to see. But what is important is these curves. If you see the left side curves, at 3 years, the 2-year PFS was somewhere about 78%, 2 years OS 93%. But that's not the great part of it. The great part is the right side curves. You can clearly define those two populations of patients. Those who get pathological response, less than YPT2, you see their survival is clearly up there. And those patients who had more than YPT2 residual disease, their survival is clearly lesser. And of course, if you had PAT-CR, nothing better, their survival is right flat on top. And that's the whole advantage of neoadjuvant therapy. You are prognostifying your patients, but you will move further to the next level and you'll start using this as a prediction tool to say, can I do something better in the next steps? But whatever we say, whether we do adjuvant or neoadjuvant, chemo is there to stay in upper urothelial bladder cancer. All of us have accepted this, but we move forward. A quick meta-analysis. This is all about studies pooled together. Again, I don't think you can really compare meta-analysis. It just says that it is really advantageous. Neoadjuvant chemo does do better, but adjuvant chemo does better with better, robust data. So I think all of us know the advantages and disadvantages. So we do chemo, but what we do more, and this is where we have moved to, immunotherapy is here. And we saw this and we discussed this yesterday, the Checkmate 274 for bladder cancer, adjuvant nivolumab for 1 year after your treatment. Those were patients who got neoadjuvant chemo, had more than PT2 disease, had surgery, and then 1 year of nivolumab, or those who were unfit got surgery and then have more than PT3 disease, they all got adjuvant 1 year nivolumab. And we've seen the data set. We've seen there's a clear improvement in disease-free survival. The hazards are clearly significant, and it is approved. And I think all of us have started using it for our high-risk patients. Of course, the PD-L1 population did even better. So why don't we extrapolate it to all patients of upper urothelial tract cancer? It's there in the trial. It was done. And if you look at the forest plots, every subgroup of patient in this trial benefited except one subgroup, and that was the upper urothelial tract cancer. And if you magnify it on the right side, that population did not show benefit to immunotherapy, and that kind of beats us. It should not be happening. That's not what we expect to happen. For two reasons, I didn't expect this. Upper urothelial tract cancer is the ones you actually expect maximum to be Lynch. That's where, and for us, Lynch and MMR deficiency in cancer, in medical onc has become any cancer anywhere in the body, MMR deficiency, give them immuno and they will work. To the extent that in rectal cancers, MMR deficiency, you give neoadjuvant immuno, you're not operating them, you're not doing anything, you're just observing them because you get such a high PAT-CR rate. So this amazes me, but I think we haven't read the whole text, so we will know what segment was Lynch in this, and I expect there will be nothing in Lynch. Otherwise, this would never have come out this way. But again, is it the biology or is it just the numbers? And I think it could just be the numbers, but we'll see with more data coming out. So my last slide, I think chemo is here to stay. Whether you do neoadjuvant or you do adjuvant, you will have to nuance that decision according to your patient population and your patients, what you see as in your practice. And I think it's the uro-oncology surgeons who are actually going to take that decision, what they think, which site they're going to put their patients into. There is a randomized trial which will report, and that will probably give us a clearer answer. I think we are looking at further approaches. Biomarkers are getting more and more important. I further think post-neoadjuvant, using tools to understand which patients will do further better and which require further escalation in treatment is important. And I think the era is going to change. I think this is the last year we'll be sitting and debating this. Immuno is going to make a space. It's moved from palliative stage 4 setting to the adjuvant setting. And if you've seen, there are already phase through neoadjuvant data have already started reporting out. And if you see the PAT-CR rates, they're so amazingly high that we will be integrating immuno into the neoadjuvant space, and all these trials will become the base of our treatment, but eventually it will really move forward. Thank you very much.
We have 4 minutes for discussion.
In our experience, what you have told is very correct. The adjuvant setting, the chemotherapy works very well. But in the neoadjuvant setting, most of the high volume tumors, they have a very poor outcome. But the low volume tumors in the upper tract TCC, they do better. So do you like to advise us what should be the best procedure if the high volume tumors can be proceeded with the surgery and they are subjected for the adjuvant chemotherapy?
Ideally, if you look at the phase 2 data sets, it's the high volume which will actually require the neoadjuvant chemo, and that's the one you can downstage even better. So I think a good, well-given GemCis does work well. But yes, we clearly agree GemCis is not the best in the present era. We need to get better than this. At least the phase 2 data clearly shows all the patients they took in, everyone responded. No one progressed, and they all went to surgery with some of them having good response, some of them not having good response. But this is something that all of us will have to see whether we are able to adapt for our patients in practice. Okay. The giving of chemo becomes an issue, and that sometimes changes our results.
Okay, thank you.
Gil here. Thing is, we always prefer to have a neoadjuvant in the upper tract setting, but the limitation for us is to get a biopsy. So are you happy to have a neoadjuvant with a radiological picture or at least a cytology, or you are telling that I have to get a biopsy? Because as a surgeon, we are concerned about chance of perforation, then migration, seedings, all these things when we are doing a biopsy. And we don't know whether the biopsy aspect can be a factor in the outcome finally. So are you, will you give a neoadjuvant without a proper biopsy with a cytology or with a radiological picture?
So we are doing that for upper urothelial. I think that's the major issue. There was a time when we used to say, no, let's try to get a biopsy, but it's impossible. We eventually understood that you're not going to get it. We are okay with radiology plus cytology. And we know
If cytology is not there, there are definite radiology, will you give
So we have done it. We do it in practice. The reason is there are sometimes you extrapolate a little bit of settings, but you eventually we have done it. But ideally it is radiology plus cytology. That's the one we should take up.
I think the thing said, biopsy is must. If it is low grade, there is no role of chemotherapy. You are unnecessarily subjecting the patient for chemotherapy. If it is high grade, there is no need to having muscle invasion and all. In upper tract, you don't see muscle invasion. High grade, go ahead with neoadjuvant chemotherapy, provided the kidney is okay. Yes. If the kidney is gone, there is no point in waiting. You just remove the swab and then give adjuvant chemotherapy. That's what we do. And there is an article from Surana Matin from MD Anderson. Way back before pandemic, where I used to go to MD Anderson at that time, and he has published a lot of cases in this segment when he suggested for NACT in such patients who have got good kidney function and the high-grade disease.
Right.
Last question.
Yeah, so, that's the way we are moving. That's neoadjuvant for those specific patients.
So in bladder, we know that carboplatin is going to be inferior to cisplatin in adjuvant setting. It's the same biology, I'm talking about pure bladder, it's the same biology in upper tract TCC. Then do we also correlate, though we don't have a robust data, but do you think that carboplatin is definitely inferior in upper tract setting for adjuvant compared to cisplatin?
Yeah, I think we are extrapolating the same data. We
so
say carbo is inferior.
Then in that case, why not to use neoadjuvant in high grade, obviously, malignancies to the more, obviously, why are we waiting till 2023 for having randomized trial? What's the caveat?
So we were waiting till 2020 to even say adjuvant chemo works in upper urothelial. So once we accepted chemo works, then we started moving to the upper.
So one quick thing then, given a choice, you would prefer NACT over adjuvant in another couple of years' time in future?
So I would, that's the reason why I put all those advantages, disadvantages. I don't think one can make an absolute one statement and say, for all my patients, I will do this. I don't think so. I think it will be a much more nuanced approach, but there is definitely a place of neoadjuvant chemo for upper urothelial. I would say yes.
Thank you, Dr. Amit Rautan. I now invite Dr. Makarand Kochikar, who is a consultant uro-oncologist from Meerut, to talk on upper tract urinary cancer, which is open versus MIS, lap, and robotic approaches. Is one better than the other? So you've got 9 plus 6 minutes.
Thank you very much. At the outset, I would like to thank the organizers, and the greetings from both the hospitals is a recent one which we started about a year ago. We are talking about upper tract urothelial cancers, and we do mean that is coming from either renal pelvis, ureter, or intramural portion of the bladder. We are not talking anything about the conservative treatment. I think the mainly focus we are talking about what's the gold standard. Is it open or a laparoscopic or minimally invasive? What is important is I think we have to understand the biology is not the same as what you get in a bladder cancer. They're mainly high-grade, high-stage disease. It's an aggressive disease. So we are dealing with something, a disparate cuisine as compared to a bladder, and so we have to be very, very aggressive. And obviously, because there is a high chance of recurrence in the ipsilateral kidney, frequently multifocal and contralateral kidney, less chance, that's why we do standard radical nephroureterectomy. To my mind, whosoever does it, either open or minimally invasive, I think you need to take a bladder cuff. I think important that we miss out on lymph node dissection. We should not compromise on that. R0 is essential, and do not violate the oncological principles. So whichever technique we use, I think we should have these kind of factors very, very important. So why are we dismissing? We all know the cosmesis, the blood loss, recovery, post-op recovery. So minimally invasive is better than open. But why we are discussing? Because as I said earlier, it's an aggressive disease, needs a radical nephrectomy with a bladder cuff. Many times in the practice, we do see a residual stump. And we also see a spillage during surgery, high chance of bladder recurrence. So we need to have a technique right. Lymph node dissection is not done in many situations, which is an important factor. And nowadays, we talked about just NACT. We are doing radical nephroureterectomy post-NACT, so this can be a challenge. So let us find out which technique gives you R0, also gives a better outcome in terms of recurrence-free survival, cancer-specific survival, and also important is a bladder cancer recurrence-free survival. I think many studies do not look at that. And we all know about morbidity and cosmesis. We are not discussing here that. So let us look at the techniques as a comparison, and then we talk in few slides about the outcomes of different studies. So techniques, what we have, a standard. We have open surgery, like a midline incision, like we do for a cystectomy. I think you can get a good sort of a complete nephrouretrectomy, take periureteral tissue along with this, and a bladder cuff is extremely important. And I think I repeat and say we need to do a good lymph node clearance. That's on the left side, that's on the right side. The extent is already been dissected and decided in many studies, so we have to follow that. Sometimes we do a prostatectomy along with that also, and I think midline incision helps that. This midline incision, transperitoneal, in elderly patient always gives us to a sort of a prolonged recovery, ileus and other things like a cystectomy. So what you can do is we can do a total extraperitoneal dissection. Do an hockey stick, something like a transplant, get an extended like a pediatric nephrouretrectomy, but important that you take a cuff of the bladder, and also important that you do good pelvic lymph node dissection. Many times in the past, we used to do 2 incisions, one in the loin, extraperitoneal, and then take, this is a huge sort of a cuff of the bladder has been taken, so you can do a midline incision. So this again can be done extraperitoneal. Previously, we used to do something like, TUR resection of the ureteric opening, and sometimes we used to do an incision around the ureteric opening and try and do something like a plug. But this is useful only when you do not have much disease in the lower ureter. And I think if you have an extensive disease in the ureter, this technique is not going to be useful. And again, prolonged catheter, leakage, lymphoria, everything used to be there. Now let us come to the lab. Standard. Now we do lateral position, do transperitoneal, but I think the distal ureteral management changes. You change the position, exploration through the retrieval incision to complete the sort of position in the bladder. I think these are things we have to address in lab. Many times we have found that you just put small clips at the vesico-ureteric junction and you do have small stump and a recurrence there, and the lymph node dissection is not done properly, and this is a big, big concern. Now managing the distal ureter with a bladder cuff without the spillage, I think that is what people talked about. When we talk about resection of the ureteric opening, that is what not people wanted to. The first technique was established by Indy Gill many, many years ago, and what he did was during lap nephrectomy, the dissection of the upper and middle ureter was done, and he actually put a needloscopic sort of small port, 2 small ports into the bladder to get sort of a read of sort of intravesical portion, technically demanding taken a bit of a longer time. Subsequently, a good friend of mine, and we worked together many years for different ideas, Dinesh Agarwal from Melbourne, Australia, he presented his work way back in 2008. And this was all sort of born out of the discussions we had many times. First thing is what you start with the cystoscopy, then you do a ligation of the ureteric opening and the release of the distal ureter by in lithotomy position. Then you do a lap nephrectomy in a lateral position, and then again make it a flat position, small incision in the iliac fossa, and then sort of retrieve the specimen, and then close the bladder. This is how it was all discussed. So what it was, you actually sort of put here a loop here by resecting here, close the ureteric opening, dissect it out, using the endoscopic endo loop there, and this was the whole idea even came many, many years ago. Me and Dinesh worked with Dr. Gaur with the laparoscopy, retroperitoneoscopy many, many years ago. And years together, we have done a lot of sort of work on sort of different techniques and in nephron-sparing surgery, as well as sort of upper tract ACC. Now, subsequently, he has come out with another technique. And this technique was another loop, which was made by an Olympus company. So what you do is basically you resect it, put a sort of a loop around here, and then sort of release everything. And there's also a cutter here where you can sort of cut that sort of loop here. He has published a long-term sort of an outcomes because technique is one we talk about. So we said, let us look at sort of a different sort of studies. So this was done in Australia. And almost in 76 patients, it was found that it's fairly good sort of technique. It minimizes the tumor spillage. So I think this is one technique you can think about to avoid the spillage itself. And in this study, they compared the endo loop as well as poly loop. And I think this is a wonderful idea in minimally invasive surgery. Yes, I think people who are expert in robot, I think the only thing is you have to dock the robot probably right angle to the table, and you can do it in one incision. And this is on the right side, this is on the left side, perfectly possible. You can get the kidney here, dissect the whole kidney out, everything is in front of you. And here, basically what you can do is you go around the vesical pedicle, isolate the ureter, and actually tent. You bring the ureter out, you take a stitch around the detrusor, so you can include the intravesical portion and stitch it. So you really don't have to sort of go into the pelvis to do or change the position. So that is the biggest advantage. But what is important is avoid opening of the urinary tract, avoid sort of direct contact, and also take the entire specimen in one organ bag. Now, talking of this conservative treatment, what I could think about is distal ureterectomy. Again, if you talk about minimally invasive versus open, do a good job. robotic, minimally invasive. You can do this distal uretrectomy for a conservative line of treatment, do a Boari flap. But I think the lymph node dissection is important. And also for a conservative treatment in a solitary kidneys, like you do segment resection, there is not much difference between open and minimally invasive. And again, I repeat, what is important is a lymph node dissection. That is extremely important here. And these are the different templates for the lymph node dissection here. Now let us look at the outcome. This is important. So we talked about technique. Now we talk about the outcome. Is one better than the other? There was one paper which came from Ghulam Nabi in 2012. And he looked at all observational studies and also sort of open versus minimally invasive. There was one only RCT, lap versus open. And this was way back, almost in 2009. The study was very small, just had more than I think 40 or 50 patients there. The outcome was, basically there was not much difference, less blood loss, discharge from the hospital was early. I think there was no statistical difference. And what is important is the bladder tumor-free recurrence were almost similar in both the studies. They also have many observational studies from 2002 onwards. What they say is blood loss is less, the hospital is still less. But we know all about it. But we are not interested in that. What is interested is whether it reduces the recurrence and you do a completeness of the surgery. This was 2019, one paper of sort of comparing open, laparoscopic, and robotic. And they had about 161 patients, 137 patients, 124 in all three arms. And what was found that the surgery type was not significantly associated with the cervical outcome. So this was another study. What is important is also this study did not show any increased intravascular recurrence as shown in other studies. This was World Journal of Uro-Oncology in 2021, open versus laparoscopic. And what was suggested that there were about 18 articles, nearly more than 6,000 patients. And what they found that the laparoscopic surgery or robotic surgery almost like similar oncological outcomes, even in locally advanced disease, because it's not something non-locally advanced disease. This is robot versus laparoscopy systematic review, and there was no sort of comparison, no sort of a difference in the outcomes itself. Last one, this is a multi-center, multinational propensity score matched analysis. And what it did suggest that almost like 2,756 sort of propensity score match patients, a total of 2,400 patients. And what was important here, there was a worse bladder cancer-free survival in patients going minimally invasive surgery. So this was one paper, I'll go back to this paper, just presented just about a few months ago, and they found that minimally invasive surgery, I think the chance of bladder recurrence-free survival is high. But we need to find out, is the biology of the disease, is it technique, or what it is? This is extremely important. And this graph shows bladder cancer recurrence-free survival was poor, and this is almost similar survival. No study has looked into quality of INU. I think if you want to take it from here, I think we have to look at all those techniques, open, lap, robotic. I think we should look at how do you take bladder cuff, lymph node, residual stump, and RCT is long overdue. So to conclude, friends, it's extremely important to have complete nephrouretectomy with the bladder cuff. It's a rare disease, aggressive disease, whichever technique you use it. There is no difference in the outcome except one study which has shown high bladder cancer recurrence in minimally invasive. Do not miss out on lymph node dissection, and the outcome will be better if you be aggressive. Thank you very much.
We have 3 minutes for discussion.
Thank you, Markan, sir. So one important part that I was thinking that will come is the intravesical mitomycin C after whether you do open lap or robotic immediate installation. What is the data and outcomes? Would you please highlight that? Because bladder cancer-free survival, recurrence-free survival is one of the thing that outcome that you highlighted. But what was the status of the immediate intravesical mitomycin C installation?
Yeah, I think it's a good question. People have done that. Problem is if you're taken a bladder cuff, and if you're not very sure, especially in the techniques where you have just resected ureteric opening, allow it to heal, in those patients you can't give mitomycin. But if you are completely closed with bladder, there are people who are given in perioperative period, but I couldn't see much data on that, whether it's beneficial in terms of reducing the bladder cancer recurrence. Yes, people followed it, but I don't know how many people in the audience follow immediate mitomycin C for upper tract TCC. Majority of them, as I mentioned, are very aggressive disease. Previously, I mean, we sort of got part in Crow's registry also, Crow's registry. We used to see about 2 or 3 patients, and majority of them were advanced, locally advanced disease. And I don't think that case, I would prefer a systemic adjuvant chemo rather than giving something in the bladder. Anyway, 33% chance that these patients would, 33 times chance that they will develop bladder recurrence. So one perioperative mitomycin would make any difference, I'm not sure.
So during intraoperative approach, also during lab, first attack the artery, or when whatever is there, then go to the ureter and clip the ureter. Because at times what happens if you clip the ureter at the beginning itself, few of the surgeons do clip the ureter at the beginning itself. Hide the ureter, all those things can happen, and the dissection already hydronephrotic kidney, then chance of spillage might be more. Would you please highlight about that?
So basically what you do is that's why you clip the ureteric opening from a cystoscopy below first, and then turn the position, then do the lab.
If that is not feasible, then intraoperatively, once you do mobilize the colon and everything, and you find the ureter there, and
you
clip
can,
that. And
you can.
But problem is that hydroureter might continue.
Yeah, I know.
Dr.
Yes,
Makar,
yeah.
Data on the value of lymph nodal dissection
Yes.
in upper tract is not very strong. You have been actually repeatedly mentioning the importance of doing a complete template dissection. Why do you so tell us? Because there is no real strong data on the...
Understand. Like we are evolving in terms of what's best adjuvant treatment upper tract DCC. We're extrapolating what
This
you
is
get
the
it from the
last
bladder.
question.
Extrapolating from the bladder itself. And again, I repeat and say, I'm sure all would agree this is an aggressive disease. Patients keep on failing quite heavily. And though there is no sort of a standard guideline saying that, you have to follow that, I think in the real practice, being an aggressive disease, it would help you. And if you don't have any adverse characteristic, perhaps some of the subgroup of patients, you may not give them adjuvant therapy, but at least do a good clearance. Thank you very much.
Thank you, Dr. Kochikar, and thank you, Dr. Pavan Raj Chalise, for chairing this session. With such intense deliberations, I think we need a quick break to recharge our mental faculties. So I have good news that we have a tea coffee break, but I also have a bad news that since we've run 5 minutes into the tea break, so I will be cutting short the tea break by 5 minutes, and I would like you to be back by 11:05 when I resume this session, especially the next speaker, Dr. Srinivas Chilukuri, and my chairpersons, Dr. Kannan and Dr. Satyakam. So please be back. Thank you very much.
Test. Check. Test.
Yes, sir. Thank you. There is a bell. I have also announced it's happening. Welcome back after that rejuvenating tea coffee break. And for our next session, I would like to invite as chairpersons Dr. V. Kannan, who's a consultant and head radiation oncology, PD Hinduja Hospital and Research Center, Mumbai. Dr. Satyakam Savaimun, who is a consultant in surgical pathology at PD Hinduja Hospital, Mumbai. I call upon the first speaker, who is Dr. Srinivas Chilukuri. He's a senior consultant radiation oncologist from Apollo Proton Cancer Center, Chennai. He will be talking on management of GG5 prostate cancer, learning from an Indian collaboration. Over to you, sir. You've got 8 + 2 minutes.
Good morning, everyone. Yesterday we heard Dr. Borges speaking about Gleason score, and with all its fallacies and weaknesses, we still use that. I mean, it's central to the most important prognostication for prostate cancers, and it was shown across several studies that patients of grade group 5 prostate cancers have inferior outcomes. And many believe that treatment intensification helps. And I'm sure most of the audience here believe that addition of surgery as part of multimodality treatment helps. But there are others who believe brachytherapy would intensify the local treatment. That could be beneficial. And some believe that we could continue giving the contemporary standards of radiation therapy doses along with long-term ADT, but do systemic therapy intensification. So how common is GG5 in the context of prostate cancers? We've seen if you count all comers, all prostate cancer in the Western setting, it could be around 5%. But if you see in the high risk, this is from the trial of 6 months versus 18 months Australian and New Zealand trial, which showed about 15 to 20% are grade group 5. But if you see the POP-RT data, you can see that about 1/4 of our patients, of high-risk patients, are indeed Gleason grade group 5. So it's not an uncommon scenario at all. So this question was came to our mind, that what are the outcomes and patterns of failure of biopsy-proven Gleason grade group 5 prostate cancers treated with contemporary radiation therapy doses and technique along with long-term ADT. So this was a multi-center effort, and many of the collaborators are in the audience today. 20 cancer centers across India had participated in this study, and radiation oncologists were personally contacted, and they were all have a track record of large experience in prostate radiation therapy. They had a dedicated oncopathology service. They have modern radiation therapy techniques at their disposal, and they were using it routinely for prostate cancers. And they were willing to contribute their data. And these are the different centers across the country which participated in this effort. And this came out as a publication recently in Clinical Oncology. And more importantly, you can see all the collaborators here from different hospitals across the country. So all patients who had non-metastatic disease, whether or not they had node-positive disease, were included, treated with definitive radiation, basically a curative doses of radiation, at least 18 months of follow-up. All of them underwent staging investigations. Most of them, of course, I'll tell you how many of them had PET, but ADT method and duration was captured, radiation dose fractionation was captured, imaging at recurrence also, what kind of imaging was done to assess to pick up a recurrence was also captured, and we anonymized data in RedCape database across these centers, and then the data was collated. The primary endpoint was MFS, and secondary endpoint was BRFS and patterns of failure and toxicities. So we had collected about, the study included about 462 patients. More importantly, 80% of them were T3 and T4. 30% were node positive, and the distribution among Gleason grade group 5 was 4+5 was seen in about 60%, and 5+4 and 5+5, the primary Gleason 5 was seen in about 45% of patients. The TURP before radiation, about 33%. 1/3 of them underwent TURP before radiation, which is probably reflective of our practice in the country. 80% underwent medical castration. Of median ADT duration was about 2 years. As you can see, almost everyone underwent IMRT. A lot of them underwent moderate and ultra hypofractionation. PSMA PET was done in 1/3 during the staging investigations. These were the survival outcomes with a median follow-up of 56 months. 5-year MFS was about 75%. 5-year BPFS was about 73%, and OS was 90%. The 5-year prostate cancer specific mortality was about 6%. This was the multivariate analysis. We saw that primary Gleason pattern 4 had a better outcome compared to primary Gleason pattern 5. So 4 plus 5 fared better than 5 plus 4 and 5 plus 5. Node positive fared worse compared to node negative. Castration had a better outcome as far as MFS and OS was concerned in patients, in all these patients. And you can see that the 4 versus 5, primary Gleason 4 versus primary Gleason 5, there was a clear-cut difference in the curves. We also looked at, do we need the treatment intensification with local RT? I mean, we don't know, but at least among the 115 biochemical relapses we had, and most of these biochemical relapses were imaged with PSMA PET, about 2/3, 3/4 of them, about 77%, and 85% of them had distant metastasis. Only about 6% of patients had local only relapse, signifying that this is predominantly a cohort of patients who have systemic relapses rather than local relapses, which counter-argues the point, do they need really local treatment intensification? The toxicities were quite expected, quite low in the community setting because we were using IMRT, and all these centers were reputed centers across the country, and they were doing high volume work in general. So the strengths of the study was its first, one of its kind, I would say, multi-center collaboration for prostate cancer outcomes in India across 20 centers. All of them gave high radiation doses, near universal IMRT, hypofractionation in about 64%. PSMA PET was used in 1/3 of patients upfront and almost 80% at the recurrence. Toxicity data was also there, but of course it's a retrospective study. We did not use brachy, although most patients were not suitable for brachy. Systemic therapy intensification, now we know that abiraterone helps in node positive cohort. We didn't use that when, of course it's a retrospective study. And central path review was not possible in this particular setting. And we also compared with other studies which used similar doses and similar techniques. And despite having more advanced disease, more number of patients who had T3, T4 disease, much more inclusion of node positive disease, the outcomes were very comparable across the studies for these specified cohort of patients.
So last 1 minute.
Sure. The question is, what happens with local treatment intensification? So this study, again a multicentric study, large study, compared prostatectomy, EBRT and brachy. It showed that EBRT plus brachy was better than prostatectomy and EBRT alone. However, if they compared patients who received optimal EBRT, which is EBRT doses more than 78 gray and 24 months of ADT, there was no difference between EBRT and EBRT plus brachytherapy. Very similar outcomes shown in this study as well. Again, a large retrospective study. Basically summarizing both these studies, addition of surgery did not help. Addition of brachy, it did not help, especially if you give contemporary doses of radiation in these cohort of patients. What happens with systemic intensification? This is a STAMPEDE trial. You can see majority of them are similar to our group of patients. Large number of node positive, large number of T3, T4, and very similar outcome, 75% MFS, just like the standard of care what we used. And addition of abiraterone gave 10% improvement. So you can see that probably that is what we can expect if we add Abi to our group of patients. So the key learnings, this is what my title is, the contemporary radiation results in better control and higher survival. Key is high dose radiation therapy, even without brachy. Primary pattern 5 showed worse outcomes, probably need to reclassify Gleason grade group 5. Patterns of failure suggest that 85% had distant metastasis, and outcomes are likely to better with systemic therapy intensification because of the distant metastases. So I would like to thank all the collaborators who are in the audience, who are not in the audience as well, and especially Dr. Vedang Murthy for leading this effort. Thank you.
We have 1 minute for discussion. One question.
Congratulations, Vedang and Srinivas. It's good to know that it's working, but don't you think, why, I want to ask you, why was MFS as the primary endpoint and why not BRFS as most of the studies?
So we did evaluate BRFS as well, but MFS is more robust endpoint which reflects the real benefit in terms of local treatments. And therefore, that is a time-tested endpoint. And therefore, we chose that as a primary endpoint, although we looked at all of them.
Yeah, I would have put the other way anyway. So you were saying that these are all high risk. You know, as soon as Robo came, we started seeing more of 9, 10, Gleason scores. We stopped seeing 7, 8. It's very rarely, in a year, we might see 5, 6. So that local treatment or local dose intensification is quite important. What is your view on this after doing this study?
So not just our study, I showed the retrospective studies also, that it is important that we go up to 80 gray, 78 to 80 gray. And that is what the studies also shown, that if you give optimal radiation with ADT, is there a benefit with brachy? We don't know. These are all retrospective studies, but this is a fact that if you give optimal doses of radiation, there is very little advantage you get with local intensification.
I have 2 observations on your study. One is that 33% of the patient had a TURP.
Yes.
And now as a local therapy, I have read in the literature from Japan, paper have been published, we call it a cytoreductive bipolar TURP. And this is our practice, patients who have LUTs and enlarged prostate, and we like to do cytoreductive TURP followed by all other treatment what you have suggested. And in your series also you have mentioned, so can you do a subgroup analysis of this 33%? Is there any difference in the outcome or not? The second point is you have mentioned about the orchidectomy. The group has a better survival. So can you also look into that? Because is that the advice now to do a orchidectomy or in front and then you proceed with all kind of treatment?
So both points.
Be very quick with your answers.
Yes. Number one, TURP, we looked at it and we didn't find any difference in outcomes. But TURP obviously is normally associated, one would expect that higher rates of GU toxicities, which we didn't see in this particular group of patients. So the second question is regarding the orchidectomy. Not just us, not just this study, but there are others as well from India, as well as from other retrospective studies, which showed that castration probably had better outcomes in these cohort of patients. Probably reflective of longer term ADT rather than anything else. So yes, that is something which we need to still evaluate.
Thank you, Dr. Srinivas Chilukuri.
Thank you.
We now have a case-based discussion on urothelial bladder carcinoma. And as moderator, I would like to call upon Dr. Bhalachandra Kashyapi, who is a senior consultant uro-oncologist at Deenanath Mangeshkar Hospital, Pune. I would also like to invite all the panelists, Dr. Uday Pratap Singh, who is a professor in urology at SGPGI Lucknow, Dr. Ravi Chandan K, who is a consultant uro-oncologist from Apollo Cancer Center, Bangalore, Dr. Suman Malik, who is a clinical director and head radiation oncology at Narayan Super Speciality Hospital, Kolkata, Dr. Amit Rautan, who is a consultant medical oncologist from Manipal Hospital, Bangalore, and Dr. Badrinath Koneti, who is a professor in the Department of Urology at Rush Medical College and an adjunct professor of urology at the University of Minnesota. He is also the president at Elena Health Cancer Institute, Minneapolis, and chief academic officer for Elena Health. Over to all the panelists who are here.
Yeah. Thank you very much.
So you've got 40 minutes.
Yep. I thank all my panelists and I thank the SOGO for giving me this opportunity. Let's move on to the cases. This was a 57-year-old male smoker, my surgical colleague, presented with hematuria of one episode. Ultrasound and CT showed a right posterolateral wall, 3 by 4 centimeter bladder mass. There was no hydronephrosis. A cysto-TURBT and the GA was done, showed a single large 4 centimeter papillary solid mass close to the orifice but not involved, completely resected. Separate muscle sent for a biopsy. There was another tumor found above the trigone which was also resected. The histopathology, these are the imaging. Right posterolateral wall about 4 centimeter tumor. The histopathology was the first tumor was a T1G3 high grade. Detrusor was present, not involved. The second tumor was TAG2, lamina propria was free, muscle was not present in the second tumor. No other variant histology. As a standard, a restaging TURBT was done at 4 weeks and there was no residual tumor. So young 57-year-old smoker with a T1G3, the question is there a need for an adjuvant therapy and what would you recommend? I'll start with Dr. Uday Pratap.
Hello.
Yeah.
So if you go see that this patient falls into the high risk group actually.
Yes.
So for high risk group, he should get the intravasacular BCG for at least 1 to 3 years.
Okay, fine. Anyone else wants to differ on this? Ashwin? Dr. Konetti? Any different in the adjuvant therapy? That is the question.
But before we go to
yeah,
before we go to adjuvant therapy, I just had a question about any random biopsies done?
No random biopsies. The rest of the bladder was clean.
So no evidence of CIS,
no.
at least as far as we know.
The cytology was also negative, sir.
It was negative. With T1G3,
yeah,
cytology was negative. So that's a concern, right? So
yeah,
now you don't know how to monitor this patient afterwards. The other question is, any lymphovascular invasion on the TUR specimen?
No, sir.
Then I think what you're saying makes a lot of sense. I agree that BCG would be the next step.
So he was discussed about the BCG, but he is very reluctant to take the BCG because of the side effects and the toxicity. He has read about it, he's seen it being a surgical colleague, and he is refusing to take a BCG. What do we offer him now? Uday Pratap.
So standard therapy we see, this is the BCG actually.
Yeah.
So all other therapies, they are the inferior if you compare. But if he doesn't want to get it done, then we have other options, like we can give him novel therapies like gemcitabine with the
Gem-dosi, would you do you use it in your practice?
I have used it because most of the patients, sometimes they have an intolerable side effect actually. So
Yeah,
I have
so
used on those.
you're not using primarily upfront?
No.
Okay.
Right
Dr.
now.
Konetti.
I guess here, I've heard that there's a lot of issues with the Moscow strain, but in the US, for sure, we would do BCG would be standard. If need be, we can always reduce. If the toxicity is too high, it could keep going down.
So in fact, this move has come in USA only with the BCG shortages. You all people moved on to Gem-dosi. So here our need is perhaps we see a lot of side effects. So the question here, this surgical colleague is asking me, why not give me a Gem-dosi? Amit, what would you be your opinion? He needs an adjuvant, everyone agrees. He's very reluctant to take a BCG. So he's reading up and he says, why don't you give me a Gem-dosi?
So there's data about Gem-dosi intravesical,
Yes.
clearly. Maybe for patients who just can't take BCG for any reason, I think it is a reasonable thing to offer.
Yeah, so a lot of novel therapies have come, of which perhaps Gem-dosi is available with us. And there are papers which have shown BCG, this Gem-dosi is useful in BCG naive patients also, as well as the standard of a BCG relapsing or a BCG unresponsive patients. So we have data we can give BCG, instead of BCG, Gem-dosi. And obviously there are advantages as put up in this slide. Oncological efficacy is similar, toxicity is definitely much less with Gem-dosi. Discontinuation rates are less. You can give it immediately, don't have to wait for 2 weeks. Perhaps more, takes a longer time to administer because it takes about 3 hours for the total installation. Availability, yes, little more costly, but again the side effects are much less. So perhaps this might turn and change into the practice. Yes, Ashwin, you want to say something?
Yes, sir. Ravi, sir.
Ravi, sorry.
I just wanted to make a comment, sir. Regarding BCG inavailability, few cities in India experiencing a lack of BCG
Yes.
supply, one thing. Second thing is, if given an option, would anyone upfront go for Gem-dosi in this situation?
That is the question. That is what exactly I'm asking.
Even if they're willing for BCG and Gem-dosi, is it okay that we upfront go for Gem-dosi, keeping
So there is a data on that also. That's what my question is. Should intravesical Gem-dosi replace BCG? Should it be done for all patients, or that is for BCG naive, or should it be done only if they are not tolerating or relapsing or post BCG failures? Uday.
If you say, you must have everyone realize that for last, I think, 1 year or something, I use this BCG, but there are patients lot of getting side effect actually. Even in some patient, in my patient, they have got the small capacity bladder because
Yes,
of BCG.
yes.
So that may be because of new strain or whatever, I don't know.
So you get one patient in your practice and you will think of changing.
Yeah.
He keeps on coming back to you again and again.
A lot
and
of patients.
It's a burden on you. It's a psychological burden. So you always think of that.
Yes.
And there are very well established terms. As I mentioned, there was a good paper by Gagan and his team from TMH. So they have highlighted the problems with BCG, especially with the newer strain, the Moscow strain, in last 5-6 years. Earlier we were using Danish 1331. That time so many issues were not there.
So in last 1 year, I have seen a lot of patients having
So
intolerance side effects.
have you changed to gem-dosi primarily?
Yeah, so I started that protocol in our institute to start with the gem-dosi instead of giving the BCG actually. So some patients are still on that.
So some patients, so this patient was demanding that. So he received 6 weekly gem-dosi cycles, tolerated well, was on a maintenance monthly gem-dose for last 7 months. He's developed hematuria again, was re-evaluated. This time he got an MP MRI done. There was a single tumor, 2 centimeters on the left lateral wall, Virads 2. TURBT was done, there were significant obturator jerks. And this was again PT1G3, but muscle was not present. Now what do we advise him now? Dr. Konetti.
Can I make a comment also?
Yes.
We cannot forget the use of mitomycin. I mean, there's a lot of old data from thin
Yes.
bladder tiles, so let's not just throw
No,
them
we-
away. It is
agree.
useful, even for the first set. And also, because he had large volume high-grade T1, I hope somebody talked to him about cystectomy as being a viable alternative also, even up front.
So
If
we are
BCG is
this
such a bad
situation
thing.
now.
Yeah.
So
now
he's-
I would say he needs his bladder out.
He needs
because
bladder
in 7
out.
months, despite therapy, he's had recurrence.
So
and it's same.
not insisting for again BCG. He has never received a BCG. So maybe I tried convincing him, why don't you take a BCG? It is still effective. We'll try to reduce your dose. We'll try to see how it can, but he's still reluctant. So early cystectomy was also discussed with him.
Sir, I wanted House
Ravi.
opinion that biopsy, because of obturator jerk or any reason, the muzzle was not included. Would we want to go back, look for the muzzle, see if it is involving, if does it make any difference in the approach?
I decided not to go back because I had an MP MRI which was showing a Virads 2. So I took my decision, it's not a muscle invasion. And either way, still an early cystectomy, even if it was offered, he's still reluctant for an early cystectomy. So what options do we have now? So we all understand cystectomy is the standard and the preferred option with its obvious advantages of better staging, trying to avoid the nodal disease and simplifying the follow-up regimen. But how about a radiation therapy?
So
non-muscle invasive disease, I'm putting up a little controversial topic. This gentleman is reading up a lot. He says there are papers, sir. Your talk, your take, Dr. Malik.
For this patient, he is young, 57,
Yes.
and there is recurrent disease after BCG or
After gem-dosi in 8
gem-dosi.
months, yes.
So probably for this case, cystectomy is the preferred option. But definitely, if patient doesn't want to go for cystectomy, there is option for radiotherapy, radical radiotherapy with similar oncological outcome.
Do we have a long-term data on that? Are the radiation therapy techniques any different?
We have data for radiotherapy, but these are not randomized. Few data
There
of
were earlier
radiotherapy
trials, yes.
are evolving with immunotherapy as well, with or without immunotherapy.
We'll come to that, but for a radiation therapy.
That for radiotherapy, yes.
Yes.
Radiotherapy
Along with combination therapy.
Along with avelumab
Vedant,
and
do you have
comparing with BCG.
Yeah, thank you. Vedant, your opinion for a...
Sir, this is the best systematic review.
This was a review.
It is a amalgamation of almost 700 patients, I
Yes.
think. And what is the risk? Why is NMIBC high risk, risky for patients? How is it life-threatening? If you think about it, it is possibly
Chance of
undetected
progression.
muscle
Distant
invasion, undetected nodes. So what radiotherapy is reasonably good at is to treat this muscle invasive component and treat the nodes in about 15% of the patients.
Do you agree with this concept?
I think it's a good concept because many patients don't want a
Yeah,
cystectomy.
majority
many
don't
patients
want.
cannot
Majority
have a
don't
cystectomy.
want, yes.
My only two concerns,
This patient
sir,
is not wanting.
two issues. Post BCG, cystitis can make it radiotherapy very painful for everybody.
Yeah, this is,
I think I would avoid.
This is not BCG.
Second is the expectation after radiotherapy is that the muscle invasive is gone. They will still keep getting non-muscle invasive, maybe papillary recurrences. That radiotherapy will not probably avoid.
Okay, fine. So there is a move to explore the role for radiation therapy in a primary non-muscle invasive bladder cancer. There are a couple of papers, and so this was a recent article published which says pushing the envelope, should we look, and there are 3 prospective trials are already in progress. The PREVERT trial, which looks at radiation with concurrent avelumab. There's a durvalumab with BCG or durvalumab with concurrent radiation, and there's another phase 2 study which is looking radiation therapy with concomitant tislelizumab. We will have some mature data in a couple of years. So there is a benefit, but you need a standardization of the dose. What is given currently is as per what we give for MIBCs. Chemosensitization has shown to improve the results of radiation therapy, and we are awaiting results from good randomized trials. Radiation. So coming to Amit, how about a systemic immuno-oncology therapy? This patient is very keen. I want my bladder to be preserved.
So if he's reading a lot, then definitely
he's reading a lot.
The data is right there. So we have the keynote studies with the pembrolizumab as a therapy for trying to preserve the bladder for BCG refractory disease, and they have defined BCG refractoriness in the both. So we did see the cohort A and the cohort B. We saw both the data sets. But Mark, you can clearly see what you saw at 3 months. We had 40% response rate.
Yes.
At 1 year, it went down to 20%. And that's my worry, you know. As time goes
this was a
by,
long-term
you will go down
follow-up.
to 10%. And then is it really worth it? So this is one setting where I would
So
really
obviously,
not push.
you would discuss in detail with the patient and explain what is shown. We do not have a long-term data on this. It looks very promising in the early phase.
No, but the data is definitely showing a decline in the response rate.
Decline
So
in the
it
response
may
rates.
end up that he will end up with a cystectomy or just maybe a year or 2 later. So it's a little setting where we may not use it.
So coming to the question to Dr. Cornetti, do we really have a long-term follow-up with all these so-called rescue therapies or so-called novel therapies? Cystectomy remains as the standard and preferred, and do we have all these? We need to tell this patient, which I have already told, but he needs to understand that again. What's your opinion?
Well, the other one that you didn't discuss was nadofaragene fludarabine. Right?
Yes.
That's the other FDA-approved.
Yes.
This thing has very similar parameters as Keytruda and the Keynote-257 trial. The advantage is it is actually we have now data we're going to present for 36 months. And the response is a little bit better than the 20% that you're getting with what you saw in
The question is,
Keynote.
are we just delaying the cystectomy in him?
Correct. You probably are delaying this. But if he's one of those lucky 20-30%, you know, the FDA panel said if you have a durable response of over 30%, then that's a viable drug. And many of these meet that. at 12 months.
I think in such patients, we need to be very clear-cut in our discussion and counseling. What is good, what is the long-term results. Obviously, cystectomy still remains. So the take-home message would be cystectomy with diversion gives best results with its inherent morbidity and mortality. Search for alternative options is on, and many promising are there on the horizon. We will come to know in a few years. So this is the second case. This was a 76-year-old male, was evaluated for irritative LUTs and hematuria. Ultrasound CT was done, followed by a cystoscopy, TURBT, and a EUA. These are the images. He also got an FDG PET CT done. There's a large, if you could watch here, there's an FDGA with tumors involving most of the dome with some peri-extravesical extension. The biopsy was a high-grade TCC, both lamina propria and muscle was involved. This is another picture. And his main prior complaint was severe irritative symptoms. Dr. Ravi, what would be the treatment options?
Considering that he's 76-year-old gentleman, and if his performance status is good.
Performance status is fairly good. No comorbidities.
I would go for neoadjuvant chemo followed by radical cystectomy.
Anyone would consider chemo and radiation therapy as a preserving the bladder. Amit.
This decision actually is, I think, more of a discussion, because patients who clearly refuse and say we are not going to end up with cystectomy with whatever the situation.
He's not refusing here. Here he's saying, so my question is, he has a lot of irritative symptoms. The bladder capacity doesn't appear to be very good.
Right.
Would you still offer him a chemo radiation even if he agrees?
No, I don't think so. I think we'd still prefer the other approach.
You would prefer a surgery. Dr. Cornetti?
Yeah, I agree. Given all the other symptoms he has, that may be the best thing. And one could argue, even the question of, I don't know the other parameters, creatinine, etc.
Creatinine normal.
It's all normal. So
no other comorbidities.
Then he may be a good candidate for neoadjuvant. But sometimes some of the older patients, if they have some other issues, hearing impaired, etc., then we probably just go straight to a cystectomy as well.
So this patient received 4 cycles of GemCis, tolerated very well, and there was almost complete response on the PET CT. Again, discussion was done, and now he's refusing a cystectomy. He says, I have got such a good response. These days, people read the PET CT reports. There is a complete response on FD, but I have not put up the images, and he's choosing a radiation. Was it the right decision, Dr. Malik?
This patient probably not that suitable for chemoradiotherapy, but definitely it's patient choice, and if there is no residual disease and patient doesn't want cystectomy, in that case, yes, we can offer for radiotherapy.
So primarily, which patients would you choose for a chemoradiation?
Usually the patients without having any hydronephrosis, not having any nodal disease, and
about the bulk of the tumor, does the bulk of the tumor, the bladder capacity make you change the decision?
Yeah. So when we can do our good TURBT, maximal TURBT, and bladder capacity is
here
good.
It was not possible.
But in this case,
so my choice was the cystectomy. He's declining. Dr. Cornett, you wanted to?
Yeah. One other option is to do nothing. There's actually a randomized trial going on right now, but there's actually good, strong retrospective data, single or multiple institutions, showing that that is an option for some patients. I myself have also done that. And in some cases where the bulky tumor reduces but doesn't go away, you can even consider a partial cystectomy if the patient doesn't want to do. So doing nothing is also an option in observing.
Uday, you want to say something?
I just want to add that if you want to chemoradiotherapy, the renal function should be good actually.
Yeah,
otherwise you won't be able to
he had a good renal function, and he has tolerated a neoadjuvant also very well. So as I mentioned, which patients are not suitable if they are not having a good renal function, small capacity. We also know the optimal radiation delivery techniques. So coming ahead, he comes back 8 months post-surgery and now again has an hematuria with occasional clots. This is 2 weeks duration. He was evaluated, but there is no recurrent disease now. Cytology negative, mild dilatation of the upper tracts. So what should be the working diagnosis now? We have ruled out a recurrent disease.
This is post-RT, sir.
This is post-chemo-RT. He went on to chemo-RT despite I telling him for a cystectomy decline.
We have done a CT.
Everything. No recurrent disease, cytology negative. CT has also been done.
Would want to do a cystoscopy, sir.
Yeah, but what's your working diagnosis?
Working diagnosis would be at this point of time either a recurrence, which we have reasonably ruled out with imaging. The second one is radiation-induced hemorrhagic cystitis.
So the working diagnosis, you're right, was a radiation-induced hemorrhagic cystitis. These were the pictures. So the question is, how do you manage him now? What's your protocol for managing radiation-induced hemorrhagic cystitis?
So the one precaution which I would take while doing a cystoscopy when I'm having a radiation-induced cystitis back in my mind is that I wouldn't over-distend the bladder to begin with. I would keep the flow rate low. The moment we over-distend, it's going to ooze from everywhere and the whole purpose is defeated. So I would keep the flow rate at minimum, not over-distend the bladder. And if there are any obvious bleeding points or telangiectatic vessels, I would want to go fulgurate them as much as possible.
Diathermy or laser, anything, any particular preference here? Does it make a difference?
I'm comfortable with diathermy.
Okay. So you need to look up for the severity of the symptoms, bladder storage symptoms, whether there are any associated clots. So conservative measures like antibiotics, antispasmodics might help. Alpha blockers you may need to give. And as you mentioned rightly, cystodiathermy fulguration will work in milder cases. Any role of sodium pentosan sulfate? Dr. Malik, do you give it as a prophylaxis? I have seen the practice, some of the radiation oncologists give it as a prophylaxis when they are undergoing a...
No, usually don't we give as a prophylaxis.
No role as a prophylaxis. Okay, any role now with established radiation-induced?
Here we can use, consider for giving hyperbaric oxygen therapy in this case.
About sodium pentosan sulfate? We'll come back to that later.
Yeah. Yes.
Would you use sodium pentosan sulfate?
Yeah.
You use it. Do you feel it works?
Doubtful.
Dr. Conetti, your experience?
No, I don't.
You don't use it. Okay. How about so-called intravesical cocktail instillation, hyaluronic acid, combination of steroids, lignocaine? Uday, do you use it? You will be getting such patients.
I don't use it actually, but it can be used. So there's a lot of data.
You don't feel, okay. So a lot of things are described in the literature like conjugated estrogen, pentoxifylline, but perhaps coming to the role of hyperbaric oxygen therapy. Dr. Konetti, your experience?
I think it works a little over half the time, depending on how many sessions, 20 versus 40. But
the literature says at least 40 sessions.
Yeah, that's typically what we do. Some patients cannot tolerate it, but yeah, if you can go 40 sessions, at least half the time it will work, I think.
Uday?
Yeah, so I have got this HBO right now.
You have a unit HBO.
So now I am sending this patient to get the...
Directly you recommend them.
Yeah.
And it has been shown with hyperbaric oxygen therapy, if you give it early, perhaps it will work better. It won't work obviously when there are a lot of clots and a lot of clot retention, that kind of a thing. So there is a good long-term data about use of hyperbaric oxygen for radiation-induced cystitis. The Canadian Urological Association presented a best practice report. They classified these into different grades, and they have given a algorithm how do you treat this management. But obviously, hyperbaric oxygen, if given early, works. Suppose that is not working. Role of cystectomy, diversions. Any precautions during this cystectomy? Dr. Konetti, your experience. Cystectomy for a radiation-induced hemorrhagic cystitis.
Yeah, so obviously you have to be careful because it was a post-radiator bladder. And these cases, I find robotic cystectomy is a lot better because the planes are much easier posteriorly, and you can do it much cleaner. And for the urinary diversion, you have to be thoughtful about what segment you're going to use. Whether it's small bowel, you have to be careful whether you want to use small bowel, T colon, or any of the colonic segments.
Uday, your opinion?
Yeah, so one patient right now in my ward, actually, he has got everything. So we have given the LM as well, but he's still he's not.
All these are described, but
he doesn't respond that.
So you are planning a cystectomy.
So we got the PCN done, right?
PCN,
so he's on PCN for diversion.
But he's heading towards a cystectomy.
Maybe require.
So,
Sanjay. Okay, Gagan, you want to say?
So just a quick addition. So because we get a referral for these radiation cystitis for all pelvic malignancies across the country.
Cervix.
Yeah, the numbers are huge here. We are already exhausted the list of all these. Hyperbaric has shown the advantage only in grade 1 and 2.
Early.
And the primary endpoint was not resolution of hemature, it was LUTS. Just wanted to inform that we've recently concluded a phase 2 study of chlorophylline, actually oral chlorophylline. Actually, the results would be out in print soon, but just to mention that the results are actually seeming too good to be true.
Okay.
We've also looked at some quality of life
Could you
parameters.
briefly tell us about that chlorophyll?
So I think we can talk. It might take longer, but all I'm saying is that So it's basically an oral tablet. It has been developed with the Bhava Atomic Research Center over a study of a decade actually. Chlorophylline has been there for many years.
So this is developed to reduce the radiation-induced toxicity.
Yes, yeah. So there were animal studies to see that it ameliorates radiation and chemo-related toxicity on the animal tissue. The pharmacokinetic studies have been done. The tablet has been produced by a company in Bangalore actually.
So this is an oral
It's an oral preparation.
And how long it's to be given?
So it has to be given at a certain dose. How long for the study we have, for the phase 2 study, we've used it for 3 months. But what we've realized is that a longer thing, because the benefit is so much and there is hardly any side effects.
So my next question is it available for use for the other urologists? So that is the next question.
There's
everybody would want to know if it's working so well.
Many of these things are going to be in
Not
print
yet
soon
available.
actually.
Okay.
We'll talk about it. Both actually.
Sanjay, you have any experience with post-radiation system?
Yes.
Cystectomy is post-radiation.
No, I have done cystectomy in post-radiation one patient.
Any specific?
No, difficulties like doing a salvage cystectomy after radiation, almost same. It's not more difficult. The difference in managing these patients are like each and every patients are very different. Some patients just respond to simple cystoscopy and fulguration. Some patient does not respond to any treatment. And there are now literature coming up with epinephrine, intravesical epinephrine, probably in radiation cystitis. So
which is also used for radiation proctitis. They are using intramural epinephrine.
So we have used in one patient, and I don't know, it's very early to say how it will work.
Dr. Kulkarni, briefly, your experience with cystectomies post-radiation, you must have done many years, and Dr. Gupta, you also briefly.
Well, actually, between 80s and 90s, we used to do this only. In fact, we didn't do primary cystectomy, post-radiation failure only. The problems were, of course, if you were doing endoscopy, one of the resident perforated the bladder.
Perforation.
So you should never.
You mentioned about being very
that's
careful.
the problem. The other thing was the recovery rate was very, very long.
Yeah.
We used to almost carry those, wounds opening directly and all the kinds of things. So they used to stay longer. Morbidity was very high.
Dr. Gupta? Yes.
In 80s and 90s.
Even higher sometimes.
And
significant more.
In 80s and 90s in All India Institute of Medical Science, when we started cystectomies, most of the cystectomies were only salvage cystectomy. The problems he has already highlighted, the adhesions, it will take long operating time, more incidence of complications, and diversion. There is no question of all this neobladder. We used to do a conduit diversion, otherwise transverse colon diversion.
Thank you, sir. So, radiation cystitis, the severity can vary.
Sir, one thing.
Yes, Aman.
Sir, so Dr. Conentino, I had heard him say once that he has never seen a bladder that does not come out. And I kind of agree with that. Even if it is stuck, thoda bleeding hoga, time pata lagega, but it comes out. The problem, I think, is the bowel anastomosis. I have seen higher incidence of bowel leaks.
Injury,
and
yes.
that is something which can kill the patient. Urine leaks can still be managed with PCNs. They will ultimately heal. Bowel leaks require re-explorations.
Yeah, that is the
stomas and everything. And that is, I think, which leads to the main morbidity. And that is why sometimes when the patient has a single functioning kidney, it's best to do a ureterostomy for that patient.
Yeah. Okay. Thank you. We'll move on.
Can I make a
Yes.
comment here?
Quick.
As Dr. Gupta said, most of the cystectomy were post-RT, and in 96 when we started in Rajiv Gandhi Cancer Hospital, we did that only. And we learned a lot of things with that. As Badri mentioned, in that time, we were not using ileal conduit. We were using transverse colon conduit. And forget about neobladder, but with the time, as the time improved, because the change in the technique of radiation therapy, I have done post-radiotherapy cystectomy and followed by neobladder also.
It's feasible in select cases.
The leak which occurs is because of, you have to tailor your surgery, you have to modify your surgery. The ureter, do not take the distal ureter, at least
that is avoid
lower
the
1/3 of the
pelvic
ureter,
radiation.
come
Fine.
anastomose as up as possible.
Fine.
If you are doing ileal conduit, take the proximal segment, make sure that this
Yes,
ileum
sir.
is not irradiated, there is no edema in the bowel, there is no petechial hemorrhage in the mesentery, and if it is there, then go for transverse colon.
Thank you. So we'll move on to the...
Our experiences is also like that in Bangladesh, Dhaka. We are very frequently confronted with this kind of situations. So in doing
Anything different you do, sir? From whatever has been discussed.
Earlier, we are using only the ureteric
Ureterostigma
diversion. And nowadays, we offer them either colonic or the proximal ileal conduit, and they works better.
Okay, sir. Thank
and
you.
radiation improves. And we are using pentoxyphylline in our most of the cases. Some of the patient, half of the patient, they respond very nicely.
Okay,
but others are not.
Thank you. We'll move on to the last case. This was a 66-year-old male, diabetic, hypertensive, 6 months hematuria with clots. Ultrasound and CT showed a 5 centimeter posterior wall solid mass. Histology was a high-grade TCC, muscle invasive. A PET CT was done, and this showed obviously an FDG with bladder mass, no pelvic lymph nodes, but there was one suspicious node at the aortic bifurcation, and these are the images. One node, increased uptake at the aortic bifurcation, while there are a couple of nodes para-aortic, which have no FDG uptake. So should we call this as an N3 or an M1A? Dr. Uday.
Up to common iliac, it's N3.
This is aortic bifurcation,
above that,
just at that.
Yeah, M1A.
So you would call it as an M1A?
M1A, it is possible, it's positive. So my problem is that if you see the other, generally you won't find the escape metastasis actually in CA bladder. It's very
there was
rare.
nothing in the pelvis.
So, so nothing in the pelvis.
Nothing in the
So
pelvis, at least on the PET.
So whether this is positive or something, I would go for the FNEC. If that can be
too
done.
small to do
prove
an
it's
FNS.
metastasis or
My
not.
radial,
Okay.
intervention radial, so it's difficult to.
Yeah.
So okay, we'll move on. So anything above the pelvis should be taken as a metastatic. N1, N2, N3, and N4 are well described in the current AJCC classification. So anything above the pelvis, that is all retroperitoneal nodes should be taken as M1A. So biopsy was considered, it was not possible, so how do we manage? In view of that retroperitoneal node, should be a neoadjuvant chemo followed by surgery, or should be an upfront followed by an adjuvant therapy? Dr. Ravi, what would you offer him?
I would go for a neoadjuvant chemo followed by, give a chemo, reassess it. If there is a complete response, I would offer him local control therapy.
So he needs a cystectomy.
He needs a cystectomy.
So would you also resect the lymph nodes, even if there was a complete response? And it's very likely he might get a complete response, at least in the nodes.
If possible, intraoperatively, we would try chasing it, but I wouldn't go beyond and above to chase that nodes.
So you would do an extended lymphadenectomy. You would not really chase up to the para-aortic and all that. Amit, your opinion, neoadjuvant, obviously, or would you say, prove that it's a metastasis and then only I will give an adjuvant?
No, I think neoadjuvant chemo.
Neoadjuvant is very clear cut, okay. Dr. Conetti, any difference?
I'm a little worried about his consistent clot retention and how he's going to tolerate the neoadjuvant chemotherapy, though that's ideal.
No, he's not in clot retention, was presenting with hematuria with clot, not in clot retention.
I see. But yeah, I would. The other thing to think about is, can you laparoscopically or robotically go in and just take out the node, even if you cannot percutaneously nail it? Because you want to identify whether that's truly metastatic disease or not.
Yeah, but that decision is for what? Giving a chemo or not?
Correct. No, then it won't be neoadjuvant chemo, right? So if this is M1A, then they may give 6 cycles of chemo as opposed to 4 cycles. So your approach may be a little different.
Okay. So it's coming at the question is, will the metastatectomy help in this situation? Amit, what's your opinion? We are going to give a chemo, we're going to do a surgery.
I think in the present era, we would definitely want to go in this direction. We're becoming more and more aggressive, so someone who responds very well, a solitary node left behind, you would think of metastectomy, or I don't know if we could do SBRT to the node and think of something like that direction.
Dr. Malik, your opinion?
Yeah, for nowadays we are moving towards, actually we are treating more radically in oligometastatic situations.
Yes.
So definitely either by surgery, if not possible, then during radiotherapy we can chase that node.
So I think we are moving towards a multimodality therapy, and there is a role for a consultative surgery also. This was an MD Anderson experience over 15 years, but only 45 patients. And it showed those who responded very well to chemo, PT0, they did actually well with the metastatectomy disease. So highlights of this paper were node positivity after pre-chemotherapy carries a poor prognosis. If there is a complete response, a good prognosis, multimodal treatment can give a 66% 5-year cancer-specific survival rate. These are rare situations, but sometimes you get into practice and you have to decide whether a neoadjuvant or a surgery followed by that and try to get a biopsy. Anyway, so non-regional lymph nodes in bladder cancer, nodes above aortic bifurcation are to be taken as metastatic disease. Neoadjuvant followed by surgery is the general approach. Very rarely, if the patient has severe bleeding, clot retention, you may consider, or severe pain local, an upfront surgery may be considered. So I want to thank all my panelists and delegates. I have completed my discussion. Yes.
Ginil here. We have actually a few patients whom we had done the Osaka protocol is actually from Japan, where in node positive that has shown a better result compared to other modalities like chemoembolization along with radiation. Myself, Haridas and Nikhil, we had a team and we used to have a combined this thing. And what patients we had is one was a para-aortic node with inoperable thing. We could have it was in the palliative intent, we could have a cytoreduction with Osaka protocol. Second was actually a renal failure patient who had a 6-7 creatinine. We had a dialysis plus radiation plus chemotherapy together. So this is actually, we feel that from our limited experience is a good thing, and report from Japan is excellent. So I think it is one thing, modality which is underutilized for compromised patients.
Srinivas?
Another comment which I would like to make is, even in node positive, recently 2 weeks back there was a publication in JCO. It was from, again, a multicentric retrospective study from United Kingdom, and they saw that in node positive patients also, it is reasonably safe to opt for trimodality therapy with radiation. Bladder preservation is safe. This is published about 2 weeks back.
Perhaps that is stretching
About
it too much.
300
We'll
patients.
await more data.
Absolutely, but
Yeah.
I just want to put
Yes.
this in front of the audience.
Thank you very much. Thank you all my panelists.
Thank you,
Yes,
all
sir.
the panelists.
She has,
You
she
have
has one
something to
question.
Thromboembolic phenomenon and cisplatin is the main culprit, if I remember correctly. Urologists are comfortable having a cisplatin, or urologists do not want to change it because the response is good, they are ready to tackle the thromboembolic phenomenon.
I think we are comfortable with cisplatin. We are comfortable. Thank you.
Thank you,
Thank
Dr.
you very much.
Kashyapi, for your crisp and timely conduction of this panel discussion. I would now like to invite Dr. Arun Singh S. Moses, who is a consultant radiation oncologist at Tata Medical Center, Kolkata, to talk on SBRT for high-risk and N-positive prostate cancer, its feasibility in India. Over to you, sir. You have 8 plus 2 minutes. Please wind up in 8 minutes so that we have 2 minutes for discussion. Thank you very much.
All right. Yeah. All right. So good morning, everyone. The topic given to me is SBRT for prostate cancer. So SBRT is the setting or the technique of delivering radiotherapy where we end up delivering a high dose per fraction, and in the setting of prostate cancers, it is usually in the ranges of 7 to 8 gray per fraction. And these are usually delivered over relatively few fractions, which are either delivered on alternate days or once weekly in most settings. And this is especially possible in the prostate because we have the technology now that allows us to deliver the radiation dose very conformally and also be very precise about it with the use of image guidance to allow us to target the prostate very precisely. And also the fact that the biology of prostate, which is relatively slow dividing in comparison to the nearby normal tissues. And these two facts are what allows SBRT in prostate cancer. But the task given to me is to talk about the feasibility of SBRT, especially in the Indian setting for high-risk and node-positive prostate cancers. We know for a fact that having a highly conformal radiation is definitely needed for delivering high-dose radiotherapy to the prostate, and it has been shown to significantly reduce the amount of radiation dose that is delivered to the bladder and the rectum, and consequently reducing the amount of significant acute and late toxicities to the bladder and the rectum. But what about the availability of such technologies in India? So I looked at the ILORA portal, which maintains all the radiation facilities in India, and it shows that more than 680 linear accelerators are available in India across the country. And we did a survey of about 88 cancer centers which practice radiotherapy for prostate about 5 years back, and about 88 centers across the country responded to the survey. And it was shown that more than 95% of the centers have the capability of delivering IMRT, and in fact 93% of the centers who responded to the survey were in fact using IMRT as their standard technique for treating prostate cancers. What about image guidance, which allows us to precisely target prostates? And it's been shown that IGRT definitely reduces the incidence of acute and late toxicities when we deliver high-dose radiotherapy to the prostate, and also possibly impacts the biochemical control as well. Usually this is used on a daily basis when we deliver radiotherapy, but what about doing it on a less frequent basis? Our center and also TMH Mumbai have looked at the possibility of doing less frequent imaging to deliver radiotherapy. And it's been shown that the random filling of rectum and bladder definitely makes it difficult for you to deliver precise radiotherapy if you do imaging less frequently, and you would end up requiring a larger margin for you to cover the prostate adequately every time. But what about the availability of image guidance in India? Lack of image guidance in that survey, again, was reported only by 5% of the respondents from the 88 respondents.
And most of these centers were using CBCT as their preferred image guidance, with only 17% using 2D orthogonal imaging for image guidance. And majority of the centers were also using daily image guidance as part of their protocol. So definitely the technology and the expertise for delivering SBRT is available in India, because I spoke about IMRT, and it's the same principles that applies for SBRT as well. What about the biology of prostate cancers in India? Before we go on to that, incidental diagnosis of prostate cancers after patient has undergone TURP for urinary tract symptoms is definitely something that we come across routinely in India. And in the POPRT trial, it was seen that nearly 1/4 of the patients did have undergone TURP when they were presenting for curative radiotherapy. And in this setting, it's usually a concern for late GU toxicities when you are delivering high-dose hypofractionated radiotherapy. And this particular setting has been examined in a matched pair analysis where they have looked at non-TURP and TURP patients in the TMH in a retrospective study. And they've seen that it's relatively safe to deliver SBRT even in the post-TURP setting as well, with the most important consideration being the delivery of radiotherapy much later after the TURPs has been done. In the West, most of the prostate cancers are diagnosed with screening, PSA screening, meaning that most of the studies for SBRT which have been done in the West have included low-risk and intermediate-risk prostate cancers, with very few representation of high-risk prostate cancers. But the prostate cancer in India is mostly symptom-detected, diagnosed, and most of the patients who are diagnosed with non-metastatic prostate cancers have high-risk prostate cancers. So we needed to generate our own data. So the first prospective study in India was conducted at Tata Medical Center. It included majority high-risk patients, and this earlier publication at a shorter follow-up showed good biochemical control with acceptable toxicities, and very slight worsening of the patient-related QOLs at the end of treatment, with improvement and settling down at a lower level with longer follow-up. This unpublished data of a little more longer follow-up of nearly 5 years shows that just for the high-risk group of patients in that study shows good 5-year biochemical and metastasis-free survival. Similarly, there's another retrospective data, again, just the high-risk group of patients from Tata Mumbai. Again, a very short follow-up. I'm not sure if this has been updated now. Good biochemical control and acceptable late toxicities. With that, the stage was set for a randomized trial, and the PRIME trial, which is very close to completing accrual now, was looking at the safety of SBRT in high-risk patients and node-positive prostate cancer patients. Recently, the interim results looking at the 90-day toxicities and QOL has been presented at the ESTRO. Nothing much in terms of the early toxicities between the two arms, very similar outcomes, and also the patient-related QOLs also pretty much similar between the two arms. While we wait for the longer-term follow-up and the establishment of safety of SBRT in prostate cancers, it certainly seems that it is feasible even in the Indian setting, and it is already being used in routine clinical care, with nearly 15% of the centers in that survey saying that they use it as part of their schedule for radical treatment for prostate cancers, and some centers said that even more than half of their patients are being treated with SBRT. Thank you.
We have 2 minutes for discussion. Thank you so much for finishing in time, sir.
Sorry, are we hypofractionating mainly for the convenience of the patient and clinician, or is it more efficacious?
It's more with relation to the convenience for the patient, sir.
Okay. And as Vedang was saying, probably maximum we can come down to is 2 sessions.
2 sessions, yeah.
And is similar thing being done for TMT for bladder tumors, or we are not doing on that front?
Bladder tumors, we have come down to 20 fractions, but I don't think we will go any further below that.
Thank you. There is a confusing this thing about whether we have to give a radiation to the lymph node. When you are doing SBRT, how you manage the lymph node?
So these are all high-risk patients based on the results of the PAPRT. Even the PRIME trial, initially it was just the prostate alone. Now we have amended the protocol, and it is the elective nodal radiation is also given.
So along with that, you add something like a
so the prostate gets about 36.25, and the elective lymph nodes get 25 gray in the same fractionation.
Thank you, Dr. Moses. I don't think we have any more questions. Now, to talk on guiding principles and challenges in the management of retroperitoneal and prostate sarcomas, I call upon Dr. Puneet Ahluwalia, who is the Director and Head, Uro-oncology and Robotic Surgery at Medanta, the Medicity, Gurgaon. Sir, you have 8+2 minutes.
Thank you so much. Good morning, everyone, and thank you for having me here. So, every now and then we, as a uro-oncosurgeon or urologist, we come across a patient who has a large retroperitoneal mass, frequently involving more than one organs. Sometimes it is difficult to even make a diagnosis of the organ of origin. And so my talk is on that, only guiding principles and challenges in the management of retroperitoneal and prostate sarcomas. And I'll be talking about the surgical aspect of it. So these are the large tumors of the body which are in the retroperitoneum and frequently involve more than one organ, which makes the surgery all the more challenging because you might have to remove multiple structures, even the vital structures, major vessels. And it is not uncommon to have very large masses without any symptoms. The symptoms at best may be vague, dull-aching pain, or the patient may be entirely asymptomatic. CCT is usually done because of a primary investigation. CCT is done, and mostly it tells us about the local extent of the mass, and sometimes MRI is required, especially in cases where larger vessels or IVC involvement is there. So whenever we are dealing with it, first up, it is very, very important to have an idea about what histology you are dealing, because it is not only important in terms of making decisions, it will also decide the oncological outcomes. So the two types are mainly liposarcomas and leiomyosarcomas. So these are not very common tumors, these are rare tumors. Suppose kidney tumors, if we talk about, so less than 1% of the malignant kidney tumors are sarcomas. So the literature also is not huge, and not many randomized trials are there on this sarcoma, but there are few specialist working groups which have evaluated the treatment effects of treating these sarcomas. So the histological subtype is important in treatment decision making, and so needle biopsy is done. It rules out benign tumors such as angiomyolipoma, which sometimes mimic sarcomas, and confirm the diagnosis. And it also is important in evaluating the tumor grade and deciding whether neoadjuvant therapy is required or not. Now, there are some randomized trials like STRASS trials which are evaluating the role of radiotherapy as well as chemotherapy. STRASS 1 evaluated the role of radiotherapy, and in some histological subtypes, especially like liposarcomas, it may be important. But STRASS 2 is still going on with evaluating the role of chemotherapy. Staging investigation, at least a chest CT should be done. Lung is a frequent site of metastasis, and whole body PET CT usually is done nowadays, but it is still not the standard. The important thing to note is that if you are dealing with a sarcoma, there will not be any lymph node spread. Sarcomas do not spread to lymph nodes. So surgical approach, surgery is the mainstay of the treatment. So you have to plan your surgical approach very carefully. You have to, know about the caveats of the surgery, the implications of your surgical treatment on the overall outcomes, and it is not just the cutting out of tumor. So you may plan your incision depending upon the location of the tumor. It may be a midline laparotomy with lateral extensions or a thoracoabdominal incision. It depends upon the location of the tumor, and also you should have a wide exposure of the major vessels surrounding it. Goal of the surgery is very, very clear. You should have an en bloc resection of the involved adjacent organs. Try to attain negative surgical margins. Lymph node dissection is completely unnecessary in these tumors, In fact, you may be doing harm to the patients if you're doing lymph node dissection in these patients, because it may lead to increased morbidity with chylous leak. Extent of resection, the importance of extent of resection will be discussed in further slides as well. So obviously you have to resect all the involved organs. One or more organs are resected in 58 to 87% of the patients of retroperitoneal sarcomas. And most commonly it is ipsilateral nephrectomy or partial colectomy. And resection of major vessels is done in 10 to 15%, which is a big number. So now there is something called compartmental approach when you're operating on patients with sarcomas. So it is mainly followed by Italian and French sarcoma groups, not so much by the US group. The fundamental concept is that even without obvious involvement, adjacent organs or structures should be resected and the surfaces should be cleared in order to achieve the maximum clearance. This is analogous to obtaining a negative margin in soft tissue sarcomas of the extremities. Basically, this is an extrapolation of that concept, and this is a study which evaluated the effect of compartmental resection on abdominal recurrence rates. You see, if you do just a simple complete resection, that is not enough. If you do a organ resection along with the involved organ, that does better, but compartmental resection does even better. So this is not something which is indicated for all the patients. It again depends upon the histologic type. So if once you have the histologic type, it anticipates the origin and the local extent of tumor. For leiomyosarcomas, these tumors are not locally aggressive. These, when they recur, they are usually distant recurrences, so compartment surgery may not be needed. Similarly, liposarcomas, they are usually multifocal, and there may be presence of synchronous tumors, and usually in these tumors you need to clear adjacent fat, or compartmental resection may be advocated in these patients. Histological subtype also tells you about whether it is well differentiated or a de-differentiated tumor, and it will prognosticate a patient in terms of oncological outcomes. Now, the importance of histological margins in these surgeries is very important. So there has been study which evaluated the histological margin in terms of overall survival. The piecemeal resection or R2 resection is totally to be avoided. It is as good as not doing any surgery. In fact, it may be doing a harm to the patient because you are giving a morbidity, and the overall survival results are as good as only doing a needle biopsy or no surgery. The best results are with complete resection with negative margins and a compartmental resection in some histological types. But even if you have R1 resection with microscopic positive margin, that is also still manageable. So this was a study by a French sarcoma group which evaluated the local recurrence, distant metastasis, and overall survival depending on the prognostic factors. And it was seen that for local recurrences, no adjacent organ involvement, specialized surgeon, and en bloc resection were important prognostic factors, and perioperative RT added in terms of improving local recurrence rates. Now, when we talk about specialized surgeons, it means specialized surgeons who are treating or operating on sarcomas, and the minimum number is, there are very few studies, the minimum number what they've written is around 10 to 12 cases per year. So that means one case a month at least you should be doing, especially for sarcomas. For abdominal sarcomatosis, again, these first three prognostic factors are the same, but histological subtype is an important thing. The well-differentiated sarcomas are better in terms of abdominal sarcomatosis. And overall survival, the grade is very important. Grade 1 is better rather than grade 3. Similarly, this is a study by John Hopkins, and they echoed the results from the French sarcoma group. Leiomyosarcoma had a highest rate of distal recurrence, perioperative RT reduced local recurrence, distal recurrence was grade dependent, and overall survival was better in patients with complete resection. So oncological outcome, local recurrence occurs in 49%, reduces to 27% with compartmental resection, distant metastasis in 12%, and overall survival is still only 39% of the patient. Now, once you have a recurrence, what do you do? still the best chances with second resection. The negative prognostic factors are as listed. I'll not going into the detail of these, but if you have a locally recurrent mass which is growing more than 1 centimeter, surgery is not going to do any benefit. And this is a study by Transatlantic
Sir, please
Group.
put your conclusion slide. We are running late, sir.
I think the next talk is
Yes, sir, but we are already late, so
Okay.
please put your concluding slide.
Okay.
Otherwise, there won't be any time for any discussion, sir.
Okay.
Sorry.
So distant metastases after second resection are very few. It is only the local resection, and again by the histology. So morbidity again is dependent upon the age and organ resected. After 65 years and more organs, especially pancreas and spleen, if resected, these lead to increased morbidity. And guidelines are also, NCC guidelines are there, which says that resection is the important step. So RT and chemotherapy is only for selected results. Prostate sarcomas are not different, very short survival time, 25 months, and they on MRI, last 2 slides. So MRI, they are irregular masses, sometimes nodular masses, maybe heterogeneous masses, and again the absence of metastasis, stage 1, complete resection, and histology of RMS are good prognostic factors. So overall survivals are better when there was no metastasis and negative surgical margin. Age, size, and even histology were not significant. So the best treatment for prostate sarcomas is cystoprostatectomy, not a prostatectomy. So if you're doing prostatectomy, the patient will going to have a dismal prognosis of few months, but prostatectomy is a better. So the conclusion is that surgery is the cornerstone of the treatment of retroperitoneal sarcomas and prostate sarcomas, and you should try to achieve an en bloc resection with negative margin rate. And the pattern of recurrence will depend upon the histology subtype, and neoadjuvant treatment in terms of radiation and systemic therapy is being more rigorously assessed. Thank you.
Thank you, sir. 1 minute for discussion.
Sir, as you told that compartmental resection is decreasing the local recurrence rate, but before the compartmental resection, we need a biopsy. Normally in retroperitoneal sarcomas, routinely we will not do a biopsy. So what is your take on that?
So biopsy, like I told, it is very important. From imaging, so it is not always possible to, from the imaging to assess that this is going to be a sarcoma. But if you have a large mass which is encroaching upon the other organs and it's not primary organ, so in those cases at least you should do a biopsy. Biopsy is the norm in treatment of sarcomas. It has
any sarcoma presenting, we need a preoperative biopsy should be mandatory.
For retroperitoneal sarcomas, yes, you should do a preoperative biopsy.
Thank you, sir.
Thank you.
Thank you so much, Dr. Puneet Ahluwalia. We now move on to the SOGO collaborative initiatives. May I remind the speakers that each speaker has 8 minutes, which will be back-to-back, followed by 4 minutes of discussion. May I invite our first speaker, Dr. Raghavan N., who is a senior consultant, specialty uro-oncology at Apollo Hospitals, Chennai. Sir, 8 minutes. Sir, 8 minutes. Okay, sir, I'll give you that.
First and foremost, my greetings to all. I'll come straight to the point. The most important, can I see a pointer? Does it work? Yeah, okay. The most important aspect of SOGO is collaborative research. We all started with the fact that we quote constantly the Western data. We don't have Indian data. We need patients being treated here. Is it the same as what we see from what the Western literature are? That is the point. And we also have, sadly, a terrible record that surgeons are terrible in collaboration. That's a fact. I mean, I'm not going to disagree on that as well. So there are lots of variations in surgical techniques, the way we deal with things and whatever. So there is a thing to say that surgeons are very bad in collaboration and we can't have our own data. Inevitably, many things that are published have been a single surgeon, single institution series. So time has come that SOGO becomes the platform to collaborate, to get data across board all the centers, to see that, it averages out all the biases that innately comes with a single surgeon series. So we looked at, to start with, we looked at two common procedures, radical prostatectomy and partial nephrectomy. And this is an ongoing process. For each of the retrospective analysis, we need to get the permission of the ethics committee and the local center and the collaborating center. We have to have a robust data collection point, and data cleaning is the biggest hurdle in this because this is a retrospective data collection, and it has taken almost 9 months of very hard work and a lot of collaboration to reach where we are. But my request is the floor is open for all. All of you can contribute. Please, I request every one of you to contribute. Larger the data, better the analysis. So we look at partial nephrectomy, and I'm just going to be brief, and I'm going to say so far we collected from 4 centers and 675 patients. 675 patients, 4 centers, and we have another 4 centers who have collected the data, but it needs a lot of cleaning. So I've not included them in the analysis here. This is just an interim analysis, and we find some extremely interesting data sets. About 139 patients are less than 40 years. We have a lot of patients less than 50, and these are the patients we are worried about genetics. We haven't started doing genetics for them. Renal scores, just for the surgeons, they will understand the complexity of operation. At least majority are moderately complex surgeries. We are not doing simple T1A peripheral interpolar tumors. Looks like most of us are doing reasonably complex surgeries. Duration of surgery, whether you do lap or open, seems to be the same. Obviously, as expected, open surgery has slightly higher duration of surgery and slightly increased risk of complication and a percentage increase in the risk of blood transfusion. In the ISUP grading, now starts the most interesting data sets. We find that grade 2 disease is the highest, as expected, very similar to the Western literature published as well. But then look at this data set. Almost 60% of them are T1A, versus the published literature is 80% elsewhere. About 30% for us is T1B and T2. We are operating on far more complex, bigger tumors for partials than what otherwise is done. But the good news is that margin positivity for us is very similar to the published literature of only 3%. And look at this as well. Roughly, we tell our counsel patients 80% of the small renal masses are malignant, and 20% are benign. Our data shows almost 89%. 10% are benign, the rest are all malignant. So looks like our small renal masses are slightly bigger in nature. They are not small, they are moderate renal masses probably, and they are all cancers. I'm just giving glimpse of it. There are so much of data underneath which I can present. All of you will run away, so I'll just jump. And we have had good follow-up of 5 years, and looks like majority patients are doing well. We have had only 2% recurrence, which is very, very similar to what is published. So we have high-risk disease, we have high-stage disease, but looks like we are doing a decent job of it. In a bigger forum and a longer presentation, I'll share more details on this as well. So I'm just going to go to the next data set, which is radical prostatectomy data set. 2,000 patients have been enrolled for this across 7 centers. Once again, ethics approval for each center has been applied as well. And once again, another 3 center data sets are with us. We are cleaning the data, which we'll put it for the next presentation. Average age is 60, but what is slightly intriguing is that more than 80 patients have also got radical prostatectomy, which is slightly painful to see. I'm so sorry. This is data cannot lie. That's what it is. So in the perioperative variables, the majority we have are Gleason grade group 2. That's what we are doing, but equally important is GG3 as well, and GG4. So look at that data set. We are having reasonably high amount of it, and once again, more than 80 had radical prostatectomies. I'm not going to defend it in any way. That's another thing I wanted to say. Less than 60 years, we have almost, so much of volume of patients. Yes, sir, that's a fact. 50 itself is so high. No, that's a PSA value less than 50. PSA value less than 50. Sir, age distribution is 2.3%. But if you take less than 60, 19 plus 2, that is about 21% of patients are less than 60 years of age. But if you look at the PSA of those patients in less than 50, PSA of less than is 34. PSA average is 34, meaning all these patients had very aggressive disease. Risk level, 52% are high risk. D-amico classification. Yeah, 52. And majority have had robotic surgery and node dissection. We have been very good surgeons. Vedang will be happy with us. Most of us are doing good node dissections. And just jumping and giving only the glimpses, post-op complication, lab had the highest complication rate at 27%, and the hospital stay for lab also was very high in spite of going through, and the lab had the lowest in terms of risk factor, but the highest in the day length of stay. Maybe many people who are doing lab have moved to robotics now, but nonetheless that's a fact there. If you look at the T distribution, post-pathology T distribution, T2, T3 and T3A and T3B forms 50%. 1 in 2 of our patients are T3A and B. And once again, distribution across the modality of lab, robot and open. Many open surgery patients are T3B disease, vis-a-vis many lab are T2 disease. So, and you look at the margin positivity and node positivity. This is just the data showing that we are getting decent amount of nodes. About 1/5 of the patient had node positive disease, and T3B had the highest margin positivity as expected. So one last
2 minutes extra.
Last 2 slides, yeah, last 2 or 3 slides. We have a huge stage migration, pre-op and post-op. You can see that the GG2 and 3 have become so higher in the post-operative status. And going forward, this is just a starting point. The floor is open. I want all of you to participate. Please, each one of you can come up with your own plan. We'll approve, we'll support the system. We have enough people to support the system. Even the retrospective data on penile cancer, testicular cancer, nephroureterectomies, cystectomies, all are open. And please take it up, and I want all of you to participate in this. Eventually, we want to create something like a minimal data set, like what is done in the BOWS. That data set hopefully will become prospective, and we want to roll out a program where you have an online platform to enter your data as you go along with a minimum data set. It will not be a 28-page document, but at least we have something to work with. And more prospective multidisciplinary centers is monthly disciplinary trials is what we want to do. All are welcome. All new ideas are welcome. Any new ideas, please. Prospective and retrospective can be done. We will assist you in our ethics approval. Even in some amount of data collection, we can help. But intricately data collecting in each center has to be done by that center with the help of your postgraduates and others. Eventually, this will become the backbone for the Indian patients, the South Asian patients living here. I sincerely thank the SOGO for allowing us to do this, and the ethics committee, almost all of them did it for free. They are supposed to charge us. All the participating consultants and the team, they have been pestered. They will cry when they hear our name. Pavitra, who is our research assistant, like Samreen, who is our background staff, did all the groundwork, and the patients who went through all these procedures. Thank you so much. Any questions? I'm happy to answer.
Thank you very much, sir. I call upon Dr. Srinivas Chirukuri, who is a radiation oncologist from Apollo Proton Cancer Center, Chennai. So you have 8 minutes, and then we'll have 4 minutes of discussion.
I have a completely different set of slides compared to what Dr. Raghavan presented. This is just part of my own experience, and we have recently, a few months back, we joined this randomized trial at our center, PRIME trial, which was started in TMH and then Tata Medical Center started participating in it, and we started participating in this particular randomized trial. We've already mentioned about this particular collaborative study which we presented.
Please start the screen timer, please.
And clearly we found that there are, at least in my personal experience, I found there are great benefits of collaboration. I'm telling this to you not to, not to preach or something. This is my personal experience, and I would probably encourage people in the audience who are sitting on the fence probably to come out and collaborate. It kind of sorts out your house in order, in the sense what kind of protocols are you following. It becomes much more clearer, and the house is clearly in order. Access to new data sets, you can analyze new things, learn new skills and expertise, expand research and impact. You can maximize your output, foster a sense of community and camaraderie between the participating centers, and this is a friendship for a lifetime. So I think these are the benefits of collaboration. And I think we have been taking baby steps. We have a small WhatsApp group which has been running for last 3 years. Those who are interested in the GU radiation oncology research, and about 20-25 of us are part of it. And we started with retrospective studies answering some important clinical questions which are relevant to our context. And yesterday there was a discussion regarding, and Vedang mentioned regarding patients with upfront orchidectomy, what to do with them. So that could be an idea, for example, a scenario which is unique to our setting. And hopefully we will do prospective studies. Maybe it has to be limited to a smaller group, because prospective studies are not everybody's cup of tea, clearly, and I can vouch for that. And we have started this kind of an idea which about a month or more than a month ago. And T4 are not, again, very uncommon, neither in the Western setting. Western setting, it's not very common. You see, the androgen deprivation high risk T4 were almost nil. The Abbey study with Stampede T4, T3, T4 were not defined, because T4 defining T4 itself is a bit difficult. But we have seen in GG5 T4 are about 15%. In POP-RT about close to 10% of patients are T4. So we have, as I mentioned, this is the group which we have already, and we are trying to brainstorm few ideas. And we were thinking of defining T4 on MRI and PET and CT, random image reviews if feasible, because I don't think central imaging review of the T4s will be possible and feasible. Non-metastatic on conventional imaging or PET, stratified into T4 due to bladder involvement, rectal involvement, or others, or both. And all patients should have received radical doses of radiation ADT and treated with IGRT. I think the strength is most of the centers which we are part of, the group is part of, our practice IGRT routinely. Then we are trying to develop the CRF form. But as I said, this is just a few slides to put it in front of you to initiate a discussion regarding what all we can think about. I think I'll float a few ideas, and based on that we can have a discussion. It's like a more of a panel discussion where I would be asking you some of you few questions, I guess. PET is our strength, IGRT is our strength, SBRT is being done routinely. So could we have some ideas from the audience? What about T4, by the way? T4 lesions? Any of you have comments? If you are urologists, you can also pitch in and give us ideas and suggestions, because those would be helpful as well. I think.
Sorry, the T4 one, I would probably leave it because it's a radiology-based one. But what I realized is the amount of neuroendocrine differentiation that we tend to pick up in Indian population is a lot more.
Yes.
And any trial that is published, they almost don't even look for neuroendocrine, at least in the primary de novo setting or in locally aggressive prostate cancer. And as we are anyway, all Gleason 4 or 5, we are doing neuroendocrine. Right. It would be useful to just study that as a subset. So whether they go for surgery or whether they go for RT, and say what happens to these people.
Yeah, neuroendocrine as well as ductal adenocarcinoma, we do see a small proportion of us see ductal adenocarcinomas as well. These are variant histologies which probably need some data. That's a very good suggestion.
Post-URP setting is another area where we have to, because we are concerned about structuring that part, and you are concerned about incontinence in our side. So this is one way by quality of life or something we can assess. That is one area where we have to do something.
Post-ERP is a very good point as well, but it has been seen across a few studies now from India that post-ERP, Dr. Gupta also mentioned regarding whether it would impact the outcomes, which is a very interesting point. But we were mainly looking from the point of view of whether TURP would add to the toxicity, which it did not in the context of SBRT as well as moderate hypofractionation. But TURP point is well taken as well.
While we are talking about the grade group 5, I think he brought on the point that neuroendocrine. But FDG PET scan would be an additional investigation there, and molecular studies.
Yeah. And of course, as I said, when we mentioned of these neuroendocrine, we'll have to look at comprehensively what imaging is used at the staging and everything else. But I would like to request Dr. Allison, you've been hearing the talks very patiently for the last 2 days. Sometimes we need an outsiders and that too from a person like with such huge experience in research. What would be your suggestions for us in terms of research?
Thank you. It's been a fascinating meeting because the population you treat is indeed different, and I think you quite rightly are putting a lot of effort into getting India-specific data. And so just my observations from looking at the data you've presented is that you have a real opportunity to lead the world in terms of the higher risk prostate cancer, node-positive prostate cancer, and answer the questions that we can't because we see much earlier disease. So that would be the obvious opportunity from my perspective.
Thank you. Dr. Nagar, your suggestions as well? Node positive and high risk, of course, if there are any specific suggestions to make in those cohort of patients?
No, I mean, I think what's being done is excellent. Just to echo Dr. Tree's point, is that right now it's, running the trials that are necessary for these patients, collecting the data, and then also, there's a big, while, randomized controlled trials are the gold standard, but just the real world experience and real world data, which India can provide the rest of the world just because of just the sheer number of patients you have here, even if it's just a cohort study, will be very informative, not just for surgeons, radiation oncologists, but also companies that make drugs that could provide resources to fund these studies may be helpful because we know that especially in a higher risk group the systemic therapy is going to be very important, and then you can lean on industry to help support some of these efforts. So I think getting data set to push them to fund further research is going to be very important from a feasibility and having financial efforts dedicated to this.
Thank you. Indranil, I want you to say, in fact, I was about to invite you. Of course, Indranil is leading many studies at Tata Medical Center. But after your comment, I will also have a question for you that what can you think of PSMA PET? Yesterday you presented a very well. What can you think of PSMA PET and how can we leverage the amount of PSMA PETs we are doing in before radiation, in many different settings?
What I was going to say was that we are still collecting data in silos. We are collecting radiotherapy for T4. Actually, what we should be doing is we should be collecting T4, all comers, whether they're getting any local treatment or not, surgery, radiotherapy. It's only then can we really answer some questions, because otherwise it's limited. And SOGO does provide, therefore, a platform where the surgical data and the radiation data can be captured together.
Of course, it is easier said than done because...
It's easier said than done,
yes,
no doubt about it. But it should be a goal to at least in one site see, it could be node-positive prostate cancers. Yes. It could be, in terms of PSMA, I think that, again, I think that it's very difficult to do randomized control trials, prospective studies, but we should actually encourage prospective data collection, which means that if through SOGO or whatever, we say that whatever is going to happen, these centers will collaborate. All the results of the PSMA in various settings will be prospectively collected. That will actually add a lot more value because you're then not chucking out patients who did not come for follow-up. You will realize how many patients don't turn up. the dropout rates, etc., which actually never gets reported. We are only reporting patients who nicely completed SBRT. Correct. But what of people who didn't? Yeah. So those are the things.
Thank you, Dr. Srinivas Chilukuri. We now move on to the next topic, which is newer age technology in oncological horizon. We've got 3 speakers. Each speaker has 7 minutes and followed by 4 minutes of discussion. We have our first speaker is Dr. Ashwin Tamhankar, who's a consultant uro-oncologist from Dinanath Mangeshkar Hospital, Pune. Sir, your 7 minutes will start now.
Thank you so much. So with this, I would just say change is the only constant, and that stands true for the designation as well. So scope, when I look into the future, what I would want for my patients is I need to choose my candidate better for deciding about the therapy, optimize the surgical outcomes. For surgical training purposes, going forward, I would have my fellows, so I would be having a perspective on that as well, and then a tailored follow-up to an individual patient. That should be the goal. So the topic is too broad. I'm just trying to cover up upon 4 or 5 points. Let's try and see how much points we can cover in the stipulated time. So radiomics, it's coming in a big way. Definitely underutilized in India. Probably there should be more radiologists in this crowd. That can be a goal for the next SOGOCON. We involve more radiologists who are dedicating their times in uro-oncology as well. So it differentiates oncocytomas, benign AMLs from RCC. Definitely a good pointer. Variable grades in the RCC, which helps us for some decision makings, and subtypes of RCCs can be. Just a quick example, we all have these kind of examples. Unfortunately, they are not that reported or not that spoken about that often. So a high risk mass, 9 centimeter renal, 12 score, undergoes lab radical nephrectomy, and biopsy turns out to be oncocytoma on the final histology. So if radiomics would have been utilized regularly, probably there would have been a caution statement coming from a radiologist, and I would have attempted a difficult open partial maybe. So that's the small change in the SOGO data. Luckily, Raghavan sir mentioned about 10% still in India we have benign histologies on the partial nephrectomy. So that is one underutilized segment, at least for now in Indian context. Regarding the grade of RCC, probably that will also help us for deciding lymphadenectomies. A grade 4, if it is speculated earlier on the radiomics, probably I would err on a side of a massive lymphadenectomy at a little small size of tumor as well. So next is similarly, radiomics is coming up in a big way in prostate biopsies. Though all of us know that yesterday Dr. Gagan Gautam mentioned about 2 + 3, 5 Gleason score. So we get those examples in India. So it has to be a standardized reporting, and AI probably would help us. Similarly, there is an inter-observer variability in the radiology section as well. So decision makings for the biopsy, PIRATS 3 especially, these are the ones which probably help us for deciding if we embark upon a strong radiological support in radiomics. Coming to the surgical part, one good part is complex partial nephrectomy. Acknowledgements to Raghavan sir for a few slides here. So tumor character, what I am supposed to see into that complex tumor identification, tumor characteristics, the nature, hilar anatomy, and the vascular anatomy. This will solve the mystery for me to have a little safe surgery, being very honest. So the inner site has been utilized. Yesterday we saw almost 3 speakers incorporating this particular segment into their slides. So that means it has been utilized commonly in India, unlike the last year when only few people were utilizing it. So these models can be 3D printed models or virtual models. So 3D printing models will give some hyper accuracy models, and they are more for patient counseling. Pitfall is more expensive nature, more time consuming, and there is a possible deformation. They are coming up with some 4D printings as well, so the future is bright there as well. Virtual remodeling, obviously it's an interface which is interactive. You can add or subtract some locations and lesions, and then you can potentially have some decision makings. It needs good expertise, and the future in there is artificial intelligence and a real-time navigation. Just a quick video. This is again coming from Raghavan sir's side. I am yet to use this, but looking at these videos, probably potentially we should all use this. So upper polar renal mass, stretching the pancreas, splenic vessels anteriorly. If I'm not very particular in evaluating the 3D anatomy of this particular context, I will still try and go in transperitoneal approach, but which probably might injure splenic vessels. So open retroperitoneal approach would probably do a better justice here. So it definitely helps us for identifying our approach, robot versus open, radical versus partial decision making, transperitoneal versus retroperitoneal approaches. It also helps us for identifying or dealing with endophytic tumors or multiple tumors. And ultimate goal is obviously trifecta and pentafecta. If you want to add ICG to the 3D printed virtual modeling, probably that will be a cherry on the cake. That will lead to some selective clamping, minimizing the ischemias, and obviously the long-term goal is pentafecta outcomes. That's been seen in the trial. It's not a trial, obviously, it's a retrospective series, but all the parameters or the boxes have been ticked in that particular segment of cohort of patients where it is utilized. The next step after that is holographic reconstruction and integration, and that is incorporated during the live surgery in a tile pro sequence. The Chinese group is definitely, they have published some papers on this. If there are certain representative images in which you would want that kind of situation happening intraoperatively. Given a scenario, if everyone has this facility available, everyone would want to embark upon it, then why not now? So a tumor which is stretching the renal vein, there is a small artery which is running ahead of the tumor, which you know that if it is going to be there, you clip it, you are going to save the kidney. Invariably, if it bleeds, the kidney is going to be lost. So these are the things which we need to utilize more often, and the data says that it gives better opportunity in terms of overall recovery. So practice before you play. So that stands true for training. For a complex partial nephrectomy, for all of us, it's something which is desirable. But for a straightforward mass, for a trainee, if you're trying to train him for partial nephrectomy, which we all must do going forward, if he can virtually practice that particular thing a day prior, that will definitely help us. So these are the things which are going to be important. The second part, which I'm going to cover in next 2 minutes, is confocal microscopy. It's a fresh tissue biopsy. So it's a biopsy ultimately that is run with the lasers, and it similarly gives similar to H&E appearance of tumors and gives you some concordance. So Bernard Rocco group kind of conducted these studies, and the concordance is about 97%, which is a huge concordance on the periprostatic tissues. So 2 indications again for prostate. Biopsy wise, you can actually have 95% concordance. I'll just take this one step ahead. We saw a German paper last few months coming up without a biopsy undergoing a prostatectomy. Then why not utilize this segment, do a biopsy intraoperatively, try and have confocal microscopy, and then do a prostatectomy in the same setting without waiting for 4 weeks. A potential food for thought, though cost is going to be a hurdle, obviously. One caution point about confocal microscopy, that in vivo it is a less feasible option. So ultimately you have to take the specimen out of the body of a patient, either a periprostatic area or the entire prostate. So again, the NeuroSEF technique, which is highly dependent on the extremely good pathologist, can be potentially replaced here. And the advantages are less of learning curve, a stipulated nomogram related appearances, and good concordance to the final pathology. Last 2 things quickly. So augmented reality has been actually utilized for prostatectomies with 3D printed models, and then it is actually utilized with a tile pro sort of imaging during the live surgery with high fidelity and precision 3D reconstructions. That's been discussed. And one last point on PSMA guided therapies, which people are also utilizing for, especially for salvage setting, when you have a node which shows uptake, potentially can be picked up with the PSMA therapies. And that's my concluding slide. So one good part on the remote monitoring. So that is one thing which we are missing out upon. Our patients, especially in Indian context, they go back and you're just basically we are relying on a principle of no news is good news, but probably the future should be that you should be having a good reporting of tachycardias, perioperative problems, fever profiles, and that can be done with some the technologies. The IROC trial actually utilized a Fitbit device in the context, and even the Razor trial also utilized some exercises which were monitored in the perioperative phase, the second part of which came up with. So that's one part for monitoring purposes. I think I'll end here. Thank you so much for the opportunity.
Thank you, Dr. Ashwin. To present the radiation oncologist view, I would like to call upon Dr. Himanshu Nagar, who is a faculty from Weill Cornell Hospital, New York. Over to you, sir. 7 minutes. Thank you.
First of all, thank you for the opportunity and the invitation to speak. I think we can all say this has been an incredible meeting and an incredible learning opportunity for many of us here. So I've been tasked within the next 6.5 minutes to convince everyone here why within the next 10 years you're going to be talking about MR-Linacs for prostate cancer radiation treatment, and words like protons, CyberKnife, and CT-based treatment are just going to be vernacular and considered the past. These are my disclosures. So today we're going to go for the rationale of MR-Linac for prostate cancer, followed by our workflow at Weill Cornell using the MR-Linac. We'll touch on MR-Linac trials in localized prostate cancer, and then trials in the postoperative setting. So what's the rationale? So we've seen there's an incredible imaging revolution in prostate cancer. So some may remember this is how we used to treat prostate cancer, looking at a plain film and sort of putting a box around the prostate. Then we had the advent of ultrasound, where we saw the incredible rise in brachytherapy, both LDR and HDR. And then we moved on to fiducial marker placement, and then therefore tracking the prostate through intrafractional treatment with stereoscopic X-rays. And then we had CT, where we had 3D anatomy, so we could actually see the bladder, rectum, and prostate and incorporate things like CBCT. Now we're seeing, here, at least in India, it seems like on the way to getting your morning chai, you're walking through an MRI and a PSMA PET CT, so it seems an audience that I don't need to discuss with the revolution in terms of imaging using MRI and PSMA PET. And we already know that MRI is very important in the diagnosis of prostate cancer. 2 landmark trials showing that pre-biopsy MRI leads to better diagnosis of significant and clinically insignificant prostate cancer to better guide treatment. And our surgeons here, I know most of the audience is surgeons, but we know MRI is used for surgical planning, both for the neurovascular bundle preservation, how to approach the median lobe, and also we heard yesterday, the width and length of membranous in the urethra that can be spared. MRI is not unique to surgery and biopsy. We've been using it for decades in radiation planning, but we know that fusion and registration to our CT base is not completely concordant and relies on us increasing the margins that we have to treat prostate cancer. So let's see if I can get this video working. So this is what our MR Linac looks like on the left, and a CT base, same patient. So you can see it's shades of gray on the right versus actual delineation of bladder, rectum, prostate, and you can see a rectal spacer clearly on the MRI. Again, this is a low field MRI compared to CT. And so our workflow, we do offer rectal spacing in New York, but what we do allow is there's no fiducials or post-spacer MRI. So a patient gets a spacer, gets an MRI sim, and then moves on to treatment. The CT and simulation are done, but we've been able to, or will soon be able to, eliminate the CT based upon, as we heard, sort of using AI platforms in order to get synthetic CT. So here's the MRI, here's a deep learning synthetic CT, this is the ground truth CT, and the difference map between the two. Contour is done on the platform, planning and quality assurance on the same platform, and this is what I want to spend a little more time on, is that this is the first time with any kind of technology in radiation oncology that you can actually see what you're treating. Every surgeon here has shown videos, live videos of what they've been doing, but without an MR Linac, a radiation oncologist cannot actually see what's happening. And so this is 8 frames per second with real-time and automated beam gating. Our margins are 2 millimeters, and we only allow 5% of the CTV outside. So within the next 3 minutes, we're going to go through all the data that we have so far, because the pictures are nice, but what is the data supporting any of the use of this? So Dr. Kishan at UCLA ran a pivotal randomized trial comparing CT-based treatment versus MR-based treatment. 178 patients were randomized. This was supposed to be a much larger trial, but the Data Safety Monitoring Board stopped it short because of the toxicity difference. And so the dose here is given a little bit spicier than what we see in India, and then on the PACE-B trial of 40 gray, the margins were different, 2 millimeters on MR and 4 millimeters on CT. Elective nodal treatment was allowed, 25 gray, which is familiar to this audience, along with boosting of the gross nodes and dominant intraprostatic nodules. Bottom line basically showed better acute GU and GI toxicity between the MRI and CT. That's not just a physician-reported outcome. They also saw it in patient-reported outcome in terms of clinically relevant IPSS. So the MR Linac afforded margin reduction, but also allowed better contouring, better visualization, and real-time tumor targeting and tracking with this technology. So that's one trial. Last week, Jonathan Lehman and his colleagues at the Brigham published a meta-analysis looking at the acute toxicity of MRI adaptive treatments. So on the Mirage trial, there was no adaptive treatment. These were just used as MR-GRT. And what they showed in the meta-analysis is basically looking at really contemporary trials using CT, SBRT, mainly through CyberKnife platforms versus patients on MRI-guided SBRT, adaptive SBRT. And the key difference between GU toxicity and GI toxicity is the method of treatment, using MR or CT-based treatment across both profiles. So we've heard a lot about two-fraction treatment. Credit to Dr. Tree, who's will be letting us know soon on a trial of 2-fraction treatment, randomized trial between 5 fractions and 2 fractions, 24 gray in the 2-fraction with a 27 gray integrated boost to the GTV. Along with that MR-Linac, there's a large registry study called Momentum, close to 4,000 patients, I think, at this point, led by, of course, prostate cancer. Not to be, outdone by Dr. Tree, we have a randomized trial similar, comparing 5 treatments to 2 treatments. Same stratification factor, relatively same stratification factors. It's open at multiple centers, about 25% enrolled, and again, the primary outcome will be a non-inferiority design at a 2-year endpoint. Post-operative setting, this again run by the group at UCLA, looking at CT versus MRI. This was a non-randomized trial, but basically showing better profiles of MR-guided SBRT in the post-operative setting. This is the last trial we'll discuss briefly, is looking at the, we have an ongoing trial that is just completed called Shorter, looking at 5 fractions versus 20 fractions, same randomization, and what you can see here is basically we've been very strict on our CTV coverage and real-time tracking. This will be reported soon. Preliminary data here, interim analysis when the first 45 patients who were enrolled had 6-month follow-up, did not show non-inferiority between the 2 arms, and this will be presented at a conference not quite so near here, but soon. Last slide here, really next frontier, combining focal therapy with radiation. This is not a combination therapy of the drug kind, but this is something we are exploring, and it's leveraging both the expertise of urologists and radiation oncologists. Thank you.
Thank you so much, Dr. Himanshu Nagar, for finishing in time. I'd like to invite Dr. Amit Joshi, who is a professor in medical oncology at Tata Memorial Hospital, Mumbai. Sir, you've got 7 minutes.
So, till the time you have heard about the whatever going to the future, and now in medical oncology, the future is already here. So I will briefly talk about 3 entities which have 2 has already come into the practice, and 3rd will be soon. So CAR T-cell, just a few basic slides. The CAR is a acronym for a chimeric antigen receptor T-cell therapy, which involves the genetic modification of patient's autologous T-cell and to express a CAR-specific tumor antigen on those T-cells. So this is the diagram. So these are the steps. First, the T-cell from the patient's body is collected, and they are shifted to a manufacturing unit. And from that, the T-cell are being isolated. And the most important step for the T-cell is the introduction of a specific the chimeric receptor in the T-cell with the help of a viral vector. So this is the most important step in the whole, which is in the last panel. So this is the most important step where the T-cell is being introduced with a viral vector, particular receptor. And with this, there are certain expression of certain receptor on the T-cell. And then these T-cell are expanded in vitro, and then the expanded cell are then again sent to the hospital or place, and then it being reintroduced into the patient's body. Before that, a lymphodepletion, because as such, the T-cell might not be able to expand into the patient body, so some sort of what we call as a mini conditioning regime is being done to lymphodeplete the normal T-cell of the body, and then this T-CAR cell is introduced into the body. And so this is the structure of a modified CAR T-cell. So this part is the transmembrane part, and this is the part of which is going to attach with the T-cell into the body, and this is the intracellular domain which will give the signal. So this diagram is showing how this T-cell is going to, modified T-cell is going to work into the patient's body. So this is the T-cell which is having a specific receptor, what we call as a CAR T-cell receptor. And with the help of this CAR T-cell and with a specific receptor, this T-cell will be T-cell will be activated, and it will release certain cytokine which will kill the tumor cells. So this is another modified diagram how this CAR T-cell functions into the body. So what happens that the transduction of T-cell with viral particle harboring the CAR encoding transgene leads to the stable expression of CAR on the surface of the transduced T-cell. So this is the transduced T-cell, and with the activation of this, so there are certain receptors which are already present into the tumor cells, with the help of this T cell get activated and they started reducing, secreting certain enzyme, what we know as a perforin and granzyme, which then starts killing the tumor cell. So this CAR T cell has already, so there are at least 6 approved CAR T cell therapy which are being used in the practice, but mostly it is in the hematolymphoid malignancies. The first indication was the acute B-cell leukemia, and after that, at least there are, so very difficult to remember these names for us also, being a medical oncologist. So there are at least 7 approved indications. So from the acute leukemia to the DLBCL and now the multiple myeloma. So these are the FDA approved, and in our country, we, in Tata Hospital has run a trial for the ALL, and the one trial is going for DLBCL. So this is not the hypothetical. This has already come into the practice, and next few years we will have a routine, like we are giving immunotherapy, the CAR T cell, where the questions for the solid tumor had this is started. So there were some inherited problem like leukemia or the lymphoma, where you have a specific antigen against you can form a specific CAR T cell. But this problem is with the solid tumors, where the tumor-specific antigens targeting a tumor-specific antigen, and the microenvironment, how to reach the CAR T cell into the particular tumor cell, that is a challenge. But still, there are trials ongoing, and these are the 2 trials in the RCC. So this is the LO316 trial, where the anti-CD17 allogenic CAR T cell has been used, and the 17 patients has been treated. This is a phase 2 data. And if you see the result, the overall response rate is 33%, and some patients are after a follow-up of around 20 months, the disease is still controlled. So, and patients who are having a 3 median line of therapy, so patient has progressed over 3 line of therapies, then receive the anti-CD70 allogenic CAR T cell, and this is going to be the next future of a therapy in medical oncology. And in the RCC, there are another trial, the Cobalt RCC trial, which has shown the disease control rate in the range of around 77%. So these are the very early results. But the things, the development in which are moving in this direction, I am pretty sure that this cell therapy will be a reality, like we are giving the immunotherapy in current era. So the CAR T has just entered into the era of the solid tumor. So this was the result for RCC. Similarly, the prostate cancer area. So the PSMA targeting the TGF beta sensitive armored T cell. This is a phase 1 trial. But if you see the result, 5 of the 13 patients developed the CRS, which I will just explain later on. And 98% out of this 98% patient has a reduction in the PSA. So that means this is a phase 1 trial. So it has already shown that the CAR T cell therapy is feasible in patients of multiply treated prostate cancer. And the data which is coming is really encouraging, and definitely we are going to see more and more number of trial in this era. So the only thing from the perspective of the CAR T cell therapy, the cytokine release syndrome and neurological toxicity, these are the 2 major challenges. But with the availability of a specific anti-IL-6 therapy, this number has significantly reduced. And I think in next 2 or 3 years, we will have a phase 3 data for a CAR T cell in solid tumors. This is the therapy which has already been approved, the gene therapy in solid tumor, particularly the bladder tumor, which has been discussed, the BCG refractory tumor. This is a very recent last year approval of FDA for this what we call as a nadofrigen fibrodinamic VNCG. It's a viral vector bond therapy for patients who are having BCG refractory disease and they does not want to go for so this was very recently approved, and the mechanism of action for this is that this is an adenovirus vector. With the genetic engineering, the reproductive sequence of that adenoviral vector has been cleaved and it has been inserted with the interferon alpha segment. Can I take 1 or 2 minutes more, because this is going to be so this particular segment which is having an interferon on this, and with this modified viral vector is then introduced into the bladder cells. With this is the diagrammatic representation of this, with the modified adenovirus, which has lost its potential for replication, and the same segment has been replaced by a interferon producing segment. And when this cell being introduced into the urothelium, the cells start secreting, And with the help of this interferon, ultimately we all know that when this interferon, the normal cell starts secreting, the more and more number of T cell will infiltrate and will the tumor cell. So this is not the theoretical, this has been already approved, and this was a randomized trial which has shown that the benefit of, so these are the two patient cohort, one is the CIS cohort and a high-grade T1 cohort, and patient have been of this who or of a BCG refractory disease, intravasically this nadopharyngeal fibroadenivec VNCG, this is, and if you see the result, this is the high-grade recurrence-free survival, high-grade recurrence-free survival in a CIS cohort and T1 and TA-T1 cohort. If you see up to the 1 year patient of our CIS cohort, 50% of around approximately 50% patient still have not recurrence. These are the patients who are a BCG refractory, and these are 60%. So this drug has got FDA approval and it is being used in the. This is the last slide for a CRISPR CA19 and CAS9. So this is the another going to be the next important development, what we call as a gene editing. So this is a relatively difficult concept to understand, but in this with the specific CRISPR and CS9, the desired segment of a gene which is being responsible for whatever this is mostly used full in a disease where the single gene is responsible. So this gene segment is cleaved, and this with the help of CRISPR Cas9 technology, and the desired segment is introduced with this. So what happens that this segment of a chromosome or the DNA where disease causing sequence is there, it is being cleaved and a normal segment inserted. So the phase 2 and 3 trial for the sickle cell anemia and transfusion dependent thalassemia, this has already shown positive data, and the FDA has also approved this CRISPR Ca9 technology in the management of a refractory sickle cell anemia and thalassemia, and this is just going to transform the management of a cancer cell in future. So these are the 3 technology: the CAR T cell, the adenoviral vector, and the CRISPR9 technology. And this CRISPR9 is the next blockbuster from the medical oncology perspective. We will identify. So the concept of a designer baby, the same is that you can want whatever gene you want to introduce, do this technology, remove the segment and introduce the segment of a DNA what you want. So these are the 3 development, and 2 has already been in the regular practice. Thank you.
Thank you so much, Dr. Amit Joshi. Now, to elaborate on optimizing MRCC risk scoring towards better outcomes, I invite Dr. Shilpa Gupta, who's the Director, Genito-Urinary Oncology, Clinical Professor of Medicine at Cleveland Clinic, Taussig Cancer Institute, USA. Over to you, ma'am. You've got 10 minutes for your talk, and then we have 5 minutes for discussion.
Thank you, everyone. Really glad to be here. So we'll talk about the MRCC risk scoring towards better outcomes. As you all know, the International Metastatic RCC Consortium, or IMDC, is very useful and has really evolved over the last 2 decades as the treatment options have evolved. And a patient's individual risk for progression and death can be estimated according to this prognostic tool. And classification into favorable, intermediate, and high-risk IMDC correlates with survival and is the basis of treatment selection as well as clinical trial design. These were the founders who put together these retrospective databases from different institutions back in 2009 and started the IMDC at that time when we only used to have Sutent and Pazopanib, drugs like that. And now it has really evolved. You can go onto this calculator online and put the patient's details like the performance status, time from diagnosis to treatment, hemoglobin, neutrophils, platelets, and calcium levels, and then it tells you whether it's good risk, intermediate, or high risk. And back in 2009, as you can see here, the patients who had 0 risk factors were the favorable risk, who had the best outcomes as expected, better than the intermediate and the poor ones. And then they did an external validation of this tool with over 1,000 patients who were not a part of the initial IMDC. And this was published back in 2013. And it again showed that the favorable risk patients lived much longer than the intermediate and poor risk, which is self-evident. And now in the era of immunotherapy, they wanted to validate this with today's therapies, because just TKIs is not the standard of care anymore. And this slide is courtesy of Dr. Heng, the founder of this, and they published this in European Urology this year. As you can see, the tool still holds good whether patients are getting Ipi-Nivo or any immunotherapy TKI or just VEGF therapy. So it's really holding true no matter what treatment patient is being offered in today's date. So what is the IMDC applicability in India? I did look up, if there's any retrospective data available from the Indian subcontinent, and I found that in this one tertiary care hospital in northern India, there were around, I think, 200, 300 patients. They looked at this IMDC score, and they also found that the poor risk do the worst. But the interesting thing here is that, as you can see, only 4% patients out of this were favorable. Majority were intermediate and poor. But if we look at the IMDC contemporary cohort, we see that favorable is much more and poor is only 31%. So that's why it's possible, that patients are getting diagnosed a little later here due to access or other issues, and by the time they come, they're already in the poor risk. But that tells you that this tool is also applicable in India. And there's multiple available options for frontline treatment for metastatic RCC. If you follow the ESMO guidelines, which I think in India, these are the guidelines people follow. So for favorable risk, you can use any of the immunotherapy TKI combination, except for avelumab, which didn't really show overall survival. But you can also use single agent TKI if there's affordability problem with the immunotherapy. For intermediate and poor risk, there's the options of nivolumab, ipilimumab, or any TKI and immunotherapy. Again, single agent TKI is not really recommended unless it's an access or cost issue. For patients who have sarcomatoid histology, we know that ipilimumab, nivolumab does better, but I think that is one of the drawbacks of the IMDC criteria, because it does not take histology into account. It was developed for clear cell RCC. So as per the ASCO guidelines 2023, this is the algorithm that one can follow, and I'm sure this is what people here are following. If patients are not candidates for surgery in their metastatic disease, you do risk stratification for frontline treatment. And if they have intermediate or poor risk disease, either offer them immunotherapy doublet or an immunotherapy TKI combination. If they have favorable risk disease, you can do a combination or just a TKI. And some of these patients can also just undergo surveillance if they have very small lung mets. But if they have favorable risk disease with a lot of comorbidities, then you can do a monotherapy or a combination, depending on what the comorbidities are and also taking cost into account. Actually, that's my last slide, so I gave back 5 minutes.
Yeah, Dr. Shilpa, just a question to you. From my own understanding, this you showed a slide of Heng where he says that IO still holds on in the IMDC, still holds on in the IO era. But my own understanding is that probably the 0 and 1 in the IO era behave similar in the similarly, but the 3 and 4 and 2 are different when you do IMDC risk criteria. I hope I'm clear. I used too many words. Okay, 0 and 1 look the same when you treat in the IO era, whereas the risk 2, 3, 4 look different. So probably the IMDC which Heng talks about doesn't hold true in the IO era, and there are publications from Israel which have looked at it, and other thing that it doesn't look at is the number of metastases.
Yeah.
0 to 1 metastasis or 1 to 2 metastasis are probably different from the rest, apart from the histology that you mentioned.
Yeah, you're right. I think it does not take into account the disease biology or the histology. So it obviously has limitations, but it has still helped develop a lot of trials. I think for non-clear cell histologies, we do need a different tool, and these are the kind of things that are easy to do because it's all, retrospective analysis and validation with different cohorts.
Thank you very much, ma'am, for covering that. What we always say, anybody presenting with de novo metastasis is in himself either intermediate or high risk. And all these ones, as you started off saying that these were all retrospective databases of people who had metastatic disease, and majority of the time they are recurrent metastatic. So patients underwent a radical nephrectomy some time ago and now presenting with metastasis. Because the moment somebody presents with de novo metastatic, you cannot have a favorable risk. That's the reason the only study that you quoted from India, favorable are 4%, wherein probably there were lymph node metastasis or something that was a resectable metastasis. That's why the time delay from diagnosis to systemic treatment was more than 1 year. I think somewhere along, for people like you who are at the forefront of this research, we have to differentiate between, like we do for prostate, de novo metastatic to recurrent metastatic. We can't just pull all of them into one and expect the same rules to be applicable.
Yeah, that's really a great point.
So the question of the cytoreductive nephrectomy, so how you tackle in your setup? So patient of intermediate or poor, at least of intermediate risk presenting, not much hematuria or asymptomatic for that. So for a TKI, the debate is practically settled down with the Carmina and the other trial. But what's your practice for in IO TKI era regarding the cytoreductive nephrectomy, upfront or delayed?
And I know the clinical trials are still going on, like the PROBE trial through cooperative group to address this. As a standard of care, we are not doing it unless, patient is very symptomatic and they've only seen the urologic oncologist. We try to put them on trials or just start systemic therapy. And then if, let's say, they've had a really tremendous response elsewhere, which is durable, then we talk about the nephrectomy.
Just another point, the cytoreductive nephrectomy, the evidence came from interleukin and interferon alpha. So do you think, compared to what we know, the Carmina trial wherein we are using a TKI, there would be more influence or less influence of cytoreductive? I know we can always say that we can await the trials, but I'm thinking that they would be better because the evidence for cytoreductive nephrectomy came from immunotherapy.
Yeah, I agree with that. I think the current trial that is ongoing, it's called the PROBE trial, that will really address this question in a systematic manner.
Thank you.
Thank you, Dr. Shilpa Gupta. And now the last session, which is a case-based discussion on the renal cell carcinoma, the India-specific scenarios. To moderate this session, I would like to call upon Dr. Aditya Pradhan, who's the Director, Uro-Oncology and Kidney Transplantation, Venkateshwar Hospital, Delhi. And as panelists, I call upon Dr. Narmada Gupta, who's a Professor Emeritus, Urology, Medanta Medicity, Delhi. Dr. Saurabh Bhargav, who's the Senior Consultant and Medical Director, Uro-Oncology, Mazumdar Shaw Cancer Center, Bangalore. Dr. Sridhar GK, who's a consultant uro-oncologist at Thangam Cancer Center, Namakai. Dr. Kaustav Talapatra, who's the Director, Radiation Oncology, Nanavati Max Super Speciality Hospital, Mumbai. Dr. Vinayak Makka, who's a consultant medical oncologist from Bangalore. Dr. Swapnil Rane, who's a professor and pathologist from Tata Memorial Hospital, Mumbai. Over to you, sir, for your discussion. You've got 40 minutes. Thank you.
At the outset, thank you organizers for giving us this opportunity. Last batsman of the day. Let's go down to the first case. You've seen some of this through these last 2 days. So a 70-year-old with a history of his brother having died of kidney cancer at age 62. He is presented with 4 months flank pain. Have a look. Can you see the video? Yeah. The GFR on the right kidney and the left kidney, 38 and 32. Right. So the diagnosis probably is obvious. Dr. Gupta, sir. Obviously, diagnosis is simple, sir. We are talking of a VHL patient. What is your plan? Patient focused.
The patient-focused plan will be to do the surgical management. And first we do a X-ray chest or CT chest if it has not been covered already, and to see that there are no metastatic disease or any involvement of any other organ in the body. Then surgery, I think so, is the treatment of choice. We start with one side and then we take not simultaneously, sequentially on the other side. And obviously the enucleation of the tumor has to be done.
Right. So we roughly went according to the same plan. I'm now focusing on the right kidney, which had a little better GFR. There was this kind of picture, a large solid mass, few cysts, big volume, one cyst lower part. I sat down with the radiologist and roughly this is what he showed me. Below this, nothing, above this, nothing. So we ended up doing a robotic right side heminephrectomy. This is what came out. RCC, grade 2, margins clear. Now, after a few months, actually precisely 6 months, we started looking at this, the left kidney. Sridhar, how would you plan this side now? You have already done right. There is 50% function on that side. You have 32 GFR here. Multiple locations, multiple cysts are there. So when you are taking up this patient, can you answer these questions? Like, would you go open? Or in your center, you would straight away say, no, this is lap or robotic. And when you actually do it, you're going to clamp it and then go over 35, 40, 50 minutes ischemia time and then take out all of it, or unclamp at some time and then go for the next. How do you work it out?
So this patient is a VHL patient.
Yeah.
So he's gonna get tumors again in his lifetime. So my prime idea is to preserve as much renal parenchyma as possible, at the same time to keep the warm ischemia to the minimum. So for this patient, I will prefer a open partial nephrectomy.
Okay.
I will try to enucleate the tumors without clamping. Whenever there is
without clamping?
Yeah,
okay.
I will try to enucleate. Whichever is possible, I will take as much as possible. In case if I need to clamp, I will clamp, cool the kidney, take out the tumors which are completely endophytic. All those areas alone, I will try to clamp. The rest of the thing, I will try to enucleate without clamping.
Okay. So this is what I found actually. We have gone robotically, but you see this landscape. Multiple cysts are there. Some areas solid, some are completely endophytic solid tumors. So this is the kind of picture that you get in, when you've dealt with VHL. Any inputs you would like to give having seen this now? So the point we're trying to say is manifold. It may not be feasible to take out everything at one go. It may not be necessary also. So let's take some more questions on this. Swapnil, about the cysts. How particular would you be regarding every cyst to be removed? Because when you looked at the CT, there was not evidence of high grade, a type 4 cyst in all. One area, yes, there seems to be a type 4. The rest seem to be type 1 or 2. So is there any truth in this, that cysts may progress to malignancy? Would you like to comment on the underlying RCC pathology that you would find here, and some brief comments about genetic markers if you would like to suggest to the patient?
So not every cyst is going to progress to malignancy, and of course the complexity of the cyst that we see would be more important. What as a pathologist, what we look at usually is we'd like to look at the cyst walls. If the cyst walls are quite thick, then that is something that we sample very extensively, and we try to look for any clear cells in those particular areas.
Okay.
The commonest pathology would obviously see is a clear cell in this particular scenario. There is, apart from VHL, the CA9 that we commonly use as a marker pointing towards the VHL gene being affected or the hypoxia pathway being affected. I am not aware of any other genetic markers in this particular area.
Right. Kaustav, I have a scenario where I have done this patient. I have not really been able to get out everything. I didn't make a very serious attempt to take out 2 large endophytic masses which remained there. What would you suggest to the patient? He has some residual disease there which I have probably not removed. The patient comes to you. Anything you can offer him?
So SBRT is emerging evidence.
if the size is less than 7 centimeter. Actually, the evidence is primarily for primary tumors, medically inoperable, but if there's a residual, there is some level 2 evidence of SBRT. If the lesion is less than 7 centimeters or typically ideally less than 5 centimeters, SBRT is emerging as an effective option with a local control rates of 90% and 1-year survival of to the tune of 67 to 70%.
Right, right. So Vinayak, this patient, what are your views on the adjuvant therapy?
Usually...
So we have some residue and we have a potential for recurrence.
See, the only thing is been their data is their non-surgical management beltazufan.
Yeah.
Otherwise nothing specific which is not there for RCC.
Yeah, absolutely. I would just like to reiterate, the belzutifan has been now recommended for this, and probably it's going to be used in some other settings of RCC also. But yes, belzutifan has got now good evidence for being useful in a VHL disease patient. Well, this patient has done about a little less than 2 years. He has now been offered PAZO as an adjuvant, and he has done pretty well. So the point we're trying to make is that in VHL, it's not really necessary to achieve the tri or pentafactor, which we would not always use. You can manage them less aggressively, watch the tumors, and then put them on suitable adjuvant, consider SBRT, and you would have fairly good follow-up. Yes, eventually most will land up with bilateral nephrectomy and replacement, yes. So I'll skip all this and come down to this. So here is our second case. This is a female this time, who's being evaluated for fever with a low hemoglobin. The ultrasound is not very helpful, but shows a very poorly defined 6 centimeter by 8 centimeter mass somewhere in the middle of the kidney, and then this is the CT scan. Right, so 9 centimeter mass with solid component more than the rest of the necrotic areas in the middle, and fairly big on the left side, right kidney normal. This patient has had an FDG PET, and FDG PET, in addition to what we saw there, shows this. A possibility that the L4 body is involved, and there may be a little bit of ingression into the psoas. So if you stratify them, this is intermediate risk. I'd like both of you, Vinayak and Saurabh, this is your patient. Let's start with Vinayak. This kind of patient, what do you suggest in these terms?
If it's only solitary, I would do another imaging for especially bone. No, we do another MRI before we go ahead.
Okay.
Otherwise, if it is there is 2 lesions are there, the soft tissue as well as bone, we would take it as a metastatic disease.
Yeah.
And see if the burden is less, systemic burden is less. They may maybe offer the surgery.
Okay, so you would consider doing?
Take an opinion at least.
Take an opinion, yeah. Saurabh?
I think this lady is going to be symptomatic. You know, she's dropped the hemoglobin. She's not going to get better unless you take that kidney out first.
Okay.
So that's what I would offer her, and then obviously send her off to somebody who's brighter and they can give something more beyond that.
Okay, so we have a doubtful one single site metastasis, symptomatic patient. On the strength of that, we would probably decide to go ahead and do a nephrectomy and then see what next, right? Okay, so this is what happened. We did a left nephrectomy. The HPE findings show a clear cell with a rhabdoid features being present, and there is no sarcomatoid component, grade 4, let me just say, with clear margins. So this is grade 4 isubgrading, where 1 to 4 isubgrading, where if you have sarcomatoid or rhabdoid differentiation, this is grade 4 disease. Now, I'd like to ask the pathologist, sir. You have a patient where this is the path report. How much of rhabdoid or how much of sarcomatoid, is that important? Are rhabdoid and sarcomatoid the same because they have been clubbed as grade 4 together? And prognostically, is there any real difference that I as a oncologist need to be aware of?
So philosophically, conceptually, rhabdoid is a type of sarcomatoid. Essentially, it is coming that this is more of a rhabdomyosarcomatous differentiation. Just that now I do not have yet the characteristic sarcomatoid component. But the fact that they are grouped together because they have very similar prognosis. This is a more recent addition that the rhabdoid is being identified separately. And therefore, there is a possibility that over time we might separate it out further as we come to know more. We don't see very frequently rhabdoid differentiation as without a sarcomatoid area.
Right.
Commonly they coexist.
Okay.
So a pure rhabdoid without a sarcomatoid is extremely uncommon. If we have to say that this is some variant of it, or we consider usually at least 10% of the tumor area should be showing this component. Otherwise, we mention in that, okay, there is a small component of this particular area. If we usually see such a thing, we will go back and sample more and to see if there is some area which has more of these high-grade histologies. So this is a usual approach to the thing, that we try and find as many such areas as possible.
Okay. And you would say that the prognosis is the same?
At this point of time, it is considered similar.
Okay. So, in fact, Vinayak, let me ask you, this is the patient. The report has mentioned the rhabdoid component being present. We don't have a quantification of the rhabdoid, but we are aware that there's a significant proportion of rhabdoid there. Your comments on this patient, in this patient has come to you for your advice on adjuvant therapy. Or if you consider that LV4 body, then it's metastatic. What would you give, or how would you treat this patient?
So actually, the both ways IO will be there.
Okay.
Adjuvant will give IO only alone pembrolizumab. If it is metastasis, it will be combo. So, but there are two components of that bone lesion. So, if that we assume it as a metastasis, would offer.
Okay, okay, and
it will be favorable most.
So we actually did pembro. She was planned for 17 doses, but we ended up actually only giving her 3 because in less than 2 months she had accentuated her symptoms. While on pembro, there was more backache and she started developing lower limb symptoms. Weakness started coming up. Further evaluated by an MRI, D12 body involved. Had to undertake laminatory decompression and that settled the matter, and yes, there was mets to the D12 body. Now, I'll just skip that, and I'll just say this is the current data today which we have, which actually says that this differentiation, you need to pay attention to this, that the sarcomatoid and rhabdoid which we have clubbed together, they are not similar. In fact, the sarcomatoid has probably a worse prognosis. It is more than the rhabdoid. And in these patients, you need to intensify your therapy. And probably today, amongst all the IO-IO combinations, Nivo-IP seems to be the best. So, by next cases, I need to thank Sanjay Sureka, if he's still here, for these cases. So, Sanjay, yeah, thank you very much. The 45-year-old on hypertension of a single drug, he is presented with 6 months of intermittent hematuria. And these are the MRI images of that patient, as you can see, right? So further, very nice images provided by Sanjay. Right? Sridhar, in any evaluation of such a patient, obviously what I need as a surgeon to know is the cephalad extent of that thrombus in that IVC. Is the IVC wall actually been tumor infiltrated, and is there presence of bland thrombus, right? This is what I need. Now, what is your choice today with all the improved imaging which is available at your center? What do you use? Would you prefer CT? You still prefer an MRI? Would you add a Doppler to your workup, or would you say that whatever is available, I'm not really worried because I have the availability of transesophageal echo, which I shall utilize intraop?
I will consider well-done CT is better than an MRI in this scenario. If CT doesn't give adequate information, then I might consider doing an MRI subsequently. And during the surgery, if the facility of transesophageal echo is there, I will utilize it.
In fact, Dr. Gupta, sir, would you agree that probably it's mandatory that you should have transesophageal echo while you're taking this case up for surgery? Would you agree, or
it is not mandatory?
Okay.
But we have in All India Institute of Medical Science, we have a collaboration with our cardiothoracic team actually. If there is extension of the thrombus into the atrium, there we are taking their help and we operate in their operation theater. They have a facility of transesophageal ultrasound monitoring, and this has been used actually in 1 or 2 cases which I distinctly remember. So definitely, if it is not necessary, you should have it, but if it is available, then it is good. The other point I want to highlight about this IVC wall infiltration. I think so this is very important factor to know beforehand. If so, then you have to involve your cardiovascular team and you have to be ready for the IVC graft or something like that, you know.
Right. So my point I'm trying to ask all of you, and any might take it, when you have a high level 2 tending to 3 thrombus, is your cardiac team always alerted? You prepare for bypass, you prepare for grafts. Any one of you could, the uro-oncologist.
When we do this, so we operate as a team of 4. So me as a urologist, we've got a vascular surgeon, we have the cardiac surgeons and the liver transplant guys. So all 4 of us do this together because this is an extremely complex thing, and you got to have you got to have everything on board. So we'll all operate together all the time.
Right. So traditionally we have been taught that the MRI is the best because you don't need contrast. And more so, when you're doing a CT scan, the dye can't reach above that thrombus. So the cephalad extent is not very good, and it's, the MRI therefore scores better. But one specific area where MRI scores is wall infiltration. If your radiologist has been able to focus on that, he may be preoperatively denoting some areas where there is possible tumor infiltration, and that's where MRI scores. But today, like you mentioned, we've got good CT. And CT with a Doppler probably is the best you can get in terms of real-time information. Dr. Gupta, sir, your opinion today on this highly disputed topic, would you consider pre-op embolization?
The type of case which you have shown here.
Yes, sir.
And if there is a complete thrombus and you can also see the collaterals all around the kidney, then there is a role of pre-operative embolization.
Right.
And we like to do it on the previous evening or on the morning of the surgery, and then we take up these cases.
What about any role for neoadjuvant therapy here, TKI-IO therapy? Dr. Vinay?
Unless there is other meds, I would not prefer it.
So many of us have felt that if you have a high thrombus, you've given him 2 or 3 months of therapy, but you might be able to reduce the size. Have you used it? Any information on that?
I've done TK for most of times, but not done with IO, but it is not rewarding.
You used TKI as a neoadjuvant in these kind of settings.
The surgeons was not keen to operate and send to me.
Okay.
I don't think it's possible.
I think most of us have not been utilizing that.
Yeah. So the issue with the TKI is, we very well know when we give a TKI, 30% respond, 30% will have stable disease and 30% progresses.
Right.
So when we extrapolate the same thing to this IVC thrombus, we are at the risk of 30% patient who had a level 3 thrombus progressing to level 4. So I won't consider TKI in this situation.
Right.
We don't have any evidence with the IO that has.
See, the problem is where I'm telling is there's metastatic disease elsewhere, and this being a cytoreductive surgery, if this is a thing, we intervene. Otherwise, if it is clear-cut, localized disease would not occur.
We will not have, right. So there is some data actually talking about pre-operatively embolizing. It has the benefit of lesser blood loss. Some experienced centers have said that you reduce your operative time, it has become technically easier to operate it. And yes, if you have a large bulky thrombus and it's difficult to get to the artery first, you feel very comfortable to go and ligate the vein, and it eases the operation. So there are some benefits of doing a pre-op embolization. Now, fundamentally, our main fear when we are dealing with this, apart from everything else, is the risk of having a thromboembolus. And some of us may have experienced it when we have dealt with these large thrombi. So, Saurabh, if you have a patient like this in your theater, would you, if at all ever, consider, don't touch the kidney, why not just tackle the problem of the thrombus first? And we'll get that thrombus out, settle the IVC, and then at a leisurely place we can get that kidney out. Right? The other question I'd like to ask you is that we've been taught always that if you tackle the vein first, you might have the inflow of the artery causing a lot of renal expansion, and then it'll be problematic. It bleeds all over. And the last question I'd like to ask you is, do you do en bloc at one time, just circle the whole pedicle and then just fire a stapler and get done with it? So have you used or have you done this, or you feel it's not helpful?
So, I mean, looking at this particular case, getting your stapler around a vein which is full of tumor, I think that's a wrong thing to do probably. I've never done it. I don't think I'll do it. I always go for the artery first, and that's just, partly.
The point is that you can't sometimes, when there's a bulky thrombus there in the vein, you can't very easily reach, especially if the IVC is also expanded out there. And in addition, sometimes you may have a lot of hilar nodes. So it's not always easy to get down to the artery. And that's the situation. How are you going to deal with that?
True. I think that's why these things you do it with all your resources. And your resources are your manpower. So you have your vascular surgeon with you, you have your liver surgeon with you. Right. And therefore it is easy to deal with it. I think one of the problems with dealing with the thrombus first is that very early on in the operation, if you dislodge it, it will go straight into the, big
Actually,
vessels.
the other way around. If you're trying to prevent this thrombus embolism, you would not like your assistant to have any manipulation around the kidney, minimal manipulation. That's what you tell your resident assisting across the table. So that's how this whole, approach business came up. And there is now data, in fact, this is what I'm quoting is from a large series out of Japan. And when they worked this way with large thrombi present in the IVC, they found that a thrombus first approach is quite helpful. You actually have less risk of that embolus happening. The surgery was faster, and there was significant blood loss with the overall complications actually going down. So we need to see in these situations what should be the attack approach. Kidney first, thrombus first. We should think about that. Dr. Gupta, sir.
No, about this renal artery ligation has to be done first. And what we do is normally we start our dissection from the aorta. From there we try to find out the renal artery. At that level, it will be much easier to find out the artery. Whether it is open laparoscopy, I don't know, but robotic we have seen, we have done in Vedanta also, and we have gone to the artery first. Now regarding the thrombus first, I think so Inderveer Gill has described his technique robotically, and he has shown that it is better to do the thrombus first. The secret to this is that you have to take care of all the vascular control below the vena cava, below the thrombus in the vena cava, above the thrombus, and on laterally on the other side of the renal vein. And when you have all these controls available, then you can go for the thrombus first, including the lumbar veins also,
Yes, sir. In fact, it is sometimes very tricky. What are collaterals which are essential, which you need to preserve, and what is going to, if you don't ligate, cause a lot of bleeding. So these are sometimes have to be decided on the table itself. Now, there is data of what I just spoke. Our fear about en-bloc pedicle control was that you might actually create a fistula in the long term. But there are many series, and I've just quoted one of them here, that if you do an en-bloc pedicle ligation or just staple it off, you are actually quite safe. You won't have a very difficult dissection there too. You can avoid all those problems. So we could think of a stapler to en-bloc tackle the pedicle. Yes, it depends on how thick is that pedicle. Are you able to get space above and below, and will you be able to clamp that entire thing at one go? So these are considerations which have to be individualized. Now, my next case is another one from Sanjay Sureka's unit. And here, this time, they've chosen to do CT. And as you can see now, in fact, you get as good, if not better, images. And here is the thrombus, which is just below the confluence. In fact, he's got about a 4 centimeter clearance from that point. Dr. Gupta, sir, specific to this now, I'd like to use these questions in this patient.
Can you go back and tell me the level of thrombus?
So, yes, it is below the hepatic vein confluence. We've got about 4 centimeters there.
Below the hepatic vein?
Yes, it's below the hepatic vein confluence. So you have this patient, large right-sided involvement, big thrombus, but you are spared level 3. Now, when do you consider looking at veno-venous bypass? Is this on table? Do you pre-op plan, as you were mentioning earlier? Now, suppose, in fact, this was a CT done 3 months prior to your surgery, and then you go in and you find there's infiltration. The hepatic vein has got infiltrated. It has gone up a little bit. How are you going to deal with that point? So the next 3, of course, I will also like you to address if you may. Now, you find that the IVC wall has tumor adherence, so this is involvement. There is a distal IVC thrombus which is there, which is a bland thrombus. How are you going to do all this, sir?
I will reverse the order to say that
yes.
Replacement of IVC filter. I think so this is becoming a normal practice nowadays.
Okay.
That we should put a IVC filter to prevent the thrombus migration. The distal IVC transaction,
So
yes.
if I may just stop you for 1 second. IVC filter thrombus, if there's a thrombus and you want to place that filter, how high would you be able to put that filter? Because if it is something which is covering the IVC and there is very little space between the upper level of that bland thrombus and the renal vein takeoff, the interventionist would not be probably very happy to put a thrombus, a filter at that level. So what kind of guideline do you go that, yes, at this level of thrombus, I need that filter?
At this level of thrombus, I think so, no. You can put a filter at a higher level in the superior vena cava also.
The guideline actually has been now established by the Mayo Clinic. They have a large series on this. If you have thrombus which is limited to the pelvic veins, you might be able to get your filter up and it helps. But when it is gone into the IVC, whether it is just below the renal vein confluence or even a centimeter or 2 centimeters above the IVC bifurcation, it's far better to transect it rather than try a placement of a filter. It's not easy to put and then it actually doesn't help you much.
Can I say something? Yeah, Jagdish.
Sir.
I'll tell you this, we used to do this putting the filter, but today the cardiac people say that there is no place for filter at all. Absolutely there is no place for filter.
So here is what the guidelines out of Mayo, sir. This is what I was alluding to a short while back. So if you have space above the thrombus, which is clear, and there is some channel available, you can put a filter across. But anything more than that, like what we see here, it is safer to transect and ligate the IVC below that. The level of collateralization is very safe, and the risk of subsequently developing P in this patient is much lower if you simply transect that vein. I think this is something we need to be aware of. We need to follow it more carefully to avoid the complications postoperatively to this patient. Right. I have just 10 minutes, right. So I'll just wind up with this last case, which is a little bit of a diagnostic dilemma. So this is a 52-year-old male. He came with right flank pain long time ago, and he was actually diagnosed as PUJ obstruction. You might wonder what am I talking about in this forum. Okay, so the guy in PUJ obstruction has been managed conservatively by his urologist, and he's found status quo for a number of years. So these are all his documents attesting to that this was stable renal function, so no surgery for that PUJ was done. Then, in about 10 years' time of follow-up, he now develops gross hematuria. There are no clots, cytology is negative, ultrasound CT is done. I'll leave this on for you to just see, and that's all that there is, nothing. The kidney is functioning okay, there is a little delayed excretion. Now, look at this. So, right. So the upper calyx, like Dr. Kulkarni pointed out, was distended, and there is a PUJ obstruction. So urologist has gone and done an RGP. He finds that the PCS is dilated on that side. The upper calyx is not seen, contrast is draining, but he doesn't find any source of bleeding with whatever he has done, and he goes and puts a stent. And then plans that I will do an endopylotomy for that PUJ obstruction. So this patient is not very convinced of what is happening. He comes to us for a second opinion. Saurabh, your patient, what would you think about?
Well, obviously, you're missing out on something here.
Yeah.
The first thing is, make sure, I'm sure my colleague, whoever has put a stent, has examined his bladder properly, because that's the easiest and, the source where you can miss it. Subsequent to that, I couldn't see very well on that CT image, but definitely the upper pole of there is something wrong there. I'm not sure. There's definitely cut off there. The collecting system seems to be a bit abnormal. So one of the the calyces looks abnormal there. So at the same, I would put a flexible ureteroscope and have a look and see what it looks like.
Okay, so that's exactly what happened. We went in with RIRS. It was difficult to see the PCS. There was active hematuria. We could see only the infundibular region of the upper calyx, and that I biopsied. Histopath, round cell. This is the actual report. Yes, on that small bit, no IHC was possible. But they asked for it. So I asked them, now what? So my point is, Sridhar, incomplete information, that is the evidence that we have. One biopsy, round cell tumor. Upper calyx, there's something which we cannot explain.
So round cell neoplasm, I'll consider doing a PET.
You want to do a PET? Okay.
There could be any meds.
Right. And you want me to go again because my pathologist said go and do an RIRS again. I hesitated because I know the effort I have made to take that little bit, though like in all upper tract biopsies, it was not very helpful.
I'll try needle guide biopsy.
Okay. You will try a repeat needle biopsy?
Yes.
Needle biopsy, okay. So we did that PET and well, it didn't help much, all right? So briefly what we had was this. 10 years, now upper calyx is dilated and RIRS not very helpful. I had a long talk with the patient and we decided that we treat it as upper tract TCC, all right? That round cell business, that pathologist which had given me, I actually disregarded it at that time. And I told him that we'll go for a nephro-U, I'll open the kidney, have a look at it, and if required, I'll do a completion uretrectomy, and this is what was the plan, right? This is what came out. Sir? Yeah, okay. Now? Doesn't look like something we have seen very commonly. Something is amiss. Swapnil, what would you say? Just guesses basically, obviously, because this is not something we are very commonly seeing.
So there is a central scar to that, some scar and necrotic areas. It's not very clear as of
something
now.
there, yes.
So round cell area is only two diagnoses, Ewing sarcoma or it is lymphoma, it's either of them, or osteosarcoma of the small cell.
Absolutely. Anything else? Swapnil?
Not particularly. We'd like to sit look at the slide.
So this is what I got actually. You are absolutely right, and credits to your judgment. This came out to be PNET. So it was strange. I never expected it. This was a 52-year-old gentleman, PNET. So obviously then the rest of the workup moved towards doing the extra renal side. So we had a biopsy done for the bone marrow. It was negative. This is the Swapnil, would you like to actually just comment on these? These were the HNE and then the CD99 other markers. Would you like to comment on these? Or
So the PNET is the commonest round cell tumor of an adult kidney.
Oh, okay.
So among the round cell tumors, this is the commonest thing that happens. The closest differentials over here, we obviously rule out a lot of the other round cell tumors.
Okay.
Commonly RMS, we commonly rule out synovial sarcoma also, which sometimes can look similar to that.
Okay.
But PNET is quite a bit, there is no specific IHC for it. MYC2 positivity, NKX 2.2 positivity, yes. But there are many other round cell tumors can give similar conditions.
Right.
So EWS-R1 gene rearrangement is usually very confirmative that this is yes indeed a PNET.
Right.
But having said that, 90-95% of these will turn out to be PNET. So based on morphology alone, a PNET or even with a MIC2 which is confirmed to be there, it is good enough in most scenarios. You don't often go into the next steps.
Okay. Vinayak, this patient now, what next? So we have a histologically confirmed PNET. How do I manage him?
So the Ewing, this is like almost like Ewing sarcoma. The main treatment is systemic therapy. So we usually give 17 cycles of chemotherapy alternating IE plus VAC. That's a treatment. And one modality of local therapy is done, so that should be good enough. Otherwise, usually we complement with radiation, especially if its margin is positive or something, or necrosis is not there. Otherwise, usually one modality is good enough.
So we have used actually what you suggested, 5 drugs. He received almost a year of adjuvant therapy.
Now we do every 2 weeks.
Okay.
It's not 1 year exactly.
Yeah.
17 cycles still we do.
Still do.
But it's every 2 weeks.
And then we also gave him some adjuvant RT to the
especially if it is violated,
renal
planes
fossa.
are violated. If
Right.
the excision time, if you violate the planes, you have to do. Otherwise, margin is clean and everything, you can skip the radiation.
Dr. Gupta sir, your comments, if any, on that?
I think so. You have to go back to that CT scan.
Okay.
I don't know how the radiologists have based that. If there was any, I had a doubt from the first time when I saw your CT scan. There's something is there in the upper pole.
Yeah.
And how, if suppose, see that solid area is also seen.
Yes.
That is cut off in the superior calyx actually.
Yes, sir, yes.
And that you see the upper one, that is the white area, which is the solid area.
Yes.
So I think so that was confused as a dilated calyx.
Correct.
But that I'm sure a good ultrasound will also tell it's a solid mass there, not a cystic or calyx, dilated calyx.
So
at that time, suspicion should have come that we are dealing with a renal tumor.
You're right, sir. So one was the imaging dilemma. The second was the round cell report by the pathologist. Unfortunately, when you're doing a biopsy at the upper tract, it's not possible to give good amount of tissue and then for them to comment on a definitive biopsy. So these
No. The question is again, the pathologist will only tell you what you give him the tissue. And
Agreed.
sometimes like in needle biopsy, the histopathology cannot be accurate. That's
Right.
why even in that cup biopsy you must have taken, or the person who has done that RIRS or endopallotomy.
Right.
So he has given a very small tissue.
Yeah.
So, and he already mentioned that round cell tumor can be a PNET, So like that.
Yeah, so these are rare occurrences. Maybe some of our senior colleagues here have seen much more than we. Yes.
We haven't. We have seen fair bit of Ewings in renal this thing.
Right.
Imaging is quite typical. It doesn't enhance much, and because of the atypical, they are also seen in very young people.
Right.
Usually. So because of those two things, not very enhancing and a young age, we have biopsied them before. And once you get the biopsy, on a renal biopsy, you can do all your markers and you can prove Ewings, and then you would have given the chemo before, because it quite well responds. And when we post chemo, we have gone and removed them. It all shows necrosis. So you are very happy that you had given the chemo
I agree.
before.
I agree. Santosh, your point is valid because these are patients where the non-enhancement, the younger age, a biopsy, all that helps you. What was a little untypical or atypical in my patient is this guy is presented at age 52. So this is not something that comes to your mind right off. So this was the point of bringing out a little rare case. I'll just switch all this to the last case, if I may. I have about a minute, so straightforward diagnosis. Any one of our urologists can take this. Yeah, right? One, and this. Sridhar, what would you tell me? The diagnosis, forget it. We all know it's an AML. So what are you going to do with this, Ra?
Can I just go back to image, sir?
Yeah. Sure.
Huge AML. Okay.
Yeah, okay. Somebody just mentioned partial, okay. This bigger tumor, you want to do partial, all right. Anyone else? Any other opinion? Gupta, sir? What would you tell us, sir?
No, I will discuss with the patient. If it is a more than 4 centimeter size,
So
definitely
this
needs a
was in
treatment.
the region of 15 centimeters.
So it needs a definite treatment.
Okay.
And if feasible, a partial nephrectomy should be the treatment of choice.
Right.
We have also removed much more bigger angiomyolipoma than this, and we have been able to do partial nephrectomy actually.
Yeah.
And if they shell out very easily, you know,
Absolutely,
it's
sir.
not that difficult.
Absolutely. So this is what I was trying to show us here, that you counsel the patient, I may need to take out that entire kidney. Angioembolization, this patient was subjected to 4 sessions of angioembolization. It didn't help. The reason was there were multiple feeders. They were not able to take out each feeder and still preserve the kidney. They were not very confident of it. We stopped after the 4th attempt. And Vinayak, any TKI therapy here? Oh, okay. So straight away go in and remove it.
Usually are mTOR pathways, so our TKS will not work.
Do not work. Okay, fine. So this is actually what Dr. Gupta just mentioned. That big thing actually had this pedicle. So it was actually possible to salvage the whole thing virtually. So just a little bit at the lower, the upper pole was gone, and this was that whole specimen. So you thought that it would be difficult. It actually turned out to be easy. But yeah, a minute more. This patient, this was the AML. Now what would you do?
So your minutes are becoming longer.
Is it? Okay, I then will just say that you thought the same options, and this is what it ended up. I had no plane of dissection between that tumor and the renal vein. There were multiple holes. We had a lot of bleeding, and that kidney was left in my hand. Sinus, not easy. Thank you very much.
Thank you.
Thank you, Dr. Aditya Pradhan, and I also thank all the panelists for their excellent conduction of this discussion. I would now like to call upon Dr. Ganesh Bakshi and Dr. Vedant Murthy onto the stage.
Thank you, everybody, for being there on the Sunday and participating actively in this conference. Thank you so much. The lunch is on, actually, and everybody can go on. Thank you so much, everybody.
Thank you, everyone. So we come to the end of this.
We look forward to you all participating in the Society of Genito-Urinary